So good afternoon and welcome to bill hearings to the House Health and Government Operations Committee. I'm your chairman, Jocelyn Peña-Melnick, joined by my vice chair to the left, Delegate Bonnie Collison. I kindly ask for your patience. If we encounter any technical or streaming issues, I'm going to go through some of the rules in this committee so you know what to expect. And I'm going to start with this. Please set your electronic devices to vibrate. Sometimes mine rings and I embarrass myself. Don't you do that? Hint, hint, someone to the left, just kidding. As a reminder, there's no food or drink allowed in the gallery because staff has to clean it and it's not right. That's not their job. You'll see us drinking. I have a challenge here from my staff that says goal for every day, finish this glass of water before the hearings end. And I never get to it, but I will try my best today. We need to stay hydrated, so you'll see us drinking. You'll see that the members will get up. They have bill hearings in other committees, but they will come back as well. For each bill in this committee, I decided not to time the bill sponsor. I know other committees do it as well. But please don't abuse it because I don't want to have to tell you to stop. The rest of the witnesses will have 2 minutes to provide their testimony. A timer is displayed on the screen and a sound will play when your time has expired. If it has expired and you hear the timer, just wrap up your thoughts. Please adhere to our wonderful committee, and I do have an amazing committee. I'm very blessed. To the rule of 1 question and 1 answer, and please keep your questions brief. If you ask too many questions, you're going to end up having to buy dinner for the committee, okay? And those are good. The chicken fillet was great, whoever, Delegate Gazzoni, and the cookies being provided by Delegate Shilega's grandchildren are delicious. Did you get, by the way, the citations for them? All right, great. Members of the public, you'll be able to view the live stream of this hearing on the Maryland General Assembly website and YouTube. Today, we will hear the bill hearings in the following order, but I am going to start by saying that I may need to change it. The speaker will be here today testifying. She does have a bill hearing in judiciary right now where she's testifying, but as soon as I hear her come in, I'm going to call the bills because she's in many places at once, if you can picture that, and that is tough, but she does it with grace and well. So this is the order. We have House Bill 965, and that's Delegate Queen. Will you be so kind and come up right now with your panel as I call the rest of them? And I believe, Delegate Queen, your panel is Dr. Nailesh, and that's basically it, you and him. And then we have House Bill 969, which is Delegate Bartlett, House Bill 739, Delegate Vogel, House Bill 1229, Delegate Jones and myself, House Bill Speaker Jones and myself, House Bill 1230, Speaker Jones and myself, House Bill 804, Delegate Gramer, House Bill 784, Delegate Bandari, House Bill 1143, Delegate Bandari, House Bill 829, Delegate Olstent, House Bill 1019, Delegate Olstent, House Bill 933, Delegate Fellmark, and the last bill of the day, House Bill 980, Delegate Rosenberg. Delegate Queen, welcome to our committee. How are you?
Fine, thank you so much. Well, good afternoon, Chair Jocelyn Peña-Melnick, Vice Chair Bonnie Collison, and the wonderful members of the Health and Government Operations Committee. How are you? I'm Delegate Pam Queen, and I seek a favorable recommendation for HB 965, Maryland Department of Health Breast Cancer Program Eligibility and Public Awareness Campaign. So what is the problem we're trying to address? According to the Maryland State Department of Health's Environmental Public Health Tracking, breast cancer is the second leading cause of cancer-related deaths for females in Maryland after lung cancer. Unfortunately, nationally and in Maryland, there are significant racial disparities between Black women and white women for breast cancer mortality, with Black women diagnosed more often at later stages. Furthermore, according to the CDC, Nearly 1 in 11 women who are diagnosed with breast cancer is younger than the age of 45 years old. HB 965 seeks to save lives via early detection of breast cancer by expanding the Maryland Department of Health's breast cancer program to enable women under the age of 45 who are considered high risk for breast cancer diagnosis based on the CDC guidelines, and giving some prevalence to differences among races. And by developing and implementing a public awareness campaign to encourage eligible individuals to participate in the department's breast cancer program. So we know that preventive health care measures have a cost, and the cost you see in the fiscal note actually will be much less based on some of the amendments we've talked with the Department of Health about. But, you know, I want you to consider the individual and societal costs of late diagnosis, resulting in possibly premature death, or for late diagnosed persons like myself, who was under 50, who endured 8 treatments of cycles of what we call dense dose cocktail chemotherapy. And what that means is 8 doses is on the high side for chemotherapy treatments. Dense dose means that there was a short time between the treatment, 1 week on for me, 1 week off, then 1 week on, 1 week off. And the cocktail means that there were multiple drugs administered at one time. So for 4 cycles, we had 2 drugs, and then we switched up for another 2 drugs for the next 4 cycles. I had a radical mastectomy. What does that mean? The removal of the full breast, lymph nodes under the arm, as well as some of the muscles in the chest cavity. I had 33 radiation treatments, 5 a day for almost 7 weeks. Breast reconstruction surgery, which all was paid for by insurance, except for the nipple, which they call cosmetic surgery. And over 5 years of post-cancer medication. All of that because I wasn't given a 3D mammography when I asked. So breast early detection saves lives. And so I'm seeking a favorable recommendation on 965. And again, we've talked to the health department on how to make the language more broader and consistent with CDC guidelines to make sure that we do address some of the disparities that we have in our communities and target changes for that. And we talked about a statewide program on awareness, and I know that the State Department wants that to be local, but I think we can come to some agreement on how to address that. So again, we'll turn it over to my other panelists. Thank you.
And I want to say thank you, Delegate, and thank you for sharing your experience. I'm so glad you're doing well, and you know, and it matters. Your experience here in this committee matters. So thank you. And before we go to your next panel, I apologize. I was supposed to do this at the beginning. Delegate Y. Holland, you have some special guests here. Can you introduce them quickly?
Yes, and it's certainly right on time, as Delegate Pam Queen is also a member along with me, and Delegate Terry Hill, a member of Alpha Kappa Alpha Sorority Incorporated. And it is a pleasure to have our sorors here visiting with us who have just entered, but also seated here watching Democracy in Action. So thank you all for being here, and welcome to Annapolis.
Welcome. And if I may, there's some seats in the front, some in the middle. Please just feel free to come and have a seat. And Delegate, again, thank you so much for sharing your experience.
Thank you.
You're welcome. Next, please, and welcome.
Thank you. So good afternoon, Chair Peña-Melnick, Vice Chair Colson, and members of the Health and Government Operations Committee. For the record, I'm Dr. Nilesh Kalyanaraman, the Deputy Secretary for Public Health at the Maryland Department of Health. And I'm happy to be here on behalf of the department to support House Bill 965 with Delegate Queen, with some of the amendments that she discussed that we have been discussing. I want to echo the importance of this effort for breast cancer screening. About 9% of all new breast cancer cases in the United States are found in women younger than 45 years of age. And we see our clinical guidelines changing and evolving to address this reality. I think another piece that's really important here is that we see nationally and in Maryland that Black women are still more likely to die from breast cancer than white women, even though Black women have a lower breast cancer incidence rate. And so it really points us towards how we can improve our breast cancer screening activities. And I think this bill will push us towards that end. Some of the amendments that we proposed are to make sure that the breast and cervical cancer program continues to focus on low-income, uninsured, and underinsured individuals so that the funds that we do have go to those who need it the most, while reserving those who do have insurance coverage for this to be able to utilize that funding to be able to do screening. Also making sure that we rely on CDC guidance on determining which populations are at high risk, but at the same time, looking at our state's incidence, mortality, and other health data to see which populations should be targeted for outreach by this program because of disparities in both diagnosis and outcomes. We'd also like to remove some of the specific references to age and type of screening. Those are the types of clinical guidelines that are continuously evolving, and we want to always be able to use the most up-to-date versions of that guidance to be able to expand our programming.
You could go ahead and do your testimony.
And lastly, addressing the point that Delegate Queen brought up around how we want to do outreach for this. And while we do want to do it statewide, we want to focus on using our local health departments to be able to really target outreach to specific communities within their counties, which they are the best situated to be able to reach. But with that, I'm happy to be here to support House Bill 965 with these amendments. Thank you.
And thank you for working with our members and in finding a compromise. I am going to open it up now for questions from the committee. Are there any questions to my right? Delegate Kaiser, I looked at to my right.
Thank you, Madam
Usually
Chair.
I don't. I go left, go ahead.
I don't really have a question, but Delegate Queen, I just want to thank you for sharing your personal story and tell you how honored I am that you represent me in the House of Delegates. Thank you.
Thank you.
That's very sweet. Delegate Lewis.
Thank you, Madam Chair, and thank you so much, Delegate Queen. I'm glad you're here, and I think this is a great bill. So my question is, do we, as a two-parter, do we know the number of women in Maryland who are at greatest risk of this early onset breast cancer? We have a number.
So
We talked about women under age
Yeah.
45, African-American women at risk. Do we have a number?
We'd be able to follow up with you on that, but as I was saying, that it's about 9% of women who are diagnosed with breast cancer in those earlier age groups is generally what we're seeing.
Okay, thank you. And I guess the second part of that question would be, if those women at risk, let's say there's 10,000, but if those women at risk got the same level of healthcare that Delegate Queen was able to have, how many lives might we save? And I realize you can't answer that right now. I just want to
Yes.
underscore why I think that Delegate Queen's bill is so important. Thank you.
And if I usually wait till the end or do not ask any questions, but I did see in the last, I would say, month and a half, 2 African-American anchors, women, that were diagnosed fairly young in the last 2 months. And one of them said that Black women, after being diagnosed and having care, right? Like 39% of them die. It is a very, very high number in the Black community as well. Delegate Woods.
Thank you, Madam Chair. I would like to take this opportunity to also thank you for your testimony. Thank you for being open about what you've been through. And most of all, thank you for doing everything in your effort to assure that your constituents receive the appropriate care. And my question is, isn't that so?
We'll have Vice Chair Carlson followed by Delegate Taveras.
Thank you, Madam Chair.
You're
And
welcome.
I too thank you, Delegate Queen, for bringing this and making us aware of this need. I wanted to ask two questions that are related. This bill is limited to the state breast cancer program, correct? So it doesn't have any implications beyond this program, any financial implications beyond the program. That's number one. Number two is you had mentioned that there are amendments that would reduce the fiscal note. How does it do that? How do they do that?
So so one of the things before we talked, I mentioned, yes, it's limited to the program. So the program basically already takes into account women that are low income that don't have insurance coverage, which the state covers. So we're not opening it up. The way it's written is opening up to women who may have insurance cover and covering them. So that would be a big chunk that would come off of that cost. And there's already some outreach programs that are being done already with the state. And so it's just looking at probably expanding those, but that would also limit the cost that you're seeing in the fiscal note now.
Thank you very much.
Sure.
Delegate Taveras.
Thank you. Thank you, Madam Chair, and thank you, Delegate Queen, for sharing your story. It's very powerful. The general doctor mentioned the fact that Black women overwhelmingly are not susceptible to this, but the ones who are tend to be more likely to die. Is that correct? And if so, why? What are the factors contributing to that?
Delegate Taveras, I don't think that I said that they weren't susceptible, just that the incidence rates we see are a little bit lower in Black women, but the mortality rates are higher. And so I think one of the things that we want to make sure that we do is get screening out to populations who are experiencing higher mortality rates.
Why is the result what particularly is leading to that result?
You know, I don't think that that's clear at this point why that is. I think from our standpoint, it's more we see that mortality and we want to be able to do earlier screening so that we can shift that, get women into treatment and decrease that mortality rate.
Some of the literature talks to, or some of the, you find that they're getting screened, but it's later in the process. It's late, yeah, the diagnosis is later.
And we usually just allow one witness, but we're gonna be a little flexible with you today. Delegate Hutchinson, go ahead.
Thank you, Madam Chair. Thank you, Delegate, for bringing this bill and sharing your story. My former wife, who I remain incredibly close to still today, is a stage 4 breast cancer survivor. I remember the day of the diagnosis. I remember the chemotherapy. I remember the double mastectomy. I remember the days of radiation. I remember the day of getting the cosmetic surgery done to add the nipples. I made a commitment to her, though, when I came here to the House of Delegates, that I would always be very supportive of anything that would help the prevention of breast cancer. So I think you have at least one vote here. Thank you.
Thank you. Thank you, Delegate Hutchinson, and thank you for sharing with us. So I don't see any other questions. I do want you to address the fiscal note, right? And this doesn't mean that we don't support it, because you know we do. But if you could, I know you have amendments to reduce the fiscal note. If I ask you, Dr. Nailesh, if you would be so kind and get an updated a letter, if you can, and work, see if they can produce another fiscal note that is more accurate and make sure that the monies are there, okay? Because it's gonna be, leadership will need that because this is a tough year financially but I'm praying that we get it done. So if you can help us by getting an updated letter, that would be wonderful. I see no other questions, so I want to thank the delegate for being with us today. I want to thank your sisters for being here today, and the Department of Health. Thank you for working with the delegate. I hope you have a blessed day. This actually concludes this bill hearing, House Bill 965, and we're going to go on to two bills that I'm going to call together, and that is actually House Bill 1229, and that is Speaker Jones and myself, and that is the Kratom Consumer Protection Act, and House Bill 1230, which is the Tianeptine Consumer Protection Act. And the sponsor panel, if I may call you, it will be the speaker, myself, Ms. Rhonda Hall. If you can bring her up, please, and she's virtual. It will be Cynthia Alvey. If you're here, that will be wonderful. And Nilesh from the department, if you can come to the desk, that will be wonderful. My vice chair is going to take over so that we can make the presentation. Thank you so much. Welcome, our speakers.
Madam Speaker, I would add my welcome and that of the committee to our committee today. Thank you very much.
Thank you.
As our chair said, we're going to consider these two bills simultaneously. The first is 1229 Public Health, Kratom Consumer Protection Act, or the two together, and the second is 1230 Public Health, Tianeptine Consumer Protection Act. I hope I said that correctly.
Tianeptine.
Tianeptine, thank you very much. And Madam Speaker, I think you're going first.
Okay. Thank you. Good afternoon, everyone. Vice Chair Collison and members of the Health and Government Operations Committee. For the record, I'm Speaker Adrian Jones. I'm here today with Chair Pena Melnick to testify in support of House Bill 1229, make sure I'm saying it correctly, Kratom?
Yes.
Kratom Consumer Protection Act. I am also, on the phone, I guess, joined by my constituent.
Yeah, it's right here. It's right.
Rhoda Hall, I see you.
Hello. Hi.
And her friend, Ms. Dorothy Mars.
Yep.
Okay. Their story is why this bill is before you today. In October 2022, Ms. Hall's son, John Talbert III, tragically passed away, and his death was ultimately linked to Kratom use. I will let Ms. Hall and Ms. Morris speak more directly to the heartbreaking experience, but unfortunately, their story is not unique in Maryland. That's because right now, Kratom is easily available, unregulated by the FDA, and its health effects are not well understood. House Bill 1229 seeks to remedy these issues by implementing common sense regulations around the preparation, distribution, and sale of Kratom products in Maryland. It also prohibits the sale of Kratom to minors and any attempt to advertise or market Kratom products to minors. Before I conclude, I want to be clear, this bill is not instituting a full outright ban of Kratom or Kratom product for responsible adults. All we are saying is that Kratom products in Maryland need to be properly labeled and uncontaminated or unadulterated with other dangerous substances. Over the years, the committee has worked diligently to protect Marylanders from substances that raise significant consumer health and protection concerns. House Bill 1229 continues that work and will ultimately help keep Marylanders safer. Thank you, and I'll turn it over to Chair Pena Melnick for her testimony.
And thank you, Madam Speaker. I want to first thank Madam Speaker for bringing this bill to the committee because we were not aware of it until you brought it to the committee. And when we started doing the homework, we decided and realized quickly that it was really important to address it. So thank you for your leadership and your constituent as well. So the bill you have in you, as the speaker said, is very limited. It basically will apply to 21 people that are kids that are 21 or younger. And why is that? Because they're kids and they need to be protected. How easily available is this? It's available at smoke shops. It is available online as well. It has opioid and stimulant-like effects, which can be easily abused and people can become addicted. We know that in Maryland, every year we have over 2,200 people that die due to the opioid crisis. This really adds to it. As the speaker stated clearly, the FDA has not approved this product at all as a dietary or medical use. Additionally, we were not able to find, and they have not been able to find sufficient evidence to claim that it does not pose a risk to people. And as I look to see what are the side effects of it, what it does to your body is the following. You can have nausea, sweating, dry mouth. You can have tachycardia, it affects your heart, drowsiness, you can have anorexia, insomnia, seizure, hallucination, and you can die, okay? And our kids have access to this, as the speaker said, easily. And there are companies that honestly they're predatories in their marketing, and they are targeting young people as well. And if you're wondering, have any other state done this? Why Maryland? Well, let me tell you that other states have gone through similar successes in regulation, in implementing in regulations that deal with consumer protection as well. So you have Arizona and Georgia, but let me tell you about Alabama, Arkansas, Indiana, Rhode Island, Vermont, and Wisconsin. They have gone as far as a full ban for everyone. Here we're doing it for 21 and younger. And also the bill that the speaker had drafted requires that the Maryland Department of Health do a study and come back to us in 2026 to look at what are the effects out there. How is it affecting people so that we can consider what else to do. But for now, it is very limited. And on behalf of the speaker and I ask for a favorable report on House Bill 1229.
Thank you, Madam Chair. Is this Ms. Morris?
No, I'm Mrs. Alvey.
Yeah, can we go to the virtual witness, please?
Okay.
Thank you.
Ms. Hall?
Okay. Hello, everyone. My name is Rhoda Hall. Back in October 2022, my son was found dead, actually in the woods. He had first started hearing about Kratom online from a company he had ordered it from called Star Kratom. It was back in May. And well, he actually told me to purchase for him. And he kept saying it was a natural substance that he wanted to try for pain and anxiety. And I thought, okay, well, since it's natural, he could try it. And he seemed to be okay trying it. When I was having trouble with pain, he told me to try it. I tried like 6 tablets or pet capsules, I should say. And I didn't feel any effects from it. And so I didn't want to try it again. He then asked me to order some more in June, and he took some, and I don't know how many he took, but he seemed okay again in June, like he seemed okay in May. I didn't know he had ordered more in July. Until I found out last year he ordered some in July. When August came around, he disappeared. Like August 11th, he left the house, and I didn't know what time he had left out the house. And I contacted police. I went to their station and told them he's missing. So they sent out helicopters looking for him August 11th of 2022. They found him later on that night coming out of the creek in the woods near where we live in Owings Mills, Maryland. After they found him, they said he looked like he was ready to pass out. They said, do you want to go to the hospital? He said, yes, he needs help because he said he was hearing sounds and seeing beams of light. So they took him to the hospital. He was there for 5 days. And actually, they diagnosed him with psychosis. And he told them he had been only taking Kratom. which was the only substance that they knew that he was taking. And during that time, Kratom couldn't be checked. They couldn't, it wasn't really tested or anything. And they couldn't find any other substances in him. So after they released him from the hospital, they had him on something called olanzapine to try to help him get over his psychotic episodes that he was going through. His medication ran out in September. I had taken him to a place called Chase Braxton, and they were going to try to get him to see a therapist. They kept canceling his appointments, and he didn't want to keep going back and forth with the counselings and everything. And then they would later have him see a psychiatrist, which never happened. So he seemed to be doing okay, except for, he had stopped, his hallucinations had gone. So around October, on October the 16th, he had left the house and called me and said that he couldn't find his way back home. So I started searching. That was at nighttime. I started searching all throughout the woods because we lived right by the woods. So I was searching for him. And finally, when I drove up to the corner where a park was in the area, I saw him coming out of the woods stumbling, and he came out there with one shoe off and his feet were wet and it was damp, and he didn't know how he had gotten in the woods. And all I know is I found out just last year that he purchased Kratom in September. So that was the second time he purchased that Kratom himself. And I don't know the dosages, but all I know is he was hallucinating that whole entire week from that Sunday. And then Monday, I was at work. I had to sign off of work just to go look for him again because he went lost in the woods again. And he told me, Mom, help find me. I don't know where I'm at. He thought he was on the highway, which he wasn't on the highway. He was actually around the same creek that he always liked to go around. And it took me like 2 to 3 hours before I had to try to direct him, bumping horns for him to come out of the woods because I didn't know exactly what part of the woods he was in. And finally, about 3 or 4 hours later, I saw him walking down Owings Mills Boulevard, and he actually didn't even notice me. I kept bumping the horn. I had to open the car door and say, "Come on, get in the car." His clothes were soaking wet all the way to his waistline. He just looked like he didn't even know who I was or where. And I managed to take him home. I told him I wanted to take him to the hospital. I couldn't take him to any psychiatric places because they said that he wasn't covered under insurance that I had. And he was only on something that he was put on like a temporary thing for Medicaid that they didn't cover. So he didn't get the psychiatric treatment he needed. I tried to go call Chase Braxton for him to get an appointment. They said they had an appointment set for him, but he said he didn't want to go back and forth again. So he seemed normal that Wednesday. He seemed like he was doing pretty good. He cleaned the house. He had went outside, cut the grass on back and front and the bushes. And he seemed normal. He started reading the Bible like he always would read the Bible almost every day and write daily stories. And he would make videos. And I thought he was okay. He stayed up all night on a night of the 19th of October. And then all of a sudden he kept saying around 4 o'clock in the morning, he said, "I hear some loud sounds and they're getting louder and I need to leave the house." And I kept saying, "Why would you want to leave the house? You need to get rest," which he didn't get his rest. I didn't know that during that time, sometime close to around 7, which I had a tracker on his phone, and my tracker was tracking that he had left out the house at 7, but I didn't know that until like later on in the afternoon. I thought he was downstairs, but my tracker showed that he left out at 7 a.m. and I couldn't tell where he went because the tracker must have stopped at some point in time. So I called the police again and told them he's missing. They said that they were going to have people search out for him. This time there was no helicopters flying around, no real searches. So I kept trying to search myself. My family members tried to help me. My coworker, Dorothy, who she's not on the call today because she had an urgent meeting with her manager. Yeah. So I kept having searches done with friends. I tried to get the guardian angels involved. They were going to go out and do searches because we couldn't get the police to do our searching. It was like till the 6th day is when a detective got involved, and he told me, he said, "We're going to do a search." And I said, "Can the guardian angels help you?" They said that, "Oh, we're just going to do the search ourselves." So on October the 28th, in a matter of about an hour, they found my son's body in a creek. The medical examiner, he did autopsy, well, toxicology autopsy. Well, he did his first autopsy results. And he said that was one concern that they really didn't know at the moment as to what he died from. They said that they could tell he must have passed out and fell in a creek because the water was so low. They didn't think that he would just drown, but they said even a little bit of water got into his lung. But the fact is, after they sent the results to another test or office where they sent to do their test or medical place, they found out that it was Kratom or Kratom, we call it, that was found in his system. And he had like a few other small, minute things in his system, like Benadryl, because he kept saying he was itching during that week and his sinuses were acting up. And it could have been like some of the effects from, who knows, Kratom or what. But he had been going through that woods. He would go in the woods all the time. But I'm like, why all of a sudden he dies from the stuff called Kratom? He was already admitted into the hospital because of it. They put him in a psych ward for those 4 days at Northwest Hospital. Yeah, and it's just been one terrible thing after another. I joined a group called the Kratom Danger Awareness Group because all the people in there that when I first joined, all of them had relatives that died from Kratom, and they're all been trying to spread the word saying that it should be banned. I know this bill is about people under 21. There was only one person that I know of and we had heard about was Ethan Pope. He was the only person that I think was younger age. Most of the other people seem to be like the ages of 20, 25, 30. My son was 36. And all the other people around those age groups. So we really wanted it banned, but I know the American Kratom Association, they want it to be something to be regulated or so, which they wanted regulated for all ages. A lot of us who lost our relatives, we prefer to see it banned. But if there's no other choice, I would like to see it regulation on it for everybody. It shouldn't be just somebody 21 and under, because people are dying that's older. I mean, I had a nurse in Florida, she died from it, right from her 3 children and her husband. She died right there, fell on the floor and died from it. And also, there's been other people's family members in the group I'm in, their family members have died from it. There's a lot of people also that joined our group, they are people who were taking Kratom and they got addicted to it. They said that it's worse than them taking other opioids. When they try to come off of it, they say it's the worst thing to try to withdraw from. They say they get all kinds of side effects. They pass out, which is similar to what my son did. They pass out off of it. Yeah, so it's really a dangerous herbal substance, if you want to say, but it's more like an opioid, the side effects. And so many people I know of have been affected by it. I talk to people daily, and we're all joining together to try to see if there's any way to ban it or some people want to regulate it. At least a lot of people who have been users of it, who were previous opioid users, when they switched to it, they found out that their side effects were worse.
So Ms. Hall, I really appreciate your testimony. Thank you so much for sharing your story and really helping us to understand the dangers. And we're here today to talk about how we can at the very least regulate it and get some information about what we need to do next. So thank you very much for being here and we are so sorry for your loss. Please accept our sympathies but we admire your courage coming today and letting us know so that we can make good policy around this. Madam Chair, shall we go with Ms. Alvey? Okay.
You go ahead. Yeah. Hi, I'm Cindy Alvey and I'm here to support Bill 1229. Gas station heroin, Kratom, Tianeptine, and Phenibut took over my son's life and caused his death at age 33. We must prevent this from happening to others, especially those under the age of 21. This is James Alvey, my son. We called him JT. He was a Spirit of Columbia Scholarship winner and graduated with honors from the University of North Carolina and was accepted into Johns Hopkins School of Business Master's program. He had a successful IT career and was blessed with many talents and a heart of gold. He was and still my pride and joy. His death broke many other hearts. Over 250 people, friends and family, attended his memorial. He suffered from anxiety and other behavior challenges, and he sought Kratom to relieve some of the stress without any legal consequences. I recall the first time he bought some at a nearby smoke shop and brought it home and said, "Hey, this stuff is supposed to be great. It can help with stress and you can even make tea out of it. So you should try it." Well, I thought better and threw it away later. And let's just say this kind of stuff isn't my cup of tea. Well, apparently it wasn't JT's either. The stuff gave him chills at first, and then he was shaky and jittery, jerky body movements and agitation. I called it Kratom crazy. I witnessed anxiety, muscles aches, nausea, depression while on this stuff. Symptoms JT thought these drugs would help with. Websites and packaging claimed that it treats anxiety and depression, increases energy levels, reduces pain, improves mental conditions, provides feelings of pleasure and euphoria. But in fact, Kratom has no legitimate medical use. Yet you can drive almost anywhere in the United States and see a neon sign saying, "We have Kratom," except in Alabama, Arkansas, Indiana, Rhode Island, Tennessee, Vermont, and Wisconsin, where it's illegal to buy. After one too many bad trips on Kratom, he entered his first rehab for drug addiction. But when he got out, he switched to other gas station heroin drugs like Tianeptine and Phenibut and became even more addicted to those. He eventually died in 2022 from withdrawals from these drugs. So, to me and my husband, this bill does not go far enough. This bill is a small step, a $500 slap on the wrist for selling these drugs versus my son's death. And it hardly seems enough, but it is a start and a step in the right direction. And I know Maryland will do more. Thank you.
Thank you, Ms. Alvey. Thank you for your story.
Yep.
And again, our deepest condolences to you and your family.
Thank you.
Dr. K?
Thank you, Vice Chair Cullison and members of the committee. I will be brief. For the department, we support this bill with some of the amendments we spoke with Chair Pena-Melnick about. Products containing Kratom are being sold all over the country and in Maryland, and for a number of different reasons that are advertised on their labeling. The FDA has not approved Kratom or its chemical components to be used in drugs, and it's not appropriate for use in dietary supplements. Research on Kratom safety or lack thereof is ongoing, but so far, as others have mentioned, 6 states have passed state laws banning it entirely due to legitimate and founded fears concerning its safety. There's a wide range of effects that have been noted from Kratom, including side effects around psychiatric complications, cardiovascular, gastrointestinal, and respiratory issues. We particularly wanted to work closely with the chair around issues about removing references to food. Kratom is not considered generally safe for food, and so even labeling can't be used as an additive in food. But in general, we are supportive of this bill. It is a dangerous substance, and we applaud any efforts to regulate and limit its use and exposure, particularly in youth. Thank you.
Yeah, thank you. Madam Chair, I need to ask, would you prefer to have questions now about Kratom, or do we want to go into the second bill?
Why don't we do the
before-
questions? Thank
Okay.
you.
Thank you, Madam Chair. Are there questions for the chair and the speaker and their panel? Delegate White Holland.
Thank you, Madam Chair, and thank you, Madam Speaker, and Delegate Pena-Melnick for bringing this bill to us. I would like to just simply inquire, based on the Health Department's letter, that it talked about unintended consequences through this potential legislation. And so, given that other states have taken action in moving forward in this way, can you describe what outcomes we've seen in other states, and in what ways have we seen results in protecting consumers from this in other jurisdictions.
So, thank you, Delegate. The unintended consequences we were talking about was the amendment I mentioned around the food. And in the original bill, there was an item about labeling the presence of kratom in food, but food labeling requires that you can't use any substance in food. Labeling is not the issue. You can't add it. And so that was the unintended consequence we were referring to, and that's what the amendment is covering.
Thank you. Delegate Lewis.
Thank you, Madam Chair, Madam Speaker, panelists, to both of the moms. I'm so sorry. I hope you will hear the message that we are really sorry for your loss. And I know we'll do all we can here. My question is directed to Dr. Nylesh. I am struggling a bit to understand where this came from. I mean, I know I'm old, but I thought I had heard of every, recreational substance, and I'm not familiar with this. So, and some of you are laughing way too hard at that. Where did this come from? How did this happen? And how does kratom fit in the constellation of other opioids that we're also tackling right now?
So, Delegate, kratom originally comes from a plant source, but subsequently is also being synthetically manufactured. Thank you. Moment there. Synthetically manufactured, and so there are other variations of it as well. And it has a range of effects. Anecdotal data is that at lower doses it helps more with anxiety. At higher doses more with pain. But there's no clear dosage range. There's typically no good understanding of how much somebody can tolerate. There's, as you've heard, dependencies. And then often with these products, there's no such thing as quality standards generally. There's other adulterants in there as well. And so what we're seeing is that this product that isn't regulated at the federal level then can be sold. And as long as the labeling is sufficiently vague, it can be sold for a variety of purposes and a variety of locations.
Good. Delegate Taveras.
Thank you, Madam Chair. I think that this is really important based on what I'm seeing here is, and I'm sorry for your losses and the concerns in your family. My concern is that this is something that really should be included, and I think we have a bill on synthetics, on psychedelics. With regards to naturally occurring, but at the same time, this is concerning because it could be addictive if used in certain doses. So that's what concerns me, that even that the fact that it is available to somebody older than 21, it could be addictive. Is there an address to that, or to make sure that people are not purchasing large amounts of quantities to ensure that they're not addicted?
The bill, and thank you, Delegate, for your question. The bill that you have in front of you, it's basically to prohibit the sale to 21 and younger. And if the committee is wondering why did we not put a total ban, it's because there was a bill in 2020 that Delegate Kurt had that went to judiciary that dealt with doing a total ban and adding it to a Schedule I. So it's a total ban, and the number of witnesses that came forward to say that they were using it for pain, that it was helping them to please not ban it, it was really, they were very loud. So in the interest of compromise, as we often do, in this body, we looked at young people and how vulnerable they are, right? How they don't know all the facts. A lot of times they don't know the consequences, and we have a duty to protect. When we look at public health, we decided to compromise and bring everyone to the table and do what some states have done, which is a prohibition of 21 and under. Simply stated, that is the reason.
Thank you. Good. Delegate Kipke.
You, Madam Vice Chairman. Thank you, Speaker and Chairman, for the bill. I had a constituent contact me a couple weeks ago with fortunately her son survived, but with concerns about it. And she was happy to hear that there's a bill that would be heard today. Dr. Nilesh, and my sincere condolences to you and your families for the loss of your sons. It's heartbreaking. Dr. Nilesh, after I received the call, I started researching on the internet, and some people claim that this product can help them. Do you believe that that's true, or there seems to be a lot of people who say it should just be banned, and but then is there any truth to the fact that this is somehow a helpful product for certain people, either trying to avoid more harmful substances? And that's what I saw a lot of on the line, and maybe there's other reasons people use it as well.
Yeah, Delegate. So there are a number of people, right, who take the substance and say that it helps them. I think the challenge we have is that a couple of things. One, there's, as I mentioned, it comes from a plant, but it's also synthesized as a chemical, and so there really isn't a good way to say which version you're getting. Right? Is it extracted from plant? Is it synthesized? There are oftentimes adulterants, and there's no clear dose response curve. And so we're kind of in this space where people take it. We're not exactly clear what they're getting, and we're not exactly clear how much they're getting. And so, yes, it may be with further studies, and there are studies going on about this, that with further studies, we're better able to, delineate, okay, at these doses, it's going to be helpful. At these doses, it's harmful, but we're just not there yet. And what we're seeing is people do get addicted to it. People do die from it. And so we're trying to, we always kind of hew to, is there evidence that it's actually benefiting? And is there evidence that it's harm and there's harm? And right now, the benefits are smushy, the harms are there. And so we do want to keep people safe and use other methods or substances that are legal and proven to be safe.
To you, the bill addresses 21 and younger, but it also goes on to address what can be sold, period, in terms of adulterated products. And this is a little, it isn't a quick read for the purposes of understanding it. It talks about certain percentages, and this is on page 2 and 3. Products that are mixed or packaged, and then disclosure of what's in the products. I was glad to see that, because some of what the internet told me was they're adulterated, and they may actually have ingredients added for the purposes of addiction to try to get people hooked on it, and certainly the marketing does as well. But my question to you is, who would enforce this provision of if there is a reported violation, who do people report it to, and then who would go out and inspect? And then I see that there's fines involved as well.
So I think that's part of what
issue regulations.
Hmm?
You're gonna issue
Yes.
regulations.
That's part of what we would need to do is issue regulations on how we would manage this and how we would essentially make sure that what is labeled is accurate.
Regulations in place that indicates who it gets reported to, and then the agency that I guess goes in and enforces it.
Yes, we will need to do that.
Thank you.
The delegates. New term of art, smushy. Delegate Bagnell.
Thank you, Madam Chair, and thank you for this bill. And I understand the intentionality of not doing a total ban. But one of the things I'm not, and maybe I'm just not seeing it in the bill, it speaks to restrictions on advertising, promotion, and packaging, labeling as regards the 21 and under prohibition. But I saw from Dr. Google that there's already an implicit or an implied prohibition on advertising to adults based on therapeutic claims. And I understand that the industry has been sort of self-policing their manufacturers. And I'm wondering if this bill speaks to
that prohibition, or if it's something that could be under consideration to prohibit advertising based on therapeutic claims.
So if you look at page 4 of the bill and you look at line 8, and it talks about, actually line 10, when it starts talking about advertising, promotion, packaging, labeling, and it tells you you can have a cartoon, a superhero, a video game reference, then go to lines 26. It says in a newspaper, magazine, periodical, or any other publication, it addresses it there, but the bill belongs to the committee now, right? So if the committee would like to make it wide for everyone, the committee can do that as well.
Thank you, Delegate. Delegate Martinez.
Thank you, Madam Chair. And thank you, Madam Speaker, as well as Madam Chair, for this bill. More and more, you're seeing smoke shops and gas stations advertising all types of synthetic products that can be smoked or consumed. A lot of young folks I'm seeing are consuming this and having the adverse effects that you all sons had, and I'm so sorry to hear about their untimely passings. Can we talk more about how this product impacts people, particularly on the what is it, the word I'm looking for, the psychoactive stimulant, and why that's so negative? Also, something that I'm glad you mentioned is why we're not banning it, because I was going to say we shouldn't be leading behind Arkansas on anything. And on this one, we are. But I wanted to know, could you just describe more about how these stimulants impact young brains?
So Delegate, I think that's part of the research that's happening, right? So in terms of the effects that it has, I was mentioning that anecdotally at low doses, it has more of a stimulant effect. But it's unclear what that effect is on the developing brain, right? And that's why generally we don't want youth to be taking any substances, this included. And the range of side effects, there are gastrointestinal things like nausea and vomiting, but then you can also see other psychiatric side effects in terms of confusion, loss of consciousness, cardiovascular effects like higher blood pressure, right? And so starting at a young age does lead to these harms in a developing body, and then also issues around dependence and starting to get used to that, and then requiring higher doses.
Thank you. Yeah. Delegate Gazzoni.
Thank you. First of all, Mrs. Salvi is one of my constituents, so I want to particularly thank you for coming and sharing your story today. I know you've been working hard. You and your husband both have been working hard in this space for a number of years now, so we appreciate that. So a lot of my questions have been kind of answered, but I guess I'm curious about things like warning labels and really sort of where the FDA is on this, and
the FDA, so the FDA isn't anywhere on this, right? And that is the issue, is that there are substances that as long as you don't advertise them for a specific purpose, we are usually behind in that there's substances that are coming out, and then we have to catch up and see how dangerous is it, and then what do we need to do about it? So to date, the FDA has not taken action.
And if I may, I'm going to violate my own rule of the one person, one answer. I'm so sorry. You can slap my hand later. The FDA has not approved this, but the DEA has actually listed Kratom as a drug and chemical of concern because they're so concerned about it. Okay.
Seeing no further questions. Oh, I'm sorry. I even have it down here. Delegate Salega.
Thank you. Thank you for bringing this bill. I asked the Google machine where I could buy it, and I was surprised how many places are selling it, but Amazon is not. Interesting. But my question would be, of these two, we're kind of hearing these bills together.
You're gonna hear the other one in a few minutes.
Okay. How addictive is Kratom? Does everyone who use it get hooked on it, or Is it addictive if you use a lot of it, or what can you tell us about the addiction qualities?
So Delegate, I don't know how to quantify that per se, and I'd be happy to follow up on that. But we do know that, like with other substances, there's a good number of people who don't become addicted to it. But there are a group of people who are getting addicted to this, and as you heard a couple of the stories, trying to enter into treatment is very hard for this, particularly when there aren't good pharmacological treatments. So it's the challenge is what is the safety profile of this? And I don't think that's been well articulated yet. So it's hard to say there's a safe way to use this.
And I'm gonna violate my rule again. You can hit my hand again. So the hospitals, the other problem that we have here is that the hospital do not have the equipment to test for it. Amazon does?
They had strips. It said, because I put it in the Google machine and it came up and it said they're urine strips. I
Really?
don't know if they work or not, but.
Interesting. Okay, now, excuse me, Delegate Riley.
Thank you, Madam Vice Chair. I heard the panel by our esteemed chair. Thank you for bringing this bill. It's very important.
The speaker brought it.
Oh, and well,
She
okay,
led.
the speaker. Thank
Yeah.
you very much. She's still here.
Yes.
Thank you. I did have a question because you had mentioned in your testimony that this is purchased, sold at a lot of gas stations, stores, and online. Does this bill affect anything or have any regulations on the online purchase?
It
you know.
has, if you look at it says retailer, right? Retailer means a person that sells, prepares or maintains Kratom products or advertises, represents or holds itself out as a selling, preparing or maintaining. So I would say yes.
Or just in-state?
It doesn't, I do not know the answer to that. So we can
that would
find
be-
out in the committee. We
Okay.
can ask council to look at that.
Okay, thank you very much.
You're welcome. It's a good question. Thank you.
Okay, so I seriously am not seeing any more lights. Thank you. Thank you very much. Madam Chair, would you like to introduce the other bill before we go to
Yes.
the other panel of witnesses?
So the other bill that I have, and it's the speaker and I again, and I want to thank her for her leadership on that last bill because we would not have it if she did not brought it forward. We have now House Bill 1230, which is the Tianeptine Consumer Protection Act. And I would like to thank Vice Chair Collison and the committee for allowing the speaker and I to present this bill to you. This is another product that is very dangerous. What this does is that it seeks to protect minors from dangerous marketing and drug usage. Tianeptine is actually known as the heroin at the gas station. That is what it's known, the heroin, gas station heroin, because it's so easy to get at gas station, convenience stores, and at the internet. It is an opioid-like addictive properties, and I know the doctor can get into it more than that. I'm not a doctor, but it creates a harmful circle of drug usage for young people, like the last bill that the speaker presented. The FDA on this one, though, they have issued a warning about Tianeptine and its potential for its abusive and addicted nature. So they have taken a position. In addition, the National Poison Data System recorded a steep increase in confirmed calls that they received. It went from 11 calls in 2000 to between 2013 and 2015, they had 202, and it's even higher now. The way they use this Tianeptine, the usage may lead to the following, which is very serious. Hypertension, tremors, you have the same symptoms, with the heart and hallucination and death as the other one. Hospitals also lack the capacity to test for it. And this substance is really widespread and addicted among young people, like the last bill that we presented. Some states that have actually taken and passed measures is the state of Michigan, Alabama, Mississippi, Tennessee, classify it as Schedule II drug, while Florida, Indiana, Kentucky, Ohio, and Georgia have gone further and identified it as a Schedule I drug. So we are not scheduling it here. We're doing the same thing, basically prohibiting it for 21 and under, but it is an extremely dangerous chemical, like the last one that we presented. And for those reasons, the speaker and I respectfully ask that you please return a favorable report on this bill. Thank you so much for allowing us to present this to you today. And if I may, Madam Vice Chair, if I would allow the doctor to go next.
Thank you. Yes, Dr. Gay.
All right, thank you. Pleased to be here in support of this bill with some of the amendments that we talked about, which were very much similar to what we talked about with Kratom. Tianeptine is a drug that's actually approved in other countries in Asia and Europe, but the FDA has actually not approved it for sale in the United States because of concerns around its use and about its abuse potential as well. As Chair Pena-Malik noted, its common name is gas station heroin. And that's because it has effects very similar to heroin and causes sedation, loss of consciousness, but critically it's not an opioid, and so it cannot be reversed by naloxone. And so we have seen deaths from that. It's not, as I mentioned, it's not approved by the FDA. It's not approved to be added to any food. And of course, other states have taken action against this. And so for that reason, the department supports this bill with the amendments to limit the sale of this to those under 21, and also note that this is a dangerous substance.
Thank you, Doctor. This completes the sponsor panel. And so let me ask if there are questions. Delegate Hill.
Missed out on the previous one, so I got to get my licks in. Thank you very
We
much.
missed
Thank you,
you.
Madam Chair, Madam Speaker, and we've had problems for years with synthetic drugs, right? Change one of the arms of the drug, synthetic cannabinoids, which were not really cannabinoids, and the narcotics and opioids. Is there a way that you think we can approach this more comprehensively instead of waiting for every new drug to come up and come to our attention and then come back to address it?
Billy, that's a difficult question, right? Because there's always a new substance being created. You mentioned the synthetic cannabinoids. That was, I believe, in the early 2010s, right? We were really confronting it then. We've got Tianeptine now, Kratom, we've got other stuff, right? And I think the challenge is that you have to know what it is to be able to address it. And so I think your question goes to, how do we deal with the entire universe of what's out there? And I don't have an answer for that for you.
Okay. Delegate Bagnall.
Thank you, Madam Chair, and thank you again for this bill. Just to clarify, because I know Dr. Kalyana, you mentioned that this was used in other countries. It's a prescription in other countries that is controlled and regulated. Is that correct?
So to the best of my knowledge, yes.
So in the US, it's completely unregulated as opposed to other countries where it's controlled. Thank you.
Delegate Martinez.
Thank you, Madam Chair. I'm just curious, how much does this cost at a gas station?
I don't know.
You know, if I may take that one, I was gonna go buy some today to bring it. So I now regret not doing it, but I do not know, but it has to be not that expensive for young people to afford it, right? And for it to become an addiction. But I do not know that, but we'll find that out. We'll look at that answer for subcommittee as well. And if I may, I want to follow up that the FDA has issued regarding this one, a consumer warning against its use. They send warning letters to companies illegally marketing products containing Tianeptine, and they have issued border alerts to stop shipment into the country.
Thank you. Delegate Chisholm.
Thank you, Madam Chair, and thank you, Madam Chair, for bringing the bill. I'm curious, you said something a couple minutes ago about not wanting to make it a Schedule 1 or a Schedule 2? Is there a reason for that?
We just made the decision. I was given the answer. It costs $9 to $20. Thank you. So we have, if I may, I had, the reason is that we try this, the earlier bill, we tried to compromise because there were people that actually thought that there was some merit to using it, right? This one, actually, the committee can do it. And as I listened to the testimony and the conversation, the committee can consider that as well.
There's a medical necessity for it, then it could be prescribed then, but then this eliminates it being so accessible. Is I know that we're talking about marketing here, but let's be honest, you don't need to market heroin. Once somebody gets used to getting something, they don't care about the marketing.
Agree, delegate.
Okay.
Agree. So the subcommittee, I want you to speak up like you usually do and make that point. You're welcome. If I may, Chairman, we have one of the witnesses that has signed up for both bills, and she would like to tell the story of her son using this as well.
Okay, and Ms. Alvey, you're gonna.
Yeah, I'm back. Unfortunately, my story is a 2-for-1. Or maybe a buy one, get one free. I don't know. So after my son James was done with Kratom, he turned to Tianeptine and another gas station heroin that you might read about in the New York Times called Phenibut. Tianeptine is sold at gas stations and online under names like Zaza Red and Neptine's Elixir. And they come in and you buy them. They look like small or large supplement bottles. When I saw them, I had no clue how serious this stuff was. And so when James started taking these, I saw the side effects: rapid heart rate, vomiting, seizures, loss of consciousness, and later on it even put him into a coma. I also witnessed depression, anxiety, and sleep disorders in his attempts at quitting it, these same symptoms that he was taking it to help him with. And when he tried to withdraw from his addiction from it, he told me that it felt like death. And he looked like it too. To avoid withdrawals, these pills must be taken every 2 to 3 hours. So you might say a bottle costs 10 to 25 bucks, but once you get on this stuff, my son's savings of thousands of dollars were wiped out. But in the meantime, tianeptine is hardly even known in the health space. Nobody tests and nobody knows about it. After completing his 3rd rehab for these kinds of drugs, a week later, James got a hotel room and bought tianeptine. He was alone and had seizures that were so hard that it cracked his skull and left a gaping hole in the back of his head, shattered his foot, and fell into a coma. I personally went to the hotel room to retrieve his belongings and saw a bloodstained room that looked like a murder scene. This is no scene that any mother should ever have to see. And there were tianeptine bottles and pills everywhere. He was sent to Maryland Shock Trauma ICU, and he was in, as I said, he was in a coma for almost a week. They tested him to find out what were causing the seizures, and they found no medical reason. They tested him for drugs and alcohol, and the only thing that was in him was his antidepressant. As I said, nobody tests, nobody knows. Miraculously, he survived. And surely we thought he has hit rock bottom. But sadly, his addiction called him back. And when the same chain of events happened 6 months later, he was found dead on January 30th, 2022 in the Days Inn in Cambridge, Maryland, about a mile away from Avenues Recovery, where he had gone for his fourth rehab to get off of these drugs. To me, my husband, this bill does not go far enough. 9 states, as the chair has mentioned, has made it illegal. Alabama and Kentucky have categorized it as a Schedule I. Come on, Maryland, we're behind Alabama and Kentucky. This bill is a very small step forward, as I said, with Kratom, but especially with the Tianeptine. A $500 slap on the wrist for selling these drugs versus my son's violent death would be discouraging. Again, it's a start and it's in the right direction, but I pray and hope is no strategy, but I hope that Maryland can do more than this in the future.
Thank you. Thank you for your testimony. Questions for Ms. Alvey or any of the other panelists? Delegate Hill.
Thank you, Madam Chair. Dr. Kalyanaraman, how do we, right, this is clearly dangerous, but as you noted, it's used as an antidepressant in other countries, not FDA approved. How do we square our banning this with our efforts to set up a work group to look at legalizing psychedelics? How do we, which can also have deleterious effects, how do we square up those two things, that we're banning some and letting others go?
I think that's a good question. And I think we can certainly go into more detail, but I think the thing that I'll say is that you know, in the psychedelics, one of the questions that has to be answered there is which psychedelics, right? And how do you define that? And what is the dosage and all those kind of really important questions? But when we look at this drug, essentially, I'm gonna go out on a limb in here and say that nobody is really calling this a psychedelic, that this is being taken for other reasons in terms of people are taking it, whether it's for pain or for the euphoric effect or whatever. And it falls much more squarely into the arena of why it's called gas station heroin. It's more mimicking that sensation.
So I guess yes. So I guess my question is, if it's about dosing and controlled use and in a controlled situation, are we repeating what we've done before, saying we see some bad trips, we're going to make these things illegal, and then we come back because people illicitly are finding ways to use it in a controlled fashion? Or, you know, is that a repeat of the cycle that we keep going through? And would we be better served saying these are drugs that people are abusing, let's control them instead of banning them? And I'm not saying that's the answer, but I think we should have a logic to why we're treating certain drugs that people are using recreationally that may or may not have beneficial medical effects, and other drugs that have been deemed to have some medical effects, like in other countries, but we're only seeing it being used recreationally.
So if I may take this question, the task force that Delegate Gazzoni has, when we looked and we were here and we listened to the testimony, people gave testimony how it had really improved their lives, right? There are some studies and science that shows that there's some benefits. The difference here is that there are no benefits for health-wise, and the FDA, especially on this one, has said absolutely not, because it's very harmful. So you can have a glove that fits all, because they're very different. So as a policy committee, what we do is that we, as you know, we listen to the testimony, but most importantly, we look at the data, at the science, relied on our experts to come up with a policy that it's based on science and it works. And I think that it is impossible to take all these drugs that are out there or to anticipate what else is coming next month or next year and to develop a policy that applies to all, because there may be some benefits to it. So unfortunately, Delegate, we're gonna have to do it one at a time.
Okay, Delegate. So, seeing no other red lights, I do have a question. And I hear that the FDA has issued warnings. At what point does it get involved in scheduling substances like this?
So the FDA, it's the DEA that does scheduling, and that's done legislatively, the federal level.
So Congress would have to actually schedule this as a dangerous substance?
Yes.
Thank you very much. Seeing no further questions, that concludes the sponsor panel. We do have some other witnesses, though.
Thank you so much.
Thank you. And I'd like to call Kristen Smith, Talis Abelines, Jack Henningfield, Lisa Lowe, and Ryan Burrows. There. Okay, Ms. Lowe, you want to get started?
Okay, I'm here to talk about Kratom. I'm Lisa Lowe with Face Addiction Maryland. And as I'm sure you're already aware, Maryland is ranked 5th in the nation for overdose deaths, and 80% of those are opioid related. And I'd like to talk about one solution for problematic opioid dependence, and that's methadone, the gold standard, according to the very well-funded methadone lobby. There are 30 plus studies that show 20% to 70%, depending on the study and where it was done, that show that those enrolled in methadone treatment are using other drugs, most notably heroin, 40 to 60%. And this mirrors what we hear from consumers of treatment services. According to nearly 20 studies, methadone maintenance patients are also at a higher risk of death from overdose, even when under the care of a provider. And this statistic also mirrors what users tell us. We know, our children know what works. Scientists know what works. But it is becoming evidently clear to me the more I come to Annapolis that we allow what doesn't work. One has to ask themselves, why? Well, we allow what doesn't work because it's profitable. Last time I checked, the average dose of methadone wholesale cost $1. Medicaid pays a clinic $80 per week per patient, and the average patient spends an average of 6 minutes per day in so-called treatment. This is what our regulated, FDA-sponsored, pharma-backed system offers us. We have chosen profits over lives. It costs billions per year for a drug to become approved by the FDA. According to the American Kratom Association, which they're here today, there are more than 180,000 Marylanders using Kratom, and 1/3 are using it as an opioid replacement therapy. In conclusion, if I may, that's more than 60,000 Marylanders. We are not hearing about Kratom deaths. It is high time that evidence-based, scientifically supported alternative therapies for opioid addiction were acknowledged, accepted, and consumer protected. In conclusion, you have an obligation to your constituents who are trapped in the nightmare of addiction to find a way out. I implore you to do the research, look at the science, understand the impacts that this bill has on your most vulnerable constituents. And if you're willing to look at that science and you're willing to choose people's lives over profits, you can only make one choice when it comes to vote on this bill, and that's to support. And in my written testimony, I've included the studies with their citations. Please do due diligence and read them.
Thank you.
Thank you.
Mr. Henningfield? Or is it Jack?
Oh. I'm Jack Henningfield, Vice President Research and Health Policy at Penny Associates, adjunct professor at Johns Hopkins Medical School, and I was at the National Institute on Drug Abuse for many years. I've been studying addictive drugs, treatments for addiction for 50 years, Kratom for about 10. Kratom is a public health asset. That is a conclusion of the Secretary of Health when they rescinded FDA's effort to block Kratom. And most recently, FDA has come in line with the National Institute on Drug Abuse on the statement that deaths associated with kratom, that only kratom use, are rare. And in most cases where they have been looked at, other drugs were involved. I was testifying here 4 years ago, almost to the day, and I wonder how many deaths might have been prevented by contaminated, adulterated, bad actor kratom products that are on the market in Maryland. Marylanders deserve better. Those that are using kratom to stay off of opioids deserve better. The Assistant Secretary of Health concurred with many of the experts in the field and the World Health Organization that the opioid-related addiction deaths and overdose deaths are more likely to increase if you take kratom out of the equation, because right now it is the lifeline for many people. Any death associated is horrible and tragic, but let's do what we can in the direction of regulation. This is a small step in the right direction. Many states are taking even bigger steps, and hopefully Maryland will be on the lead of it. The science, by the way, over the last 4 years since I was here has increased. And again, the FDA has moved away from the statements that it was making several years ago, more in line with the National Institute on Drug Abuse. It's not a heroin-like opioid by chemistry, nature, or addiction and death-like effects. Those are just facts, and the leading experts agree with those. Happy to provide you any science that you need.
Thank you very much. Next, please.
Good afternoon. My name is Dr. Kirsten Smith. I've been clinically or scientifically involved with kratom since 2015. I'm an assistant professor at Johns Hopkins University in the Department of Psychiatry and Behavioral Sciences, and I was a fellow at NIDA, National Institute on Drug Abuse, intramural research program for 4 years prior to coming to Johns Hopkins. I have over 50 peer-reviewed publications on kratom. I'm one of the few people in the nation to have evaluated and published on substance use disorder for kratom, that is to say, dependence and addiction on kratom. So I would be happy to answer any questions. I want to make clear the views expressed here are my own and do not necessarily reflect those of Johns Hopkins School of Medicine. But I am here to support passage of House Bill 1229. My work and the work of my colleagues has shown that many people have been using kratom-derived preparations and products since at least 2006 in the United States. This began with people using for chronic pain relief and as an opioid substitute, but as Dr. Henningfield has mentioned, the pharmacology of kratom is highly complex. It is not an opioid full stop. It has actions at many different systems in the human body. And so to call it gas station heroin is a remarkably simplistic and really, quite frankly, useless term. Tianeptine is maybe a different story. But with respect to kratom, people are now using it not only for substitution for opioids, alcohol, and sometimes psychostimulants, but increasingly using for the mild stimulatory effects that were discussed earlier. So using it almost kind of like a cup of coffee. We have people using it for enhancing energy, productivity, and meeting the needs of daily living, right? So people are not trying to take kratom products and not out in a car and not function. I have assessed recently and published in JAMA Network Open, again, a very well-respected journal, over 13,000 dosing or serving events of kratom products in a national sample. So in some respects, kratom use among most consumers is very boring. That said, we need regulation, including age restrictions. And so therefore, I'm very much in support of this, again, small step in the right direction. With respect to kratom products, Tianeptine probably should be scheduled, but that's another story and I don't have time.
Thank you very much, Doctor. Are there questions for this panel? Okay. Oh, I'm sorry. We have a virtual witness, Talis Abilene.
Yes, thank you. My name's Talis Ablins. I work as an attorney with MCT Law, and I'm here to personally share some of the dark realities of kratom that we've learned over the past 3 years, representing family members who've lost loved ones with tragic stories like you've heard today. Here are some of the important points the American Kratom Association and its funded scientists do not share when they support regulation. First, kratom is not regulated because it itself is considered adulterated under federal law. Every bag of kratom sold in a gas station or a vape shop is smuggled into the United States as products that are not for human consumption. This is because it is a new dietary ingredient. It was not in the food supply before 1994. And for those people who want to sell something like that, the rule is safety first. They need objective scientific analysis showing kratom is safe for human consumption. Otherwise, it is deemed adulterated. That is why there is an import ban on the importation of kratom for human consumption. The problem is not regulation, it is enforcement. Second, why doesn't the industry do its job and establish that the products are safe for human consumption? It's because they cannot. Recent studies by real unfunded scientists show that it is 63 times more deadly than other natural products on the shelf. Another study compared cardiac arrhythmias between kratom and other opiate alternatives like buprenorphine and methadone and found that it increased the risk of those dangerous arrhythmias 8 times over baseline, more than any other alternative for the treatment of opioid use disorder. The kratom industry is taking a page from Big Pharma and the nicotine industry, which is also affiliated with the Pinney Associates scientists. And they are now a multi-billion-dollar industry capable of hiring scientists and lobbyists and marketing experts. But I assure you that the clients who've lost loved ones, their loved ones believed the same story that you hear today from the American Kratom Association until they died.
Thank you very much, sir. Delegate Woods, you have a question?
Yes, thank you. Out of curiosity and in line with the question asked by my colleague, can you tell us where this kratom is being brought into our country from?
It is imported from Southeast Asia. It grows on the leaves of a tree there because it's kind of like a white collar crime when they import it not for human consumption. It's not illegal to own or use, the consumers, they're not committing any crimes, but those who are distributing and importing it, we have found the documentation showing how they get it into the country, and they have bills of lading and documents that show it's like it's incense or plant food, and they code it at Customs and Border Protection data entry. They code it as not for human consumption, so the FDA is unable to enforce its own regulations.
Delegate Lewis.
Thank you, Madam Chair. Thank you all for your testimony and your work. Whoever is best to answer this question, I'd like to know if we had a more comprehensive, accessible, well-staffed mental behavioral health system in the state of Maryland with an array of effective, clinically approved medications and psychotherapy and other interventions, would we see less kratom use and less use of the other product that we're talking about? Because the theme that I heard from the 2 moms who'd lost their sons was that both of their sons were seeking relief from mental behavioral challenges, and both of their sons discovered this very low bar to entry, product that they were told would help their mental behavioral symptoms. So can you help us understand that?
Yeah, so I'm actually a licensed clinical social worker. I do not currently practice, but I am trained in this area. And this is something I spent a lot of time thinking about. I actually first encountered kratom working in an addiction treatment center with a person who, this was an abstinence-only program. They did not prescribe buprenorphine or methadone. And this young man came to me and said, I'm using this tea from Asia, and it's called kratom. And I'm like, is this a synthetic drug? What on earth are you talking about? And he's like, it's helping me feel better and good, but not high. And it's helping with my opioid cravings and anxiety. And I'm like, well, who cares? This is boring, right? But for this man, this is what was helping him attenuate his opioid cravings. Now, he was in a treatment program, but it was not necessarily an evidence-based treatment program. They did not prescribe medications. They didn't have behavioral therapies. And I think to answer your question directly is yes, 110%. All of the systems of care in Maryland and in the United States need more funding for evidence-based interventions. I think people are looking for other alternative things, in part because the systems are so maxed out. That said, there are people who do have access to treatment and who do not tolerate buprenorphine or methadone at all, or it's too much, or perhaps people in many cases are not using Kratom as an opioid or alternative or an alcohol alternative or for mental health problems. So you have kind of two populations within the Kratom consumer population, some who use to self-manage issues related to mental health and substance use disorders, and some who've never had any of those issues that would be addressed by increasing funding for the systems of care. So I think it's, yes, we need more funding, but also we need to recognize that every patient is different and that they're going to be trying to seek out things. If they're not getting what they believe to be adequate care, they're going to get desperate and try anything. And so I think it's regulate and fund on both fronts.
Can I just add briefly to
Actually,
that?
we're gonna,
For a lot of people,
we
sorry.
actually only allow one person except our chair to answer a question. Delegate Martinez, if
Madam
you'd like to
Chair.
follow up with.
And this is for the
Okay.
panel here with us. I take our responsibility of protecting our children and young folks really seriously. I think all of us here in this committee do. And I'm looking at the states that have banned these substances. And I know people that serve in these legislatures, and they have that same mantra as well. Can you, I guess, speak to why we shouldn't put regs or bans on these products? Because I'm not truly understanding why we wanted to get this out of the hands of young people, and particularly this low barrier of entry. I mean, anybody with $9 can get some of these products. We should put stricter regulations on consumption and who has access.
Yeah, I think most of us in the field support minimum age. And when I was here 4 years ago, that was where we left it. We also need more regulation and oversight over the product so that the bottom feeding, quite frankly, marketers are not on the market. But for many people that have access to drug treatment and have been in formal drug treatment, say Kratom worked better or was preferred for them. And so, again, the answer, as Dr. Smith said, is yes, yes, yes. But right now, we know that for many people, Kratom is the preferred way to, as many of them put it, get my life back. One colleague at Hopkins' son story is typical. He almost died of overdose of heroin. He got into buprenorphine, a drug I helped develop and I'm proud of, but it wasn't right for him. He hated being on buprenorphine. He tried drug-free treatments. He hated that. He couldn't live. He tried Kratom, and over about several months, he got his life back. And his mother, who's an board-certified addiction medicine specialist at Hopkins, said, I was skeptical at first, but he got his life back. And that was 5 years ago now.
Okay, thank you. Seeing Delegate Taveras popped up while I wasn't looking.
Sneak up on you. Thank you, Madam Chair. Sorry, to the subject matter expert, can you speak to the issue of why there is a conflict or an inconsistency in the literature regarding at least the second drug with regards to abuse, addiction, and withdrawal? They said that there was a 2018 study in Madrid that reported that it did not produce dependence or withdrawal, that this was used for an antidepressant, a major antidepressant from since the 1980s.
Yeah, so you're speaking to Tianeptine, which I have published on, but I am Kratom is what my expertise is in, though I am working on Tianeptine now, both collecting samples for analysis and doing a systematic review. And I can say with respect to the literature, as an atypical tricyclic antidepressant with mu opioid receptor activity, it has actually been very helpful and effective for many patients in countries where it is approved by the medical systems for use in depression and treatment resistant depression. However, there have also been signals of dependence and misuse and abuse of those prescriptions. So the abuse potential with Tianeptine is certainly there for some, but it's kind of like any substance, right? It's the intention of the person who's using it. If someone is really wanting to use it as prescribed, by their doctor and taking it as prescribed, they're going to probably be getting the effects with fewer abuse potential. If someone's looking to achieve a high, well, they're not going to be following the doctor's orders. And so I would say most of the literature is pointing in the same direction. And to be very clear, the tianeptine that is prescribed in these other countries is not necessarily what's being prescribed, or sorry, what's being found in gas stations or these smoke shops. People have said a lot about this stuff, right? Or kratom or tianeptine, lumping it together like this stuff. Well, we don't know what's in each bottle. So you could pick up 10 bottles of tianeptine in a store around here, and it could have 10 different things in it. So this gets back to the whole point of having a bill and making sure that people have to substantiate what it is they're selling, because quite frankly, people might be saying tianeptine, and they could have, again, phenibut in that, or many others, or a proprietary blend. And so the consumer has no idea what they're taking. So I think all of us are very much in favor of regulation, particularly with kratom and with tianeptine. I'm not sure that there's really any reason for it to be sold in this state, in my opinion, given that we do have a lot more data to support that it is, at least whatever they're selling here and calling tianeptine, pretty habit forming.
Thank you. I want to thank you all for your time and your testimony today and for your patience as we work through the bills. I'm just asking one more time, is Ryan Burrows here? Okay, Ryan, you want to come up? And he's
Thank you to the committee for your time. My name is Ryan Burrows. I'm the executive director with the American Kratom Association. The American Kratom Association advocates for the more than 15 million kratom consumers to have access to safely manufactured, age-restricted, fully tested, and properly labeled kratom products that provide adequate instructions for safe use. This speaks directly to the efforts of Bill 1229, the Kratom Consumer Protection Act. Unfortunately, until just the past few months, the FDA has engaged in a more than decade-long anti-kratom campaign on the mistaken belief that it is highly addictive and potentially deadly. The FDA's own science is now directly contradicting their false narrative. The FDA has submitted 2 separate recommendations for the scheduling of kratom as a Schedule I substance, both of which were rejected for lack of evidence and data, and a petition to the UN Commission on Narcotic Drugs for international scheduling of kratom, which was unanimously rejected by the Expert Committee on Drug Dependence for insufficient evidence. On February 8th, just a couple weeks ago, the FDA was ordered to present evidence and documents before the U.S. District Court for Southern California on their claim that kratom is dangerous. The FDA refused to attend the hearing, and the U.S. Attorney explained to the court the FDA has not yet determined whether kratom is dangerous. The fundamental claim that kratom is dangerous was most recently disputed by a human dose finding study conducted by the FDA itself, which found that there are no significant adverse events observed even at very high doses. Only 2 of the participants experienced nausea after consuming 12 grams of kratom. Just to explain, that's 24 capsules in this study that had to be swallowed in 5 minutes. I personally don't know that I know I would have nausea for sure if I had to do that. The finding was that, quote, kratom appears to be well tolerated at all dose levels. This safety study has cleared the way for a human abuse potential study that will be completed by the FDA over the next couple of years. The Kratom Consumer Protection Act has been passed in 11 states. In addition, the Federal Kratom Consumer Protection Act was introduced last year. We appreciate the efforts of this committee to continue to keep properly regulated kratom products available in the state of Maryland. Over-criminalization in this country is rampant. Regulation is critical. And thank you for your time and consideration of the bill.
Thank you, Mr. Burrows.
Thank you.
Any questions for this witness? Thank you. Delegate Martinez.
Thank you, Madam Chair. Something you said kind of struck my interest. You spoke about a 10-year campaign that the FDA had on you all. What makes you all so special that the FDA would resource 10 years to attack you?
It's maybe not necessarily just kratom. It's dietary supplements in general. And that's where the DSHEA Act was formed. So the dietary supplements actually have a pathway.
And just to be clear, you're in a position of support of
yes, ma'am.
1229.
Absolutely, and I would say more regulation than what's in it now. It should have more than just an age limit.
Okay, great. Thank you very much. Seeing no further questions, that completes the hearings on bills 1229 and 1230. Thank you all for your
Right,
patience.
thank you.
And for your testimony today. Thank you.
And I want to thank the committee for being flexible as we play musical chairs here. So if I made the next, we have Delegate Bartlett, House Bill 969, death certificates, course or manner of death determination, requirement after change or correction. And will you be so kind, Delegate Bartlett, and bring in, oh, actually you have favorable with amendments, so you're it for the favorable.
I am it with for the favorable because I am amending it. So we're all favorable.
All
with the
together? I was gonna say you're enough, but why don't you bring Marguerite Morris and Grace Merrick? And then we have a favorable with amendment virtual. Can you please bring the person up? And Delegate, you can get started.
Thank you, Madam Chair. We also have an amendment. We have hard copies of the amendment because unfortunately, I don't think the digital copies made it to you all in time.
Did you provide it to the committee,
I
Delegate?
have not because I didn't have permission yet, but I have my chief of staff at the ready.
Okay, so may I ask you a favor? Will you be so kind and go to the committee next door and make sure that Cassandra gets it and she brings it to the whole committee? Thank you
Okay.
so much.
Thank you, Madam Chair.
And then also the digital one, just make sure the council gets it.
Certainly.
Thank you very much. And welcome to our committee. How are you?
I am doing great. It is good to be back. I miss you all. I haven't been back since yesterday.
And you are supported by a sea of pink today behind you.
Pink and green.
Welcome
Yes,
to the
yes.
committee. Go ahead.
Thank you so much, Madam Chair. So I am before the committee to introduce House Bill 969. And you may recall, some members may recall that I've been here before on the cause and manner of death when it comes to the medical examiner's office. So at first we did a bill to change to allow a person in interest, usually a family member, to appeal the cause and manner of death as established by the medical examiner. Unfortunately, both were not allowed originally. Thank you very much. You passed that bill. It is now law. Families are appreciative. And then we came and we needed more time because after losing a loved one, 60 days was what was allowed, and that wasn't ample time. So we needed more time. Thank you very much. You passed that law. I come before you again because the more I learn, the more I know, right? So last year, there were 1,936 deaths that where the ME deemed those to be undetermined. And over the past 2 years, there were 11 families or person in interest who appealed that decision, and 6 were changed to some other cause of or manner of death. So we're talking about 6 cases over the past 2 years, not a lot. So what House Bill 969 does is says, okay, so now we've got the families in a good position, or starting position, I should say, where they can actually, they can appeal, they can get a decision. The decision can change the death certificate based on winning the appeal. So after all of that is done, you're almost left with, okay, I got the death certificate changed, but what's going to happen with the police investigation? Where does that stand? So that is what the amendment changes, and that is what House Bill 969 changes. Now, I appreciate being able to wait in the wings a little bit because while I was there, I was on the phone with the amendment office again, and I've been on the phone with them quite a bit, and they've been so kind to work with me on this bill. You have an amendment before you, and it should be Amendment 593520. This amendment says that we start generally where we rename the bill to my witness's daughter, and she's gonna talk about her unfortunate situation. So we renamed the bill Catherine Morris Death Reclassification Act. We also speak to law enforcement and, generally define which agencies we're talking about. So we're not talking about the National Guard or the military. We're talking about only, the sheriff, the security force or police force. So then we get into Article 5, Section 3-531. And there, B, under B, we state if a law enforcement agency is notified by a medical examiner, the law enforcement agency shall. Well, we had it lukewarm. And what it said was, in this amendment, take the notice into consideration. And the reason why it said that is because we have been trying to overcome the hurdle of what we as legislators can do to mandate something on local law enforcement. So that's not quite our job. It's a step a little too far. But what we can do, because the authority lies within the medical examiner, is, and this is where an amendment to the amendment will be coming forth, because I literally just got off the phone with the amendment office. It will read as follows at Section B, that the law enforcement agency shall reopen or reinvestigate the investigation upon notice from the medical examiner. So if the medical examiner says you need to we advise that you should reopen this case, then therefore law enforcement can do it. And I have spoken with the Office of the Medical Examiner. I've been getting data from them, and they also reference the Health General article 5-311C, and it states that the I'm starting at shall deliver to the state's attorney, it's the ME, shall deliver to the state's attorney for the county where the body was found a copy of each record that relates to the death for which the medical examiner considers further investigation advisable. So we are incorporating that authority in the amendment to the amendment. I hope that wasn't too confusing, but the beauty is you have the opportunity to ask questions. We also state that the state's attorney, has to meet with state's attorney and the local law enforcement has to meet with the family if the family requests to provide information as to why the case is not being open, and that the family receives upon this change because they've appealed it and they brought in information that has passed the standard to change the cause and manner of death, that they get a copy of that death certificate at no cost, of course. So those are the things that we have in the bill, and that is the amendment, and I've given you orally what the amendment to the amendment is going to be. And I appreciate your patience in letting me explain all that and walk that through. And I of course request a favorable report. I didn't introduce myself, but I'm Sandy Bartlett from District 32, Anne Arundel County. Thank you very much.
She is Vice Chair Bartlett.
Yes, Vice Chair Bartlett.
Who's next, please?
I can. Hi. If you all don't understand why this is so important, I'm wearing her picture. And I actually started to bring one that I could set here, but I didn't think it would be allowed. So my name is Reverend Marguerite Morris. I'm Kathy's mom, and I'm in favor of House Bill number 969, and I'm from District 33. My Kathy was found dead in a car at Arundel Mills just 2 weeks before graduating the University of Maryland. Her cause of death was carbon monoxide toxicity from charcoal grills lit in her car. She was a victim of marital fraud, and her spouse had a $100,000 life insurance policy on her with no suicide clause. Records show that an inexperienced responding police officer Googled what appeared to be the cause of death while Kathy's body was still in the car, and it came back a method of suicide or murder. He opted to choose suicide. Police allegedly, and this is from an expert testimony of a senior law enforcement officer who supported us in the testimony, that haven't changed, that they had made several serious investigative errors and subsequently went to cover those errors. The first was referring to the cases at the scene as a suicide, and therefore not properly processing the scene as a possible homicide. Investigation was closed in 48 hours. The medical examiner on Dr. David Fowler's watch followed suit, using the word suicide at the scene. We fought this ruling for a decade. Myself and experts from around the country, one of which you will hear from, a forensic pathologist out of Texas, worked tirelessly bringing to light numerous inconsistencies and unanswered questions. After 5 years under Governor Hogan's watch, we were finally granted an administrative hearing that ended in our favor. Order amount of death changed to undetermined. It now reads that they do not know the manner, the date, nor the time of my only child's death. And they're not trying to find out what happened to her. The administrative AL judge issued a 58-page opinion. The Maryland Secretary of Health designee, Mark Davis, affirmed the findings of fact and conclusions, and it stated the following. The ALJ had thoroughly analyzed the testimony of each witness and raised numerous points the OCME and the Anne Arundel County Police Department should have considered in their investigation. The ALJ acknowledges that the medical examiner finding of suicide could not be said to be an error at that time, but myself and others had gathered an abundance of evidence that weighs heavily against the determination of suicide. Despite additional evidence, both agencies declined to change their findings to undetermined. They did so in the face of the ALJ called in an abundance of inconsistencies present in the case. Mr. Davis and the ALJ agreed that changing the manner of death to undetermined would permit some inconsistencies to be resolved. We returned to police making the simple request that the death be listed as unsolved. This would not make law enforcement, but allow law enforcement agencies to pursue more information and possibly encourage the public to provide additional information. However, and thank you for your patience, I'm down to the end here. In 2022, when approached, Chief Amala Watt said no, disregarding both judges' noted expectations and amid a myriad of conflicts of interest, stating that the case after a decade was administratively closed in 2012. That crushing, unjust outcome revealed that there is a need for independent oversight that oversees issues related to death reclassifications. We urge you today to pass HB House Bill 969 in its entirety. We ask that it be named the Catherine Morris Death Reclassification Act, honoring my child and giving hope to other families and preventing stories like this one from happening again. Thank you for your patience.
And thank you, Reverend Morris, for being with us today. Thank you for having the strength to present it and for sharing your story. It really matters, and the committee takes it really seriously. And you know, I pray for comfort and peace. Next, please.
Hi, my name is Grace Myrick, and my address is I don't have to, okay then. I am Kathy Morris' grandmother, and this is my daughter, Reverend Morris. I have been with this situation from the time that the death of Kathy up until now. I have attended a lot of police conferences, including them coming to the home of my daughter and her husband. And I have attended a conference with the police here in Annapolis. And also what hurt me the most were when the state attorney, I think she was new on the job, came into the conference, and it's like she acted like that, you know, to pass it over like it didn't really matter what was being said. And that bothered me a whole lot, you know, but my biggest thing I was thinking about was, why was this car that Kathy was found in, why was it taken to the place they take a car to and released to the family without released to the family, and the stove that's supposed to have caused her death was still in the car. Other items of her were still in the car. Why would the police have this car and let this car be released without examining it? That still has lingered in my mind all these years. Why, if you're doing a thorough investigation, why did you release a car that might have evidence that you could have, did something with? I have had death in my family. My son died, and the reason why he died because of inflammation of the heart and the brains. My great-grandson died last year, and he died from brain tumor. My husband died, and he died from a stroke. So those are resolved issues of why a person have died. And I would like to see closure brought to Kathy. What happened to her, so we can bring closure to this family, as well as my daughter or such. Her father died a year later from heartbreak and his job. He was military for 30 years, Air Force. He worked at the NSA, and they was told on his job not to discuss anything with Joe Mars, which is my son-in-law. Why, I don't know. But my most important thing in supporting this bill, that maybe by chance we can get closure to what happened to Kathy. Kathy, well, I call her Kat. That was her nickname. And me and Kathy, we had this thing about jigsaw puzzles. Me and her was partners in jigsaw puzzles. I miss that. I miss my granddaughter. So hopefully, that this committee will help us bring closure to what happened to Kathy. And not only, the family of many have encountered this situation, circumstances, and no one understands like another person when something happened to your child. No,
Thank you
very much.
Thank you and I'm so sorry for your loss. Truly sorry for your loss, both of you. And thank you for being with us today and sharing her memory. I am going to open it up for questions now, unless you want me to call. I think that's it. There's Leanne Grossberg. Why don't I call her and then we open it up for questions?
Thank
Will
you,
you
Madam
be
Chair.
so kind? You're welcome. And unmute yourself, please. Thank you. Good afternoon.
Good afternoon. I'm Dr. Leanne Grossberg. I'm a board certified forensic pathologist, medical examiner, and I've been practicing forensic pathology for 25 years. And I am here to express my full support for House Bill 969. Deceased individuals obviously cannot speak for themselves, and forensic pathologists, medical examiners, were physicians. We undergo years of medical school, pathology residency, and forensic training in order to be able to speak for the dead and to determine the cause and manner of death. However, forensic pathologists in many cases have to rely on investigations by law enforcement. But if the investigation is faulty or incomplete, the manner of death may not be correctly determined. And I was hired by Reverend Morris about 5 years ago to review the cause and manner of death for her daughter, Kathy Morris. And it became immediately apparent to me in reviewing her case that there were multiple factors that were suspicious for homicide. And it's well known in forensic pathology and in law enforcement that it is possible to stage a homicide to look like a suicide. However, due to assumptions by law enforcement that it was just a suicide and lack of any further investigation, Kathy Morris's death was then classified as suicide by the medical examiner. But due to all the appeals and the hard work by Reverend Morris and others, And due to the uninvestigated suspicious circumstances surrounding Kathy's death, the manner of death was then later reclassified as undetermined. But despite the amendment to undetermined, which to me means that the case is now unsolved, no further investigation by law enforcement has yet occurred, even though it's been changed to undetermined. And throughout the course of my career, I have seen other situations very similar to Kathy Morris's, where more investigation is needed and it doesn't occur. I'm almost done. Therefore, it is without reservation that I am in full support of House Bill 969 involving death certificates and the requirements after a death is reclassified. And I'm not being paid for my time here today. I am here because this bill is crucial in ensuring that the death investigation process be performed in the manner that all decedents deserve. It is my strong recommendation that you pass this bill in its entirety. Thank you.
And thank you very much for being with us. I am going to open it up for questions now to the committee. Are there any questions for this panel? Seeing none, I do have delegate, if I may, and you know that this is a common question, especially this year. Given your amendment, right, you now are bringing in more stakeholders with your amendment. So I would recommend if you can reach out to the state's attorney's office, the sheriff's office, right, law enforcement, because you're bringing them in with the amendment. And then the Office of Medical Examiners, the Department of Health. While you were talking, I was paying attention, but I was looking for the letters and I don't see it there. So, you know, that it will come up in subcommittee. I just want to be ready. And if you could do that, please, and let us know as soon as you do that, okay?
Certainly.
My pleasure. Any other questions or concerns? Thank you very much. Thank you for being with us today.
Thank
Again,
you.
so sorry for your loss.
Thank you.
Okay. And this actually concludes the bill hearing on House Bill 969. Next, we're going to go to House Bill 739, Delegate Vogel, followed by Delegate Kramer, sorry. And I'm still pronouncing it incorrectly. Grammar. I just realized that. Sorry. Where's Delegate Vogel? Well, let's go to Delegate Grammars. All right. Delegate Grammer, welcome to the committee.
Thank you, Madam Chair. If I could bring up a couple panel members.
Absolutely.
With your permission, I'll get started.
Absolutely.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. For the record, Delegate Robin Grammer to present House Bill 804. House Bill 804 removes psychiatric services from our Certificate of Need laws. Certificate of Need laws are needlessly preclusive to the needed expansion and delivery of healthcare services in our state. Many states have moved to either greatly reform or even remove Certificate of Need laws completely. Several federal agencies have reinforced the move to do away with or reform Certificate of Need laws via multiple federal studies. The one issue we hear about in every committee is mental health and the lack of available beds to service the needs of our state. I have discussed with many of you the issues experienced by Turnaround Incorporated, who serves victims in Baltimore County and Baltimore City. It has taken 3 years for Turnaround to expand the number of beds they offer to victims. We appreciate the suggestions of the chair in relation to this bill, and those calls have been made. I found the discussions that we had very formative. Those conversations also reinforce the need to greatly revise our Certificate of Need laws, which in many cases had certificates denied, and those denials were exceptionally arbitrary. House Bill 804 makes a small but clear change to our Certificate of Need laws by removing psychiatric services from our Certificate of Need scheme. I sincerely believe if we take the path taken by other states, we would find expanded access with little cost to quality. Thanks for the opportunity to present House Bill 804. Be happy to take questions, and I'd ask for a favorable.
Thank you, Delegate. Next, please.
My name is Paul Schwartz. I am State Legislation Chair for the National Active and Retired Federal Employees. With the alarming number of suicides in this country, especially among our teens, let's do something to make mental health care more available not less. With the incessant claims after every mass shooting in America, especially in our schools, that something needs to be done regarding mental health, let's make mental health care more available, not less. HB 804 is an attempt to do just that by exempting psychiatric healthcare facilities and psychiatric and mental health services from certificate of need requirements and the restrictive bureaucratic burden it imposes, limiting treatment availability. Roughly 10% of our state's older adults, for example, experience Alzheimer's disease and related dementias, while many older adults experience subclinical mental illness. And let me emphasize, this is not about standards. Standards for mental health care facilities should apply to facilities, regardless of whether a certificate of need is issued or not. After hearing all the testimony about Kratom, and at a time when there is a mental health care crisis in this country and a need to expand mental health care availability, please give a favorable report for HB 804. Thank you.
Thank you.
We did have one other person from the Institute of Justice online. I'm not sure if they're there.
Actually, I'm looking and I just saw, there's only two people, there's one, actually one virtual. Can you go online, please? Thank you.
I'm not sure if they're there.
Actually, I'm looking and I
Good
just
afternoon.
saw
Good afternoon.
Will you be so kind and give us your testimony? Can you go? You have to turn off your YouTube channel. So we
Can
don't
everybody
have
hear me?
feedback. Yes, that's better. Thank you. You can get
Great.
started.
Thank you. Good afternoon, Chair Pena-Melnick, Vice Chair Cullison, and members of the Health and Government Operations Committee. Thank you for the opportunity to provide this testimony in support of the Certificate of Need reform proposed by HB 804. My name is Alistair Whitney, and I'm a legislative counsel at the Institute for Justice, which is a nonprofit public interest law firm that for decades has researched and advocated for con reform through litigation and legislation. Now, we encourage the committee to support HB 804, which would eliminate the con requirement for psychiatric healthcare facilities and psychiatric and mental health services providers. This bill would allow for the expansion of services in underserved areas, increase access to healthcare providers, encourage investment in community-based healthcare facilities, and reduce costs for patients. Research shows that these restrictions limit the number of beds available for psychiatric patients and increase costs, and impede the development of new innovative treatment programs. One study even found that states with con laws targeting psychiatric services have up to 20% fewer psychiatric hospitals per 1 million residents and 56% fewer inpatient psychiatric clients per 10,000 residents. The study also found that such con laws result in hospitals being significantly less likely to accept Medicare. As a result, individuals in need of mental health services experience delays in receiving care, which exacerbates illnesses and increases the likelihood of adverse outcomes. The need for accessible and comprehensive mental health services has never been more pressing, particularly in the wake of a devastating pandemic. Mental health conditions affect individuals from all walks of life, transcending age, gender, race, and socioeconomic status. Yet despite the prevalence of these conditions, many Marylanders face significant barriers in accessing timely and appropriate care. This bill represents a meaningful step in the right direction for con reform in the state, and it would align Maryland with the positions of federal agencies and other states that recognize the burdens that con laws place on patients and providers. If I may just quickly finish, Maryland should make it easier, not harder, for folks to get critical mental health treatment. We urge your support for this bill. Thank you for your time and thoughtful consideration of this issue.
Thank you for being with us today. I'm going to open it up now, Delegate, for questions, okay? Are there questions? Delegate Chisholm?
Thank you, Madam Chair. And I just
You're
want
welcome.
to ask a question so you can get a chance to respond, because you have some unfavorables. And one from the Maryland Healthcare Commission that says the real problem is not the CON. The problem is lack of workforce. And then also they say in their letter that the CON process is not a major bottleneck. In fact, they've streamlined and accelerated the CON process in recent years. If you want to speak to that.
Yeah, at the advice of the chair, we called around to some of the folks, the HSCRC, and really had some frank discussions about not only turnaround, but the process in general. And you know, what I learned from all of this is the whole certificate process is a disaster. We discussed some of the cases where actors who are looking to come into the space and provide mental health services, and I focus specifically on that, were shot down by really the big players in the space, quite arbitrarily, for quite arbitrary reasons. But in you know, my specific focus, I talked about turnaround quite a bit. And what most people don't realize is when you have these groups, and for the record, turnaround provides victim services for domestic violence, rape, things like that. And they begin this process by saying we could file as one of several different kind of organizations, and they try and figure out how they can get across the finish line. And when they did that, they considered the certificate of need, and they avoided filing certain ways just to avoid that headache. And they still got hung up for 3 years. So, you know, I think we would all agree that for any business organization, whether it's healthcare or not, there's going to be a permitting scheme, there's going to be a licensing scheme, and it should be that way. And permitting and licensing should do 99% of the work that we need them to do, even when considering healthcare facilities. But if you look into this more and more, this whole certificate of need process, it's a disaster. It's used to keep competitors out of the space. And I think, you know, we owe it to the people of the state to do something to address this mental health crisis that we hear about every day. We hear about it in every committee. We hear about it at the dinner table and with our family members.
I just want to say it doesn't help
It's
in
only
any
one
way.
person
Yeah.
in this committee, one person. There could be a follow-up if anyone wants to ask a follow-up. Delegate Lewis.
Thank you, Madam Chair. I was just wondering if Delegate Grammer's panelists had any follow-up remarks.
She's asking you.
Oh, I'm sorry. Say that again, please. I thought it was.
He's giving you a chance.
Oh, yeah. The bottom line is it doesn't help in any way. All right. So even if it doesn't cause as big a problem as we're saying it does, which apparently it does, how does it help expand the coverage? It's more, the certificate is more about having too many operations in one location. Well, to me, the more you have, the more opportunity you have for covering the mental health needs, and it is a crisis. As I said in my testimony, between the gun shootings, and they always say it's the mental health issue, it's not the guns. The suicide rate is going up. So anything that helps address that. The thing we heard just this morning about the Kratom, all right, they said they need more facilities to help identify, to help those people with mental issues before they go to the different drugs. So anything that expands the availability of mental health facilities is something that we should pursue. While I have the opportunity to address something, I want to address something that you had raised at 340, HB 340, which is if the bar owner makes a profit at $4 a beer, right, he's going to stay here. If he's not making a profit at $4 a beer, then it's up to the board to determine if it should be raised to $5 a beer, $6 a beer, or keep it at $7 a beer. I waited a long time. I want to say that when the testimony for 340 was, I got the opportunity now. Thank you.
You may not get another follow-up. All right,
If-
Delegate Bagno, followed by Delegate Taveras.
Thank you, Madam Chair, and thank you for this bill. I just wanted to give you an opportunity, Delegate, to clarify, because I think there are a multitude of opinions on certificate of need and the value of that. But given your comments on this panel, I just wanted to clarify that this bill is just speaking to an exemption for psychiatric beds, because one of the positions of opposition was a concern that that this would be a loophole to build capacity for inpatient psychiatric beds that then would be converted to other service lines. So I wanted to ensure that was not the intention. of
That's
this bill.
correct.
Thank you.
And I know that you stated, Delegate, that you met with, I believe it was the HSCRC, but it was really the MHCC.
You may be correct.
Yes, so we just want the record to be clear on that. And thank you for reaching out to the names that I gave you. I
Yes,
appreciate
thank you.
it. We have next Delegate Taveras, followed by Hutchinson.
Thank you, Madam Chair. I'm just trying to thank you for the bill. I'm just trying to understand why psychiatric care is being taken out versus intermediate care that can be taken care of in a clinic. I don't know.
Yeah.
I mean, and the reason why I'm asking is because when I look about in the streets, I mean, the folks that haven't been tended to are not the ones who can be treated in a clinic, but rather those who are walking the streets and need mental health care and should probably be properly treated in a facility because of changes in our policies in the 80s. So I'm just trying to understand why
Yeah,
psychiatry.
it's a great question. And, for me, I really call certificate of need into question across the board. But I like to bring small bills where it's workable. If we all agree it's an issue, as opposed to just striking all our certificate of need laws. And I think, this is a small way to start to talk about the issue and enter the issue. And that's why the bill's structured the way that it is. But there's no doubt from the conversations that I've had, you could look at the sponsors of the bill. I've talked to so many people about this very issue, and everybody says the same thing, and we have the same problems across the entire state. But I appreciate that question.
Next, Delegate Hutchinson.
Thank you, Madam Chair. Thank
You're
you,
welcome.
Delegate, for bringing this to our attention as well. I sort of been following CON issues a little bit, and last year the MHCC director did talk about the fact that they were going to streamline, and I think you mentioned this, said that they have streamlined, and I'm not so sure they've streamlined yet, but you made a comment that said it's a disaster right now.
Yeah.
Can you expand upon that?
Yeah, I have not seen in the discussions that I've had this year that there's any streamlining. I believe it was 2017, there was a study that talked about that. I've read it. Did not seem to be substantive to me. The disaster. Let me start here. If you have a private actor that comes into the space and they say, I want to offer mental health services, and Shepherd Pratt comes in and says, we don't think that they should be allowed into that space. I mean, shouldn't we have at least some kind of market forces to chase a need? And what you have are the biggest fish in this space that will come in and they'll just blow up the little guy. So, it's unfathomable to me that we can for years talk about this problem, and we see it. We see it all over the place. We see it in our own communities. And that we would, it's frankly, I mentioned that the chair, advised I have some discussions, and we talked through a lot of the cases, a lot of the denials, and a lot of the cases it was, well, we challenged the idea that they have funding. Well, that's not really the way the market works, where your competitors come in and they challenge the idea that you can funding or that in this region there's a need. So I challenge it altogether from the cases we discussed and the issues I have in my jurisdiction. I think we need some kind of more free leeway for people who are interested in providing these services to come in and take a shot at this. And I think it's un-American that the biggest institutional players in a space could come in and just use this process to blow you up. Thank you.
Any other questions for this panel? Seeing none, thank you very much.
Thank you.
Delegate. Appreciate it. Next, we have a panel of unfavorable, and that is Jeffrey Grossi, Ben Stephan, Winnie Hawk, Peggy Townsend, Michael Reka. Will you be so kind and come up, please? Oh, did we call them? Who would like to get started?
Madam Chair, I'd like to get started. Ben Stephan, Executive Director of the Maryland Healthcare Commission. I kind of don't know where to start, but let me be clear. The Healthcare Commission met with Turnaround as soon as we were contacted. What I learned was that Turnaround wanted to establish a group house for individuals that were victims of sexual abuse and children that were subject to trafficking. Not a CON issue, never been a CON issue. We explained that to the individual constituent. We did volunteer to help.
If I may, and I usually don't do this, but for clarity, explain why it's not a CON issue, please.
Because group homes are not within the scope of the CON authority.
So you do not regulate them,
We do not
correct?
regulate.
That's what,
group homes.
yeah, just want to be very clear of what you regulate and you do not. Go ahead.
Correct. So the constituents issue was relevant to other state agencies and county government, and we tried to point that individual in those directions, but we have no authority over that. But I want to really turn to the legislation itself and talk about why we oppose it. We believe that this is the basis for it is not anchored in fact, and we also note that there are three key reasons for why this legislation is not needed. First, actually, when you look at licensed bed capacity, psychiatric licensed bed capacity from 2019 to 2022, the number of licensed beds went up from 714 to 845. In acute care hospitals, in specialty psychiatric hospitals, it went from about 400 to 480. So there is some expansion. We recognize that it is more is needed, but it is not a matter of unavailability of options. Secondly, we have streamlined the CON process. We are now operating under a 90-day rule for turning around a CON application after an application is judged complete. And third, we think that there's also opportunities for hospitals to move forward with expanding psychiatric beds today, because if their licensed capacity is greater than their physical capacity, they may have an opportunity through an exemption process to expand those beds. It's clearly an issue more complex than simply beds. There are issues with reimbursement. There are issues with workforce, and actually the counterintuitive outcome is that things could be made worse if we simply willy-nilly added beds across the state, because our workforce is not adequate and our reimbursement structure is sadly in need of some additional modifications, much like psychiatric reimbursement across the country. It's not unique to Maryland. For this reason, we would urge an unfavorable response. We think that a willy-nilly approach to CON reform is not the way to go. Thank you. Happy to answer questions.
And I want to thank you. When I met with a delegate, and I do thank him for meeting with me ahead of time, I suggested he meet with you so you can help that company, and thank you for meeting with him. I appreciate it. Next, please.
Winnie Hawk. Good afternoon, Madam Chair and members of the committee. Winnie Hawk here. I am the director of the Center for Health Facilities Planning and Development, and CON is a division in my center. So I'm actually here just to answer questions and support Ben. So I really don't have anything to add. I did want to talk about the streamlining of the CON. The regulations went into effect to streamline how these projects are, these applications are processed on December of 2023. We've just received our first certificate of need under the new regulations, so we'll see how it goes. But I just want to say that for the first time in anyone's memory at the commission, there are no pending certificates of need on the docket at the commission. So we do think that it's been streamlined and it's working well. So thank you.
Wonderful. Who's next?
Madam Chair, Madam Vice Chair, members of the committee, thank you for the opportunity to testify today on House Bill 804. For the record, I'm Jeff Grossi, Chief of Government Relations at Sheppard Pratt. I'm certainly not ashamed to say Sheppard Pratt is the nation's largest private nonprofit provider of behavioral health services. With more than 400 licensed inpatient beds, 160 programs, 380 sites of care, and through telehealth, Sheppard Pratt cares for every Marylander. and is the only hospital that receives patients from the emergency department of every hospital in the state. Specifically here, the CON process is in place to ensure that the quality of care provided to some of our most vulnerable populations is not compromised and that limited resources are appropriately utilized. Shepherd Pratt has applied for and received CON approval many times over the years to expand access to behavioral health services across the state, including most recently to open up our new inpatient hospital in Elk Ridge, Maryland. Although the process can extend the time required to open a new site, the process does strike that appropriate balance to ensure the clinical, operational, financial, and really importantly, quality plans of the organization are all sound and in the best interest of patients. While Shepherd Pratt is certainly supportive of expanding services and access to psychiatric care and has submitted several proposals to the state to do so, we are concerned that eliminating the CON process could compromise the quality of care being provided to Maryland residents. Shepherd Pratt thanks the committee and respectfully requests an unfavorable report on House Bill 804.
Thank you, Peggy.
Thank you, Madam Chairman. Peggy Townsend on behalf of the Maryland Hospital Association in opposition to this bill. Just going to take you back a step. The reason we have certificate of need is to make sure we don't have an over proliferation. And that's pretty important in Maryland because we're the only state that has a rate setting system. So if you have a proliferation, it can lead to dilution of staff for sure, which raises the cost, dilution of the professionals in the field. But we also have to be concerned because that raises costs for everyone. If you have too many, the overhead is spread across too many places, and that makes the costs go up. And that impacts the hospital rate setting system and what we can charge. So there is a link between the two. And for those reasons, we would urge an unfavorable.
Thank you. Is Michael here?
Yes.
Okay.
Good afternoon. I'm Dr. Michael Reka, and I'm here to represent Brooklane Behavioral Health Services. Brooklane is Western Maryland's largest nonprofit mental health system. The main campus is in Hagerstown, Maryland, and home to the second largest freestanding psychiatric hospital in Maryland. Brooklane opposes House Bill 804. Brooklane believes that the elimination of the certificate of need process for psychiatric hospital beds and psychiatric services removes critical regulatory and oversight practices that can ensure sustainability of new services, verifies that services established are appropriate for a specific geographic area, and validates new organizations have the expertise and capabilities to provide high quality care. In the absence of this process, we believe that the healthcare environment in Maryland may be negatively impacted by the entry of providers without the skill, the resources, knowledge base, and the expertise to safely and effectively operate a mental health hospital system. We strongly believe that this bill would reduce the quality of behavioral health services overall, and we recommend opposing the passage of this legislation. However, we are willing to collaborate with the state legislature to assist in designing legislation in the interest of improving behavioral health access to care throughout Maryland. Thank you.
And thank you for being here and doing business in Maryland. So I'm going to open it up for questions now from the committee. Are there any questions? Delegate Johnson?
Thank you, Madam Chair, and
You're
thank
welcome.
you, panel, for coming to explain your side, but I'm a little confused, and if somebody could help me out. Our hospitals right now, we have the worst ER wait times in the country. And we're getting a lot of feedback that we have a lot of mental health patients clogging up our hospitals. So if we have folks that want to come in and invest in our healthcare system in this state, why are we not inviting them in? It's our job as a state to provide the oversight. That's what our job is. So when you talk about that we can't regulate them, no, that's our job. So if somebody can help me explain that, I would appreciate it.
So there's no prohibition against an outside operator coming into Maryland to establish a psychiatric hospital or an acute care hospital, they do have to go through the CON process, which does look at a number of factors, including the need for a facility, the financial feasibility of the facility, the capability of the applicant to actually operate a hospital, kind of important. So there is no prohibition against an outside operator coming into the state. It's important to note that Maryland has a rate setting system, as been mentioned before, and that may be a factor in why we don't see as many for-profit hospitals coming into Maryland as exist elsewhere in the country, that they simply, the opportunities to make up a sizable margin on the services they deliver aren't available. So there's no prohibition against any applicant applying for a CON in Maryland, either already here or coming in from outside the state. CON applies to all of them.
Absolutely.
So if a company would come in without needing a CON, would that release them from oversight and regulation?
They would still be subject to the hospital rate setting system. In all likelihood, how psychiatric hospitals are treated versus acute general hospitals would be a little bit different.
But would they be released, or would they have to withstand our oversight and regulations in the state?
The regulations that apply to other hospitals would apply to that hospital as well. Yeah. Like I say, we've not received any applications from outside the state. In my recollection, there was one for-profit hospital. That hospital was acquired by MedStar Health about 12 years ago. Since that time, there's been no for-profits operating in the state of Maryland.
Well, I want to be clear, though, the CON, not having the CON would not release them from oversight and regulation.
From
yes or no?
It would not release them from the planning. It would release them from the planning functions to demonstrate that they have a plan to establish services. They once established, they would still have to meet other regulations that exist in state law.
All right, thank you. Thank you, madam.
You're welcome. Delegate, the way I saw it was Johnson, Olson, Bagnall, and Hutchinson.
Madam Chair. So I will tell you, I really like this bill, and I'm very concerned about some of the things that I've heard from this panel. What I've heard is having more people is somehow going to mess up the system. When our system has problems, we need more mental health beds, and we are struggling to get it done. I've also heard, like, I'm not sure why we have the certificate of need process, because in basic business, you have supply and demand, and the market figures these things out. And we have regulations to regulate our hospitals. I don't find it funny, because in our county, we had to go through a certificate of need process, and in Prince George's County. And as a result of that process, we have a hospital that's much smaller than what's needed. And our emergency room stays packed with people. Our law enforcement officers, when they are serving emergency petitions, they are sitting there for hours because they can't get out of there, because they can't leave the people unattended. And so I don't think it's funny when we're telling you that this process is not working for everyone. I personally feel like our county got the short end of the stick with the certificate of need process. But I will tell you that when it comes to behavioral health and the crisis that we've been having in this country since COVID, it is not working. And to hear that there was not a consensus that could be met on this bill, because I was the one that told the delegate to please go talk to my chair, because she would give him the right people to talk to so that we could work this out. And I don't see that it's been worked out. And I'm just wondering, what is the real issue that you think will happen if the private sector comes in and starts opening up mental health facilities? Because they are still doctors and nurses and have to answer to their regulatory authorities. They will still have the same oversight that the rest of the state has when it comes to opening any other medical facility. All we're saying is that some government bureaucratic agency doesn't get to say whether we need it. The market will determine whether we need it. And I will tell you that the mental health crisis that we have right now demonstrates that we need more beds. And we should not be delaying that because of bureaucracy.
Who would like to answer that?
So what I would say is we're certainly open to any applicant coming to the Healthcare Commission to establish more psychiatric beds. Up to this point, we have approved most recently the Harford County FMF, or Harford County Psychiatric Hospital, that sits on top of the FMF in Aberdeen, Maryland. That opened February 1st. We recently established, just in terms of Prince George's County, additional capacity in Prince George's County to deliver obstetric services. I believe they have also been approved for some additional psychiatric beds several years ago. And one of the things, Delegate, that you have to keep in mind, we don't have a free market healthcare system in the United States. It's mostly paid by payers that are kind of unique to this system compared to other aspects, other elements of our economy. So there is concern that we have overcapacity because the patient is divorced from the cost consequences of that care. So like 34 other states, Maryland does have a certificate of need program. It makes sense to include hospitals in that program, particularly because of the rate setting system. And I think the fact that there are not sufficient behavioral health beds is a concern to the Healthcare Commission. We're doing our best to accelerate any approvals or considerations of projects that come before the commission, and please take my word for it that it is a very significant concern. We're looking across the entire spectrum of care for behavioral health services. That's why we are charged with doing a behavioral health workforce study that's due in December of this year. We're looking at reimbursement for behavioral health services. That too is due in the December of 2024. And the Healthcare Commission, along with colleagues in other state agencies, as well as stakeholders, serve on the Behavioral Health Commission that's addressing issues across the spectrum of care. So I understand your concerns, particularly in Prince George's County. I live not far from Prince George's County. We're doing our best to expand services. I've made commitments to other leaders from Prince George's County that we'll do our very best to ensure that residents of that county, like other counties, can seek care from within the county to the extent possible.
Okay, thank you. And just as a follow-up, because I think it's relevant to the conversation we have had for the last 5 minutes. If you will be so kind and expand on, you stated that you streamlined the process this past December and that there's nothing on the docket. Can you tell us what you're doing differently? What have you put in place to make sure that it's accelerated and that we don't have, and that we have a system that actually works?
I'll let Ms. Hawk describe that process since she is responsible for administering the program.
Thank you.
So we've updated the regulations, timeframes, as well as we have, I think some of the bottleneck of the process was in completing the application, getting complete information for applications. So there was a lot of back and forth with questions from staff. So we have accelerated that step of the process, and there's going to be one bite at the apple to ask questions, and only for good cause can that be extended. Other timeframes have been made to be hard and fast timeframes, so there will be deemed approvals if the commission does not respond in a timely manner. We have changed the definition of interested parties to try to streamline who can be involved, because when there's an interested party that opposes a certificate of need application, that does delay the process quite extensively. So those are the key components, but we now, for this division, we have a project tracking system And there will be hard and fast deadlines. And I think that that's a difference from the past.
Can you send those, please, to the entire committee?
Absolutely.
Thank you so much. I have next Bagnell by Hutchinson, Rosenberg, and then Whitehall.
Thank you, Madam Chair. And I find myself in a very awkward position. I think you see the frustration of this committee there. This is bipartisan co-sponsorship, many of the members of this committee, because this is such a concern. We know that we have certificate of need for our hospitals. But again, our psych beds are a very different space. Currently, under our state hospital system, we have no non-forensic beds. We have to look to the private sector to build capacity for our non-forensic mental health patients. So I don't know if this is the answer, but I appreciate hearing the work that you're doing, because I will say that in your testimony, Dr. Reka was the only one who said he would want to work with the committee on solutions. So I will just say, if this isn't the answer, I hope that you will help us find the answer, because the need is now and not 2 years from now, 5 years from now. We need beds for our non-forensic Marylanders. Isn't that so?
Certainly, my apologies. It goes without saying that the Healthcare Commission will work with the committee to the extent and direction that you ask. I think it typically is in our DNA to work with both the legislative committees, and we're certainly committed to doing that. And I'm confident that you would find the health systems and hospitals equally anxious to be part of those solutions.
Delegate Hutchinson, followed by Rosenberg.
Thank you, Madam Chair. Mr. Stefan, I'm sorry to be a thorn in your side when it does come up to CONs, and having in my 25 plus years in healthcare, that's always been some type of an issue. You see the frustration here. I do have a question first, and that is, and I'm very happy that my hospital in Easton has their CON, but was that in the streamlined process, or was that in the old process? Because that was an extensive, time-consuming process.
So thank you, Delegate Hutchinson. It's always, I appreciate your questions and have spent a good deal of time on the Eastern Shore. So actually, Easton had 3 CON applications. The first one was actually introduced prior to the start of the new hospital waiver. It didn't really align. It was withdrawn. A second one was withdrawn when Dorchester was converted to an FMF, and the most recent was submitted about 13 months ago. It was slated to be approved in 11 months in December of that year. We did have to delay it till January of this current year, but the regulations that governed that CON were under the old framework. But should that application have come forward today, it would be governed under the procedural regulations that went into effect in December of 2023.
Absolutely.
Not a question now. It's really maybe even directed to my chair, but I'm glad she asked the question about, could you explain what's going on? But that was a very quick 30-second response. And I don't know if this is possible, but I would like to recommend that in the interim, we maybe create a work group. And
you know what we're doing right now? Can I tell you what we're doing?
I wonder if I'm going to be on it or not.
So I'm gonna go there now. You guys know me too well, and that's really dangerous. Okay. I tell you, we were discussing asking you at the end of all the questions to put together a work group. You don't need legislation, but it does have to be balanced. And we have to think about, was gonna ask Aaron to draft something about that composition. Aaron, I'm sorry that I am giving you work, because 17 of my members co-sponsor this bill. And I just counted to see how many out of we're 23. So, but I also understand both sides, right? And I try to be balanced as a chair, because I get it. But I honestly think that out of respect to them, because there's 17 of them and I'm one vote, and this is not a dictatorship and they know that. I really would like a work group to be established, and Aaron will think about what that composition will be, and I would like you to help staff it. They will look at very narrowly focus expediting psychiatric beds, right, in that process, because it is an issue. And it is an issue, and I know that Madam Secretary of Health has been doing a lot. I have to really commend her for the work she's doing in this area. You guys have been doing a lot as well, right? Everyone is at the table, the hospitals, everyone, HSCRC, everyone. But we need to really get to the bottom of it. And my members want solutions. And I didn't realize till I just counted that 17 of them had done that. And I was gonna leave that at the end, Delegate Hutchinson, but you beat me to it. So I guess I'm gonna go there right now. Will you be willing to do that?
Absolutely. And the Healthcare Commission does have a record of responding to working with the legislature in this area. The last work group we convened was in 2018, which focused broadly on CON. I know it was characterized as useless, but we did make some very significant changes in the scope of the authority, and look forward to trying to launch another one this summer with the commitment to answer some of the questions that you've raised.
And I think I like Aaron to think about who should be, just to be balanced, right? To give it credibility that is not just one side. Who should be, on that work group. I like Delegate Alston and Bagnall, if I may, and Delegate Hutchinson. I'm giving you homework in the interim, and Kipke to be part of that. That would be great. I know you say yes, right? You accept? You accept? All right. So Aaron will work on it and get in touch with you. I don't think that we need to make this into a work group. I think that we trust each other, and you have done it for me before and for other chairs. So we're gonna go there. Is that okay with everyone? Okay, I want you to feel heard. 17 of you is a lot. Okay, enough for me to pay attention. All right, Delegate White Holland, your light is off.
My questions were previously answered by my colleagues. So
Thank you. Delegate Rosenberg.
Ditto, you've just taken the question right out of my mouth. So, yeah.
Okay, well, it's important to do it, okay? Delegate Johnson.
Madam Chair.
You want to join the work group, Delegate Johnson?
That'd be great.
Can you include Delegate Johnson? And anyone else who wants
I
to?
appreciate another bite at the apple, and this question's for Mr. Stefan. I'm not picking on you, Mr. Stefan. You just happen to be the man in the know. You mentioned the Aberdeen freestanding medical facility. Now, they requested a certain amount of psych beds. Were they approved for that amount?
So I thought that question may come up. The Hartford has 27. The new psychiatric hospital at Aberdeen has 33. I'd have to go back and check to see if I think that was the number that they requested, but I want to confirm that. It was a bit more than was available in the psychiatric unit at Hartford Memorial, which is now closed.
Get that information back to us, that would be great.
We'll share that with you.
Thank you.
And if anyone else would like to be part of that work group, feel free to come, okay, and join in the summer. I want it done.
Yeah.
Okay. Thank you so much. I don't see any other questions from the members. Yes, Ben.
If I may.
Sure.
Chair Penny Melnick. So I think it will align with some of the other work work we're doing on reimbursement for psychiatric services, as well as the workforce study that all will be moving towards completion in the summer and fall of 2024.
I think that's wonderful. You know what? It's time to put this in the front. We just need to address it. It's important.
Could we add to the study, how to incentivize hospitals to expand mental health services?
Can that, I wonder if it can be included in that work group. You know, why don't we include it? Right? I mean, my members are willing to work. They work really hard. And I think that they will be willing to do that. Okay. Is that okay?
That's fine.
All right. And so therefore, more of you can join. So let Erin know, okay? Because they need the work. We can't just come with problems. We have to come with solutions, and we have to help do the work. And I know that this committee works really hard and they care, and they will do it. Thank you so much. And thank you for sitting there and, you know, just being open. All right. You have a blessed day. We have actually, if I may, 1 second. We done everyone. I did the virtual witness. We did her, right? Yeah. Okay. So this actually, and you know what? Can you also include Delegate Grammer? All right. Just to be fair and respectful as well. So this concludes the bill hearing on House Bill 804. I'm going to go to Delegate. I'm going to give you an opportunity. All right, because I was gonna go to someone else, but since you only have Nilesh is here from the Department of Health, and I want him to go do the work that we're giving him on every time we email him, go do the work, and then I'm going to call Delegate Alston because we have a special guest here that represents us, and he needs to also go do the work. So why don't you start, Delegate? So we have here, I'm calling House Bill 739, which is Delegate Vogel, Maryland Department of Health, list of diet pills, Delegate Vogel. I believe you have Perry Patel with you.
Yes, Madam Chair.
And then you have a Stanley Wong. Will you please bring that person up? And that will be the favorable, and then we'll call the unfavorable and then information. So please get started.
I believe Stanley's virtual, but
Yes.
thank you, Madam Chair. And I apologies. I was in the Economic Matters Committee for another bill that overlapped. Madam Chair, Committee, I'm here with House Bill 739 asking for a favorable report. This is a bill that has been 2 sessions in trying to make some progress on a very critical issue that Pari and many young Marylanders have brought to my attention over the years, which is the danger of unregulated or underregulated weight loss supplements that are sold in our state. These weight loss supplements are readily accessible to anyone walking into a CVS, a Walgreens, a Target, any sort of retail store, or purchasing them online. Last year, we came to the table with a piece of legislation that intended to regulate the sale of weight loss supplements to those under the age of 18, recognizing that they pose potential for real bodily harm, serious bodily harm, and are associated with a 258% greater risk of being diagnosed with an eating disorder. That is 258% based on studies. There have been bills across, there's been legislation across the country to address this issue. And we've had conversations with the Maryland Retailers Association, with the Maryland Department of Health. And what we have before you today is a bill that takes into account the concerns and the recommendations from all different stakeholders. And what we're trying to do here is start by compiling a list of which of these products are currently being sold in our state. The amendments that I distributed earlier, that I think were sent to you all earlier today, refines the process by which we're going to compile that list. The intention of creating that list, I'll be very straightforward, is that we will be able to come back in subsequent years and sponsor legislation that allows us to regulate these products using the lists that we will be creating. The challenge is that because of how this market and this industry operates, there's not one product, there's a number of different products. The products change names constantly. They're using all sorts of ingredients, some more dangerous than others. So I hope that we've been we've been working or trying to work with the Department of Health and other stakeholders in good faith. And what we need to do here, and this is, I'll leave you all with this, we have a real serious problem and it's causing real harm to children. I will work with anyone who wants to work with us to make some progress on this front. I think this legislation is a compromise that we can make some significant progress. So I urge a favorable report. But Madam Chair, I know we've had conversations and as I said, I'm happy to work with anyone to make some progress here. Thank you.
Thank you. Next, please.
Good afternoon, members of Maryland's Health Government Operations Committee. My name is Pari Patel, and I am a college student and a resident of Hagerstown, Maryland. Thank you for the opportunity to speak here with you today in strong support of HB 739, sponsored by Delegate Vogel. I was exposed to supplements at the age of 14, and as a competitive athlete, I turned to over-the-counter diet pills as a way to see immediate results. During this period of struggle, no one was there to speak to me about the dangers of these products. My friends, my coaches, and teammates even recommended the use of these supplements. Finally, through deep research, I eventually realized the ingredients might be dangerous, but still, it was hard for me to believe because I so firmly trusted that our government would not let dangerous products like these be sold to me. I was convinced that our government would put a stop to this if these supplements were truly bad. My story is one of millions, but it begs the question, how do we expect teens to understand the negative effects of these drugs? What's worse, these products are marketed as harmless, natural, and even healthy. But the truth is that they are none of these things. They are unregulated and they are dangerous. And our young people are paying the price. We cannot allow for this to continue. We cannot risk another young person to fall victim to this industry. We cannot allow our children to be put at risk by these harmful products. It is time for our government to take action. Creating a list of diet pills that are accessible for consumers is a vital step in protecting the health of Maryland youth. We must prioritize the health and well-being of our young people and ensure that they are not being misled and put at risk by these harmful products. I implore a favorable report on HB 739.
Excellent timing. Thank you very much for your testimony. I'm going to go to our virtual favorable witness, Mr. Huang.
Thank you, Madam Chair, and the honorable members of the Health and Government Operations Committee. My name is Stanley, and I'm a sophomore in college. I am testifying on behalf of the Strategic Training Initiative on the Prevention of Eating Disorders in favor of House Bill 0739. The dietary supplements industry generates billions of dollars in revenues from consumers annually and are not required to undergo rigorous pre-screens and testings by the U.S. Food and Drug Administration. The industry deceptively markets these products to youth as promoting safe and effective weight loss. As a youth who has lived experience, I and many of my peers have been the victims of persuasive, unrealistic, and misleading advertisements soliciting over-the-counter dietary supplements. When I was 14, I began using a variety of weight loss supplements that were easily accessible in groceries or supplement stores, none of which required parental permission or had any age-related restrictions. They fueled my psychological distress into an eating disorder and into further extreme measures to lose weight and starve myself of essential nutrients, especially at a young age. But my story and experience is not unique. Youth are increasingly using these products and remain unaware of the harms these products pose. In fact, the American Academy of Pediatrics issued a strong warning cautioning youth against using these OTC weight loss supplements. Additionally, each year, 23,000 Americans end up in emergency rooms because of dietary supplements, and a quarter of those are linked to weight loss supplements. Research has documented time and time again cases of adulterated OTC weight loss products that are laced with pesticides, steroids, heavy metals, and can cause stroke, cancer, liver injury, or even death. An adolescent and young adult women who use OTC pills face 6 times the risk of being diagnosed with an eating disorder within the next 3 years. This act would publicize the vast assortments of toxic and underregulated products and serve as an important incremental step towards protecting youth from these products. Additionally, this act may signal to youth, parents, and public health officials and organizations that these products should not be the de facto position to promote healthy weight loss or be touted as safe. Other states have already begun taking measure to document, and I urge that the honorable members of this committee to join in support for HB 0739. Thank you.
Thank you, and I apologize for the mispronunciation. Try better next time. Questions for this panel? Delegate Bagnall.
Thank you, Madam Chair. And thank you for this bill. Delegate, you had spoken to conversations you were having with the Department of Health, but we have a letter of opposition based on the broad text of the bill. Can you speak to where you are in those conversations?
Yeah, so based on the thank you for the question, Delegate. Based on the conversations we had with the Department of Health, I sponsored or I put forward amendments that seek to address those two concerns. I hope they're in your system. If not, they should have been emailed to you all. The first thing that we're doing here is addressing the issue that the Department of Health put forward, communicated to us, which I agree with, which is that, you know, this could, depending on how this list is released or advertised or put online, it could appear to be an endorsement of these products. The amendment that we put forward is that this list no longer is needed to be released publicly online, but rather sent in a report to the legislature. I'm also willing to work on specific language for how we can make it very clear that this list is not an endorsement of these products. The second amendment, the second amendment that I drafted is to streamline the process and reduce the burden on the Department of Health to create this list. These products are already being categorized by retailers as either weight loss supplements, weight loss and detox supplements, or diet pills, depending on which of the retailers you're looking at. They're already doing that in their back end system. So what the amendment says that we remove any language in the bill around ingredients, around labeling and marketing, which I know poses a concern in terms of identification. And we say, we want a list of the products that are being currently sold by retailers with over 10 physical locations in the state, products that are categorized in their systems as weight loss supplements, weight loss and detox supplements, and diet pills, which should be as easy as exporting a spreadsheet and sending it over. I don't want to minimize the work that needs to be done, but I don't think it's going to cost $233,000 a year to do that.
Yes, go ahead.
Thank you. Just if you could make sure that we get those amendments, because I don't think we had them in advance of the hearing. So thank you.
Yes, thank you, Delegate.
Any further, are you thinking, Delegate Casoni? Okay.
Chair, could you go back just a second? Because I think what I heard you say was this list wouldn't actually be published. It would just be sent to us. Is that what it is?
To start, yes, Delegate. I think to start, it would just be sent to us as a basis for the bills moving forward. And I want to be very clear. The intent here is eventually to regulate the sale of these products, but it's really hard for the retailers to go about doing that if they don't have a list to work off of. I just want to address at first, right, the Department of Health's concern that if we put this list available online, it could seem to be an endorsement of these products.
Did you want to follow up, Delegate, or do you have your answer? Okay. Okay, I don't see any other questions for this panel. First of all, I want to thank the young people for taking time out of your day, coming and spending it with us and providing your stories. It's really important for us to hear stories from the people who are experiencing the need to demonstrate to us the need for policy changes. So thank you. Thank you both very much. I appreciate that. Thank you, Delegate.
Thank you.
And I'm going to call up Sarah Price, please. You guys can go. Or stay, Delegate, if you'd like. Sarah, have you signed up for information?
Yes, that is correct, Madam Chair. Good afternoon, honorable committee members. I'm Sarah Price here on behalf of the Maryland Retailers Alliance. We are informational at this point because we wanted to give you a little bit of background for where we are on the ultimate goal of what Delegate Vogel wants to achieve. We have no position on the efficacy of these products. We make no claims about if people should be taking them or what they do or don't do. We are simply selling the items. So if the goal is to, what we came to last year was if the products are identified and we are told, here's the list of products, you have to ID upon the sale, we are fine with that. Initially, when this was first introduced last year, it included provisions such that retailers would have to keep all of the impacted products behind the counter or locked up in a cage. We did have concerns about that. So we did reach a point where if the items were just ID'd for, similar to cold medicine, we can do that. The place where we start butting heads with the sponsor is on how the list of impacted items is produced. So we were the ones who had suggested that the state produce a list of impacted items. We had some concerns about the ability for retailers to go through with the previous specifications regarding ingredients and marketing strategies. We had concerns about the retailer's ability to properly identify every possible product that this could be. We didn't want things to be left out, and we didn't want the responsibility for one business's list to fall on the head of, the individual who happens to be coding those products that day into the system. So as long as the ultimate goal is for a list to be provided to us and then we ID, we're okay with it.
Thank you. Questions for this witness? I have a question. So I think you just heard the delegate say that you have in your inventory the different categories of supplements. First of all, is that true?
Yes. I mean, every item that is sold by a store typically is coded into some product category in their system.
So was that something that could be delivered to a central source who is gathering this information, ostensibly the Maryland Health Department?
The concerns that we have are that not every store uses the exact same product categories. When you search for supplements on different store websites, you're going to get results that don't always match up. If you search for weight loss supplement, you might start getting fiber pills or apple cider supplements, things that aren't necessarily advertised as weight loss, but maybe they're getting pulled because the word supplement is on the bottle. So we just had some concerns about the accuracy of the information that could get pulled, and the fact that some items might fall into a certain category in one store, but not in another. So we thought that the best way to get accurate, consistent information across the board for all businesses is for the research basically to be done by one entity rather than every business saying, well, here's how we do it, but maybe not how they do it.
Thank you. That's helpful. And Delegate Bagnall.
Thank you, Madam Chair. And I think I'm just following on with your question. So if the department was to populate that list and then provide it to the retailers, it would make it easier to sort of uniformly code. Is that?
Yes, yes. And you would have consistency in all retailers because every single store would be looking to the same resource, as opposed to maybe CVS says this is one thing and Walgreens says it's another.
Thank you. Any other questions? Seeing none, thank you very much for being here today and your patience in waiting for this bill.
Yes, thank you.
I'm going to call a panel of unfavorables. We're going to go with Dr. K, who I think we should have put a reserve seat on your sign on your chair. And you want to go ahead and pull up Mr. Fabricant online. And when you're ready.
Thank you. Thank you, Vice Chair Collison. I'm okay without having a designated seat. We'll give it that. Thank you once again for having me here to speak about House Bill 739. For the record, I'm Dr. Nilesh Kalyana-Raman, the Deputy Secretary for Public Health, Maryland Department of Health. So just want to lead off with, at the department, we know that addressing eating disorders in youth is a serious issue. And we support efforts to make sure that products that are available are safe and are also safe to use for youth, and to also help guide and do education around what should and shouldn't be used. Our concern with this bill is around its execution. So this bill would require the department to make determinations on what are diet pills or diet supplements. And I think there's really two paths here that both are particularly challenging. One is that the FDA has not made a definition of what constitutes a diet pill, a diet supplement. They are the federal agency that is responsible for this. And, you know, hearkening back to prior testimony when we were talking about the role of the FDA, it puts us in a position where we are trying to do the work that the FDA hasn't done and isn't doing at this moment. And so if we were to start making those determinations, right, if we were to start pulling products and saying, okay, we are making a determination, that requires a set of expertise that frankly we don't have as a state health department, because that is a federal function, and a federal function that's not actually being executed. And I would say that not just the fiscal note is the issue there, but also what we would have to make determinations as to what constitutes a dietary supplement. And that gets into tricky questions around efficacy, harm, labeling. The alternative, which was suggested, which is to rely on the retailers' definitions, then swings us to the other side, which is if we rely on their definitions, then we're not really performing a function anymore because the retailers are defining it. And it's not clear to me what us pulling together a spreadsheet of whatever if I may finish quickly.
Please finish.
It's not clear to me what function we serve then, because however the retailers define a diet supplement is what we're going to go with, right? And so to that question of what are they defining, I've been on these websites, we've all been to pharmacies, we see the range of products, and they range from all sorts of compounds to take this drug, to heat this bar, to here's some cranberry juice, right? It's a messy field. And I think that it takes a lot more effort to disentangle it. And that is our concern, and that is our opposition to this bill. Thank you for the opportunity.
Thank you. Dr. Fabricant?
Thank you, ladies and gentlemen of the committee. My apologies for not being there in person. I had to take my daughter to Hopkins, the Cystic Fibrosis Clinic at Hopkins. NPA was founded in 1936 and has taken a role in ensuring quality for consumers that manufacturers follow the rules. Prior to my role as CEO and president at FDA, and consistent with what Dr. K just said, I was the principal detangler for the FDA. I was in charge of dietary supplement programs under the Obama administration from 2011 to mid-2014. During that time, we obviously made great policy strides, but we also took significant enforcement action. Some of that enforcement action was based on adverse event reporting. The same adverse event reporting for dietary supplements federally is in place for drugs, medical devices, both over-the-counter and RX drugs. You would happen to know, if you FOIA that system, that there's a causality associated with a number of prescription drugs on eating disorders. Over thousands have been submitted since 2019, approximately about 10,000. In that same time period, there have been absolutely zero submitted to the FDA on dietary supplements leading to an eating disorder. So while I think everyone, and especially the industry, wants to protect consumers and protect the children, we wouldn't have consumer confidence that we do, that about 70% of the country uses a dietary supplement every day. Those same ingredients, like vitamin D, is actually responsible for fat metabolism, things like that. So to Dr. K's point, there would be a lot of confusion. But furthermore, there's not a causal link. There's not even an associative link between dietary supplements and eating disorders. So what is the problem we're trying to solve? And also, tools like getting a list to the legislature, what exactly is that intended to do? So these are all problems why we strongly oppose this bill. We appreciate, again, everyone wants to protect the health of the children, no one more than the industry. Certainly, we saw during the public health pandemic how important vitamin D status, folic acid status was to everyone in this country, especially youth. So while we appreciate the efforts here, it's a misguided policy, and we would like to see it voted against. Thank you very much for your time. Happy to answer any questions.
Thank you very much, sir. Let me open it up to questions from the committee. Okay, Delegate White Holland.
Thank you, Madam Chair, and thank you for your testimony. I just wanted to follow up again with the health department related to this. And I know, I'm not sure if you have seen the amendment provided. So is it still the case that the health department doesn't have the expertise and would need to need to acquire the appropriate expertise to create this list? So with this amendment, does it address the concerns, or if not, is there anything else that you could propose to work with the sponsor in this way?
The amendment that I saw, I don't believe addresses our concern, which is that, so I think it addressed one of the things we had raised with the bill sponsor, which was just the sheer magnitude. So when we looked, there were 2,100 pharmacies in the state and another 100 or so GNCs and vitamin shops. So we were talking about the magnitude, and I think the amendments get to some of that, but that's just the volume of stores. It doesn't get to the substantive issue we have, which is we would then be defining what a dietary supplement, like what we, the Maryland Department of Health, are saying this is a dietary supplement, this is not. And that is absolutely not something we have the expertise to do.
Thank you. Delegate Bagnall.
Chair, it's interesting because we've been wrestling with this at the federal level for 30 years, right? Since the Dietary Enactment Supplement Health and Education Act. And it appears that we're not going to make progress at the federal level. So much like you said on our previous bills, we do need to look at what, if anything, we can do with the state. So would you be willing to work with the bill sponsor, look at maybe what other states have done, and see if there is a space in which there would be a suitable action that the state could take?
So I'd be happy to do that, and we have looked into this. There's two states that have passed similar legislation, New York and California. California was vetoed by the governor, and in the New York legislation, there was no involvement at the health department. It was a straight pharmacies or retailers may not sell to these products labeled as such to minors.
Okay, good, Delegate. Okay, seeing no further questions, that concludes the hearing on House Bill 739. Thank you all for your time and your testimony this afternoon, and good luck, Doctor, there at Hopkins. And we will call the next bill, which is House Bill 1019, Delegate Alston, and you're going to bring Sheriff Carr up, is that right? Okay.
And just to.
Okay. 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 I'm going to add a couple of witnesses to this table. Captain Wiseman and Assistant Sheriff. I'm not sure how to say the last name, so I'm going to say Assistant Sheriff Stephen. And you will help us learn how to say your last name.
All right. Thank you, Madam Chair. Thank you, members of the hardest working committee in the House of Delegates, my colleagues. I am here today to present House Bill 1019. During the interim, I was invited to participate in a high utilizers group for people who are frequently petitioned to the emergency petition process. This is something that my sheriff created after he was elected. And I will tell you, I was astounded by some of the things that we saw and the things that I learned during that process. The number of people that are being frequently emergency petitioned over and over and over again because of their mental health problems was disturbing at best. During that process, I realized that our sheriffs were not protected. Oftentimes they go to serve these petitions and the people are a danger to themselves. They're a danger to others. And they are sometimes violent, not always, but sometimes they are violent. And when we looked at the code, this is a civil order that they're serving. It's not a criminal order. There's no arrest warrant, they're not being arrested. We're trying to get them help and treatment. So we want to take them to the hospital. But when people are a threat to themselves or others and they don't want to go to the hospital and they're acting out, it creates a real challenge for our law enforcement officers to serve that warrant, to serve that order of emergency evaluation. And so we discovered that there was a gap in the law because there was nothing in the law that really explained what to do in terms of force. And so that's why the use of force is in this bill. We put in reasonable. I've seen the opposition where they're requesting that we use necessary and proportionate, which is the standard that we amended into the police article. We don't have an objection to that in theory. I'll do the research to make sure that it's still going to be okay. Because in some of these videos, you have people who will pull out knives, they're throwing chairs, they're trying to hurt themselves, they're trying to hurt their family members. And our deputies are just trying to get them to the hospital so they can get the much needed medical care that they need. Often they don't report these folks, they don't file charges against them, even though they've been assaulted during the process, because they understand and they've taken the specialized training to make sure that they keep everyone safe. And that is their top priority. You're going to hear testimony, though, that during the process of serving some of these warrants, they are the most violent sometimes, and they have actually lost officers in the line of duty trying to serve these warrants, trying to get people to the hospital. So we have to protect our law enforcement officers. The other issue that happens is that sometimes people are in crises and they know they're about to be served, and then you might not be able to find them. And as a result, the people have to go back in 5 days because it's expired, but the imminence and the danger is still there. They're still displaying the behavior and they haven't been able to serve them because they can't find them. They might be homeless. They might be bouncing from place to place. And so the amendments, what the bill does is it says that you can go in and ask for an extension for good cause. And the court can determine that. You have to show that there's still the issues are still displaying and present. And I saw concern. I'm willing to work with the opposition on that to make sure that the issues that were originally displaying that precipitated the need for the emergency order in the first place are still there. But you have to prove to the court that it's still there. And it's better for us than opening up multiple case after case after case. So those, I have amendments that I will pass around. I meant to pass these before I got up here. But that's the bill. I'm asking for a favorable report. I'm willing to work with the opposition. I did talk to the public defender's office. I don't think they're ever going to agree, but I did try. And I understand their concerns. I understand their position, but it's important that our law enforcement officers are able to get people to the hospital when we need to get them to the hospital. And their lives are in danger every time they do it. And we just want to make sure that they are protected and that it is clear in our law that they can use the force necessary when the problem may present itself. So I'm going to turn it over to my sheriff. We had a video that we wanted to show. We blacked out the faces so you couldn't see, just to show you how these things transpire. But apparently as a committee, we decided we wouldn't do that. So I will send that around for people to see individually so that you can see what's actually happening. And they will, the captain and the deputy sheriff will be able to explain. And I'm going to turn it over to him and pass these out.
Before you begin,
oh, and I'm Tiffany Austin, sorry.
I just want to make sure that folks know that we've been joined by a representative of the Judiciary Committee. You want to introduce yourself, Delegate? This bill is jointly assigned to HGO and Judiciary. Thank you very much for coming. I'm sorry, now Sheriff Carr.
Good afternoon, Madam Chair, members of the committee. I appreciate your time. I've come before you and I thank Delegate Austin for putting this bill, House Bill 1019, in front of you. The Sheriff's Office has been around for 328 years. And in that 328 years, we've only lost 2 deputy sheriffs, and they were actually serving an emergency petition. This is not a criminal matter. This is a civil matter. Somebody's going through health crises, and I understand that. And that's one of the reasons why being sworn in 2022, I actually created a division for behavioral health. This is something in which we work with our families, our citizens on a day-to-day basis to let them know that, one, we care about them, but two, how we actually address and interact with our citizens. So therefore, we take a softer approach. We have a modified uniform in which you do not see the outer couriers, you do not see you see a polo shirt, and you see a softer khaki type pants to, one, try to get somebody who's going through a mental health crisis to feel at ease. This is one of our most dangerous calls, for lack of a better term, of what we deal with. In Prince George's County alone, in 2023, we actually had 1,282 emergency petitions issued from the courts. I heard in previous testimony about how many beds we may have dealing with mental health. That's an average of 105 a month in which we are serving. So my deputy sheriffs are going out, we're taking a softer approach, and we're trying to help our families who are asking for relief from the courts. The bill actually states, as far as extending that time frame, it goes towards, if we're unable to locate somebody within that 5 days, should that family have to go back to the courts and go through this whole process all over again before we can actually go out and serve it? And then dealing with the force, we're talking about trying to de-escalate a situation in which I require my deputy sheriffs to go through special training as far as crisis intervention, and to also work with the hospitals, in which we do a bi-weekly meeting. And I have Captain Wiseman and Assistant Sheriff Umathamical, who are responsible for that can address that. But I'm asking for a favorable review because this is a health crisis that we have, not only in Prince George's County, but throughout the state. Thank you.
Thank you, Sheriff. Appreciate your patience and for you waiting today. I know it's been a long afternoon.
It's okay.
Captain Wiseman?
Good afternoon, and thank you for this opportunity to speak. I am the commander of our behavioral health unit, as the sheriff has said. I'm here more for the purpose of questions, since I run the day-to-day operations of our behavioral health unit.
Okay, thank you very much. Thanks for being here. And Mr. Stephen?
Good afternoon, everyone. Assistant Sheriff Stephen Upathambagul. I oversee our Bureau of Field Operations, where we created the new behavior health unit. Like Delegate Austin said, every time we serve these, someone's in a health crisis, and oftentimes deputies are assaulted, spit on, and other things. But we as law enforcement understand that the crisis that they're in, we don't charge them. They could be charged, but we don't. We want to make sure that they're taken as safely as possible and taken to that facility where they can get proper care. There is a long wait time with the hospitals that we heard, and that's something that we're dealing with. We're having to travel outside of our jurisdiction of Prince George's County to go to Anne Arundel, to go to Howard County, to go to other different counties to take our folks that need help. This bill, in addition to the extension of 5 days, is really important because a lot of times we can't find these folks. They get a petition taken out by a family member that's concerned about them. They leave the house, they're at a friend's house, they're possibly homeless. It takes us a while to try to find this person, and to have that family member have to go back to the court and repeat that process again and tell the court the issues that is happening, when we can just get an extension to help us get that person on the 6th day or the 7th day, would be very good and beneficial. So I asked this committee for a favorable report, and I'll stand for any questions if there are.
Thank you very much. I'm going to start with Delegate Woods and ask Delegate Williams, if you have a question, just let us know. Come on up. Okay. All right, Delegate Woods.
Thank you, Madam Chair. First and foremost, I want to just express my extreme gratitude, Sheriff Carr, for you and for the work that you all have done as a department as it relates to mental health. Second, as a person who has had the experience of having a request made and it expired after 5 days, and the humiliation, and in my professional work, having experienced the same thing, I think that what you're doing is phenomenal. And I would hope that you would, my question would be this: if you could give us kind of an overview, because I think the work that you're doing is phenomenal. And I think people need to kind of hear despite some of the challenges, how beneficial it has become to establish this behavioral health unit to try to take away the stigma and the shame that causes people not to want to see a person in uniform, and kind of just talk about how that has been beneficial, please.
So
Thank you,
yes,
Madam Chair.
so I'll start off by saying the whole purpose of creating that was really to work with our citizens and families who are going through this. Just because we go there and we actually take their loved ones who is a mental crisis to the hospital, it doesn't end. Once they get evaluated, people are still looking for long-term solutions. Unfortunately, we have folks that we consistently see on a regular basis. And that was the whole purpose of actually creating these high utilizers, people who are utilizing when we have to continue to go to the hospital. We've had one individual within 3 months, we've actually took that individual to the hospital 25 times. So imagine that family going through this over and over again. When we talk about the manpower, we have manpower shortages just like everybody else. But imagine the hours in which we have to wait into the hospital. We have to locate this individual who's going through a mental health crisis, and we have to try to make sure that they're getting the proper care. That takes time. So you don't want to be limited by saying, hey, we have 5 days to try to hurry up and locate this individual. And we take this as a priority. It's first and foremost our priority for us. But imagine in 5 days, if we're averaging 105 emergency petitions a month, and I only have 5 days to locate this individual, take them to the hospital, and dealing with the shortages, it becomes, it's overwhelming. And not to account for the person who's going through a mental health crisis, them acting out. We understand that it's a health crisis. It is not a criminal act. And that's one of the things that we try to make sure that we push across. It is a health crisis. And that's what we are there for, is to help. Not to lock up, but to help and transport to a clinical technician or a facility that can help this individual.
Yes, Delegate, go ahead.
You do that in the midst of constantly coming to Annapolis, advocating, spending many, many hours advocating to try to make sure that we increase services. Isn't that so?
That is so, along with the warrants, juvenile reform. So I can go down a long list, but I won't. How about that?
Delegate White Holland.
Madam Chair, and thank you, Delegate, and thank you, panel, for your testimony. I am not an attorney, and nor am I aware of the differences in the language here, but if you could just clarify the language as it relates, and I believe, Delegate, also you mentioned this in your testimony, but again, necessary and proportional versus, I guess, reasonable. So can you give us what that distinction is, and are there any examples that you can provide to provide insights into what that looks like in that difference?
So I'm gonna let Captain Wiseman chime in, but I know we have no problem with.
Okay. Thank you for the question. So when it comes down to, obviously it's a situational, the necessary and proportional depends on the circumstance. If my deputies are able to go onto a scene and someone is irate and we're able to talk to them before we physically put our hands on them, and all we have to do is physically grab their wrists and pull their wrists behind their back and handcuff, that's what's required at that time. There are other times where my deputies have opened the door and immediately the person has started swinging, fists and started kicking and doing anything that they could possibly do to resist the deputies. Then we would follow our use of force continuum to determine what was the necessary level of force at that time. Obviously, it would change if the person was armed, if they're throwing a coffee cup at us, spitting, throwing other fluids that we're not aware of. So it's a case by case basis. We can't have like a continuum or a definition of everything. But a lot of times we go in and we try to de-escalate right away before we go hands-on, unless the threat is at us immediately. And then even if we do have to use force, my deputies have been trained to use their de-escalation once we have the person in custody to try to calm them down. And that's part of my background as I'm also the commander of our negotiations team. So I have tried to instill training on my deputies before we even go to the address, let's do some research and find out what video games they like or who really upsets them, because a lot of times the petitioner is the trigger for the EPS. So we don't want them on scene, and we try to gather intel, including criminal history, likes, dislikes, food they like to talk about, so that when we go on scene, the need of force, if we can talk to them about something that they like or take away the elements that they don't like that trigger them to make them angry, that's kind of the research and the de-escalation that we use before we even get on scene, so that we don't need to use that force. And then I would just speak that sometimes in emergency situations, we may need force to actually get onto the premise or into the apartment or the house because they're a danger. They haven't been seen. There have been weird noises coming. So we want to actually use a key from the landlord or force our way into the door because we have some expectation or some belief that something is going on and somebody's been harmed or being harmed.
Okay. Anything, Delegate Marks? Yeah. Peter, your mic's on.
Okay, thank you so much. Just to piggyback on what Delegate White Holland was asking, and I apologize if I must have missed this in the testimony, because I did see the concern about the standard of necessary and proportional versus reasonable. And so I don't know if the necessary and proportional is a standard that you're willing to entertain, Delegate Alston?
Yes, we are. I saw the testimony today in preparing for the hearing, so I didn't have time to draft an amendment, but we don't have an objection to the necessary and proportional. And I would just say that when something is necessary and proportional, it's based on the force that's being exerted by the other person. So they would use whatever is necessary to de-escalate it and calm the situation. So it has to be proportional. So if the person is, tried to punch, you don't pull out a gun, you use your hands. So that's the proportional piece. So you're not going to the most extreme mechanisms of force that you have. You're doing whatever is necessary. But if that person has a gun, then yes, you're entitled to then pull a weapon. And I've watched countless videos with these folks doing their jobs, and I'm sitting there saying, you haven't put your hands on them yet, because things are being thrown at them, they're being hit, they're being abused, they're being called all manner of ill things. And it's dangerous. It's very dangerous. And to not have the law clear, because this is a civil order, not a criminal one. It's clear in the criminal aspect. I think that's a problem. We want to just be clear. And so necessary and proportional is fine. That's what we've amended the criminal code to say. We don't have a problem with that.
Good. Thank you. Any other questions? Seeing none, before you go, we've been joined by two additional members of the Judiciary Committee. Please introduce yourself. You can stand up and speak loudly.
Delegate Kemp Roberson. Delegate Christopher Boucher. Good afternoon, or good evening.
So the favorable panel, which you just missed, but you'll be able to watch, but I will be calling the next, unless you have a question for the sponsor. Okay. Then thank you very much for your time and your testimony. I am going to go to a favorable with amendment panel. And they're both virtual. So if we can bring up Mary Moran and Evelyn Burton. Go. Hi, Ms. Moran. You've appeared first, so we're going to let you go ahead and get started.
Thank you. Can you hear me?
Yes, we can. Thank you.
Great. Thank you. Okay, my name is Mary Ellen Moran, and I have bipolar disorder. And I've only been committed twice, but I would welcome another emergency petition if one is needed. But I would like to focus on the one that adds where a peace officer may use reasonable and necessary force.
Ms. Moran, can you move just a little closer to your mic? We're having trouble hearing you.
Is that better?
That's better. Thank you.
Okay, sorry.
That's okay.
I was visiting my sister and I became manic and then psychotic, and she called 911 and they sent an emergency response team. And I do remember 2 members were a psychiatric nurse and a police officer. Well, I refused to go with them. And I don't remember what I did, but my sister said that the police officer took hours to talk me into going. And I do remember standing in front of her house next to the police car, and he talked me into putting my hands behind my back so he could handcuff me for safety reasons. And he safely got me to the hospital. And I would like to suggest that there be something added as the way of an amendment to require attempts at de-escalation with the ill person before using force if it wouldn't interfere with the safety of the officer. And on the emergency petition, I think it's good that the bill would permit a court to extend it for 5 days if the person goes missing that they're looking for. But I was wondering if it could be amended just for 10 days. That way, if the person is missing, it won't necessitate another visit to court.
Go ahead and
I'd like to recommend support with amendments. Thank you.
Thank you very much for your testimony. Ms. Burton, you want to go ahead? You're on mute, Ms. Burton. Okay, start all over.
All right, sorry. I'm Evelyn Burton. I'm the Maryland Advocacy Chair for Schizophrenia and Psychosis Action Alliance. And I think it's of critical importance that the language of this bill does not end up having unintended consequences of increasing the use of force by police officers when they're executing the evaluation order. I applaud all the training that Prince George's County gives and their special units, but not all counties are so well trained. And we've definitely heard of peace officers that are really interested in completing this assignment as quickly as possible and returning to their other duties. And that's often not compatible with keeping the evaluee calm and safe and avoiding a traumatic experience. Evaluees, as you've heard, may be experiencing extreme fear due to psychosis delusions and hallucinations. My relative, who I'll call Dan, when psychotic, was terrified of police because he knew that they were really a praying mantis that could eat him alive. So, of course, if under those circumstances, he would try and protect himself and resist any use of force because he would feel like he's being attacked. So the use of force greatly heightens the risk of harm and even death to both the police officer and the evaluee and risk criminalizing them as well. So the amendments I've proposed basically require that unless there's an imminent danger of harm, that the officer use extensively de-escalation and persuasion techniques, and if available, call a mental health professional before force can be utilized. I also question about the renewal for 5 days. If they can't find the person in 5 days, why couldn't it just be automatically renewed without any questions asked or procedures? Thank you.
Thank you so much, Ms. Burton, for your testimony. I'm going to open it up for questions now from the committee. Are there any questions from the committee? Seeing none, thank you so much for being with us today. We really appreciate you, okay? And we appreciate your personal stories and your journey. You have a blessed day. I'm going to call now a panel of favorable, if I may have Ms. Deborah Levi, Courtney Bergen, Michelle Lepshin, Juliana Filkowski. Could you come up, please? Thank you, Brett. It says unfavorable. Yes. It's okay. It's all right. How are you?
I'm well, thank you. How
Good.
are you?
If you could have a seat and get started, please. Thank you so much and welcome to the Health and Government Operations Committee.
Thank you very much. My name is Debbie Levy. I'm with the Office of the Public Defender. Thank you for having us today. We appreciate the difficulty of legislating in this area. And we wanted to point out the difference in the policy that is being presented today is sort of a more watered down.
Give me your name.
Again, my name is Deborah Levy. I'm with the
Okay.
Office of the Public Defender, the
Thank
Director of
you.
Special Litigation.
Mhm.
Thank you. So while we do recognize the difficulty in legislating in this area, we want to acknowledge that the legislation proposed today essentially confuses the issue and waters down the standard of how officers should approach people in these very difficult situations. I wanted to point out that the public safety article, as delegates have pointed out in the last panel, already puts a standard out there that if there is a standard, if force is necessary, it should be reasonable, necessary, and proportional. But I would ask this body to turn to law enforcement as a best practiced guide. And so, for example, I practice mostly in Baltimore City. And if you look at Baltimore City's policies, particularly 1107 and policy 713, petitions for emergency evaluations, the Baltimore Police Department requires first that members of the department use de-escalation tactics when serving emergency petitions. It's a requirement. In addition to the and so we're asking, I guess, if this body wants to sort of wade into this territory and start talking about these difficult issues, do so leading first with de-escalation. And then if the body feels compelled to move forward, then do so in a way that's consistent with the public safety article and also with police training across the state of Maryland that already requires the 3-tiered reasonable, necessary, and proportional force. Of course, we don't advocate for force. We'd ask this body to go de-escalation first, and then if force becomes necessary, be consistent. Thank you very much.
Thank you so much, and thank you for the work you do. May I have the next person, please?
Thank you, Madam Chair and members
you.
of the committee. My name is Juliana Felkowski. I'm an assistant public defender in the mental health division. We represent clients who are certified for involuntary admission after they've been brought to the hospital, most often by police, for an emergency evaluation. We are requesting an unfavorable report on House Bill 1019, and we have submitted written testimony, so I won't get into everything here, but the bill loosens the use of force standard only in the context of an emergency evaluation for psychosocially disabled persons or people who may be suffering from mental illness, and we don't think that's appropriate. An emergency petition is completed to provide an evidentiary foundation or probable cause to believe that a person has a mental illness and is a danger to the life or safety of themselves or others. An emergency petition is meant to be served immediately and within at most 5 days. Police can issue an EP on their own. Mental health providers can complete an EP with police, or a court can endorse an EP and serve it through police or the sheriff's office. An EP is meant to contain the immediate observations of the petitioner to establish that the evaluee currently presents a danger to themselves or others and is currently exhibiting symptoms of a mental illness. If a petitioner is a family member, they could just as easily return to court and request a new EP if they continue to have concerns and an EP was not served. They would still have to return to court if this bill were passed to obtain a ruling from a judge that good cause was shown. So if there is a need for an extension when a police officer could complete an EP immediately in response to a call, we're happy to answer any questions on this bill. Thank you so much.
Thank you. Next, please.
Good afternoon, Madam Chair and members of the committee. Thank you for the opportunity to testify. My name is Courtney Bergen. I'm an attorney and Equal Justice Works Fellow with Disability Rights Maryland. I'm also a Baltimore City resident with a mental health disability who's been subject to an emergency petition. DRM opposes HB 1019 because people with mental health disabilities experiencing a crisis deserve a healthcare response, not a law enforcement response, and federal law already requires this. Police are already permitted to use force in executing emergency petitions, and the public safety article is very clear about the standard that can be used. We are concerned that this bill could increase the level of force and authorize police to use more force than they are allowed to use when executing other duties. We are also concerned that people with mental health disabilities covered under the Americans with Disabilities Act account for 1 in 4 of police killings when police are responding during mental health crises. So we believe this could lead to even more deaths and more disability. The other thing DRM wants to raise is that Maryland schools are frequently misusing the emergency petition process on Black and disabled children. As young as 5-year-olds are being subject to this. Do we really want to allow schools to allow 5-year-olds to be subject to reasonable force for misbehavior? These are often children who have not been found to be in imminent danger, who are being improperly removed from school for minor behavioral issues. And Wicomico County has actually been under a DOJ settlement, and there's been recent reporting that this has been an ongoing issue. So we also have adult clients, often, again, who are Black and disabled. In fact, I just had a call a few weeks ago about a situation like this in Montgomery County. This is not an isolated issue. Police frequently use excessive force. We ask you to oppose this bill. Thank you.
Thank you. Next, please.
Thank you, Chair, Vice Chair, and committee members. I'm Michelle Lifshin with Honor Own of Maryland. I'm here today to strongly urge an unfavorable report to House Bill 1019. Extending the emergency petition time is counterintuitive to the law's intended purpose to provide emergency care in response to a mental health crisis where there's an immediate and current danger or threat to safety. The EP process is designed to keep an individual who's in crisis safe now and provide timely care in the present, not in the future. Authorizing police to use reasonable force during an EP is unnecessary, dangerous, and contradicts our recent legislative efforts towards police reform. Across our peer network, we have heard countless stories of individuals who have experienced detrimental and sometimes fatal consequences resulting from police use of force during a mental health crisis. Following the death of George Floyd, our legislature passed the Maryland Police Accountability Act of 2021 to establish stricter standard of force, permitting police to use force only when necessary and proportional. Police response not only fails to meet the healthcare needs of individuals experiencing one of the most vulnerable times of their lives, but can also dramatically increase risk of arrest and fatal encounters. This is especially true for marginalized communities where a longstanding history of discriminatory practices has already warranted distrust of police. Maryland residents who experience mental health crises deserve understanding, support, and high-quality healthcare. This bill fails to uphold the primary purpose of EPs and creates significant risk of harm. We strongly urge an unfavorable report. Thank you.
Thank you for being with us today and for the work you do. So I'm going to open it up for questions now from the committee. I see first Delegate Woods. Sorry. Delegate Woods, go ahead.
Thank you, Madam Chair.
Nobody couldn't even get the word out. Go ahead.
It's okay. So I have so many questions. First of all, I hear a real conflict in what you presented as what was presented to us today. And my first question, if you will, is can you tell me about your care professionals who are trained to address a person who has a mental crisis and is utilizing an ADW to resist getting the support that they need?
Specifically, at the Office of the Public Defender, who are our folks who are trained?
Whoever can answer the question, who talked about the support teams that they would recommend. I heard the Sheriff's Department very clearly talk about how they are trying to reduce the stigma and shame that is associated with law enforcement. And I heard someone say that you all have support services that would, right. So my question is, can you tell me about those support services who are trained to deal with a person who has an ADW challenge and is trying to be apprehended for their safety and the safety of others?
So could you say what ADW is?
With a deadly weapon.
Who's the best person?
And if you don't know the answer, you can get back to us.
Well, I would just say from the perspective of the Office of the Public Defender, it is a very good question, and I defer to law enforcement. And so the reason that I look to the Baltimore Police Department is because they're under consent decree and looking at best practices nationally in this very difficult area. And so they urge a certain amount of their officers to be trained in mental health responses. The preference in Baltimore, and I know also in Anne Arundel County, is to have folks who are crisis interveners and folks who have special training to respond. And those folks are required with the special training. And I think Baltimore has a goal to have 70% of their officers trained in de-escalation tactics and mental health response. I think that's the goal for 70%. And those folks are all required to first use de-escalation, even in an RDW situation or some other kind of dangerous situation. So that would be, I would defer to their training is that everybody is trained and required first to use de-escalation.
That wasn't.
Okay.
Yes.
My question was more specifically to that person who, as far as I am seeing, is not equipped to handle a person who is a potential major threat.
Yes.
And so I hear what you're saying about your de-escalation person. I don't believe it should be an either or. I believe that it has to be a both and. That is my feeling. So my feeling, and I'm asking you to either tell me yes or no, is that 9 chances out of 10, 9.5 chances out of 10. You need a law enforcement officer, even when you have a person equipped in de-escalation. And the purpose of that law enforcement officer is to do what that person equipped in de-escalation cannot do, and that is to restrain and prevent a potential life-threatening emergency. And I'm just asking if you can speak to, who would be appropriate to speak to that?
I can. I've had clients in similar situations like this. And so I think we need to recognize that there's multiple ways that emergency petitions can be executed. So it can be that if there's like an imminent and evident risk, that police officers can do it themselves. They don't need to go to a judge. They don't need to have a clinician involved to do it. They can just execute an EP on the spot based on their observations. So I think we have situations like that, but then we also have situations where people are going to the courts, which is kind of brought up in this bill, because they're allowed to be valid for 5 days. And then we are talking about extending them. And in situations like that, there's often not in kind of an imminent and evident risk that we're seeing. And so I think those two situations need to be disaggregated a little bit when we're talking about these issues, because I think they're very different situations in terms of just how the process goes. So there's federal guidance on this issue from Department of Health and Human Services that, again, it requires a healthcare response to a mental health crisis. If someone has a deadly weapon, say a gun, and is, threatening others with it, I think, again, that would, on any ordinary basis, we respond to people with what the situation calls for. So I think that would be a little bit different and require police. It doesn't mean it's not still a mental health emergency, but I do think that situation, we talked about the standard necessary and proportional force might call for that. I think many other situations where a family maybe is going to a court and asking for an emergency petition, that doesn't seem justified. And so I think it's, we have to talk about each situation individually, and many states do have models of support workers responding that don't involve law enforcement. They've reduced deaths. They've been much more effective at engaging people without force. And so I think if we want to, be talking about this issue, I really think it would be better to understand the issue and what we're talking about, because this spectrum of when emergency petitions are used are so broad. And if we start applying reasonable force to everyone, like 5-year-olds, then I guess it becomes, I think, very concerning and dangerous. And I think the risk may outweigh the benefit.
Yes.
I'll normally do this, so just call me Delegate Hill for the day. In her absence. In her absence.
I will not call you Delegate Hill, but I will say you are very close to giving us a dinner.
So I promise I'm gonna try to make this real short.
Yeah, you do that.
And let me say, excuse y'all, let me just say, if I provide dinner, it will be gluten and soy free.
Oh,
So
that's
just make
cool.
sure
That's cool.
everybody.
We accept that.
All right,
Accept it.
all right, okay. So my final question, because I did not hear anywhere that this bill is supporting reasonable force for a 5-year-old, number one, or young children. I didn't hear that. Number two, and correct me if I'm wrong, please, I thought I heard it said that law enforcement officers are being taught the appropriate de-escalation techniques. And so where that is relevant, is that not sufficient? And I promise that's it.
It's okay. You're entitled. Go ahead. You're welcome. You still owe dinner. Go ahead. Who's the best person?
I think my practice is about in the areas of policing in relation to our clients. So I would say that you don't want to confuse the issue. If the police standards and the best practices across the country are requiring first de-escalation, force as a last resort, and then reverting immediately back to de-escalation, we don't want a policy in this part of the code that goes right to reasonable force, which is a different standard than in the public safety code. So I would say that it should mirror the best practice of police departments, which is de-escalation first. If you have to use force in this narrow circumstance, reasonable, necessary, and proportionate, and then de-escalation again. What would then, I guess the question back would be, what would be the harm in just paralleling the best practices in law enforcement across the country, recommended also by the federal government? So that's what I would say, is you'd want to mirror that. First de-escalation, if you have to use it, it's narrow, and then again, de-escalation. Because we're in the beginning of a trend of changing the way we respond to folks with mental health issues. And we're trying to get away as a country from criminalizing mental health. So we want to be consistent with that and lockstep with those new trends versus sort of going backwards, where we used to look at force. This is scary for everyone. Force first because we're afraid of this scenario.
Yield to the bill sponsor.
Yeah,
Madam
and
Chair.
I know that the sponsor of the bill did speak with you last week, and she requested amendments from the public defender's office. And the public defender's office basically said that you're going to oppose the bill. So I have to tell you, I understand your position. I used to be a public defender.
Well, thank you.
And I used to be a prosecutor. I done both. And I won't tell you which one I prefer, maybe offline. But I can tell you that what we try to do is, and I know there are times when we cannot agree,
Yes.
but you cannot say no all the time. It is important to come to the table when our members call you and see if there's any way that you can, that is reasonable. Come on board and have, amendments. I understand your position on this and I respect it. But I think it's important that we, moving forward on when a member calls you, if you're able to compromise or find some way to have a happy medium, even if you walk away and you're not happy, if you could do that, that would be great. Because I know the work you do, and you don't need to reply to me. I know the work you do, okay, and I respect it. But that is really important, and of course, when the delegate testified, she said she was open to amendments, okay? No one wants 5-year-olds to get attacked, right? But when we use those lines, that is what those are sound bites that people remember. And we have to try not to exaggerate, because we live in such times that we're so polarized, right? That the words have meaning and they matter. And I think that's important. And I'm going to get off my soapbox. I usually don't do that here, but I think it's so important that we do that. I'm going to go to Delegate Bagnall, and I do appreciate each and every one of you. You're doing God's work, all right? You deal with very tough cases. You really do. And I'm not going to even ask you what your caseload is, because I remember what mine was. So go ahead, Delegate Bagnall.
Thank you, Madam Chair. And you pretty much said what I was going to say, but and again, thank you for your work. I just want to make sure that I have captured the concerns, because I have already spoken with the bill sponsor, who is amenable to taking the public safety standard, to codifying the best practices of de-escalation in the legislation to clarify that that is the intent. And also to clarify that the petition is to be executed expeditiously and that the extension would only be for good cause. Because I heard that there were concerns about having that ability to extend it might mean that they're waiting that 5 days. And I don't think that was the intent. So if we can work on clarifying language, and I'm not going to ask about your position, but it just, if there's anything that I missed in those concerns, please let us know.
Am I allowed to?
Sure.
Well, and I do appreciate everybody's comments, and we do try to work with the legislature as much as possible and anybody to reach agreement, even in plea bargaining. You know, we're always trying to reach an agreement to make parties happy, everybody. And I think my colleagues in the mental health division will speak to the extension. But leading forward with de-escalation would certainly be something that we would be accepting of, I think, for my agency, if I have agency to speak to that. But then I would defer to my colleagues. I think it was the the 5-day extension that was the harder piece for us.
So, and if I can just say, what I would like you to do when we're done with this bill hearing.
Yes.
I like the delegate to get up from her seat and meet you outside so you guys can agree when to meet and sit down and work on
Okay.
it. Is that okay?
Yes.
All right. Go ahead, Delegate Bagnall.
If I could hear from the mental health division.
So we did look at alternative language. And so in our written testimony, we've tried to explain why we didn't feel that this part of the code was the place for this language. So we're certainly open to continuing the discussion. Our position is that an EP is already a very flexible tool. It's not an onerous barrier to getting someone into a hospital. If the police are struggling to serve an EP, there's certainly the opportunity to execute a new EP. The reason why an EP is valuable for the evaluee is that it is the basis of the probable cause for having them taken to the hospital against their will. It's important that we have immediate facts regarding why they met criteria. So that's why I don't love the idea of extending an EP, because then we're looking at the original facts versus the facts that related to the day that they were picked up. So that's our primary concern is related to that immediacy issue, but we're happy to continue the discussion. Thank you.
And I would like you to join that meeting. Okay, thank you. Delegate Williams.
Yeah, and I guess my question is just kind of a follow-up to that. If the bill sponsor is open to the good cause language, would that satisfy the concern you just raised about having the EP reflect kind of the facts as they presently are? You know, I get your point that it's an emergency. You want to make sure that that emergency continues to exist when the EP is served. And so if the sponsor is stating that she's open to the good cause, adding that to the language, would that alleviate Yes. Okay. Would that alleviate the concerns that you're raising?
So respectfully, no, because the issue is really that on the EP itself, it is a one-page form and has questions on it for the symptoms of the mental illness and the behaviors that are demonstrating dangerousness. And so if there is a good cause hearing before a judge and a judge finds good cause, we've actually had issues subpoenaing the hearing recordings of emergency petitions because they are sealed. So they're completely sealed, and we struggle to get access to that. We also struggle because it's a very tight turnaround. So there's no access really to what is happening in court regarding the ex parte findings that the court is making with regard to the EP. So it's really just what the petitioner writes down is all that our attorneys can see and all that our clients can see with regard to the basis for the emergency petition. So a good cause hearing would not give us any insight into why that extension was happening. Does that make sense?
Delegate Olson.
Thank you. So there's an amendment that I worked on with the judiciary, and you may not have had the benefit of seeing that, but they have to actually file a motion and put in writing what the good cause is. So it's not just they're coming in saying, hey, I need an extension. They have to actually spell out what the reasoning is. And the reason the extension is needed is because sometimes you can't find people and the issues are still presenting. And instead of having them go to court and open up a whole brand new case, it's more costly for the court to do that. You can just do an amendment or ask for an extension instead of opening a brand new case, but you still have to prove that the emergency is still there and presenting. So I'm happy to work with you all on language to clarify what needs to be done the same way I work with the court to clarify that they needed to file a motion and what needs to go in there so we can work on it. But it's something that's needed because when people can't be found and they're still displaying the behavior that necessitates the medical need, we need to be able to help them without making it too onerous. And I'd be happy to even work with you on making sure you can get those hearings because I think it's important in the criminal justice or in the justice process, not the criminal, in the justice process that everyone has access to the information they need. So I'm happy to work with you like we talked on Friday on whatever amendments that can get you all to a point of you can live with it because I know you're not gonna like.
Okay. Any other questions? No? Okay. Don't be afraid to ask. We'll give you a free pass, no dinner for you. Okay. All right. I allow a little more than I usually do just because I know that these bills are usually very difficult, especially when these parties are involved. So this actually concludes the bill hearing on House Bill 1019, but I like Delegate Alston and Bagnell to please go outside, and I like them to meet with all of you outside. Okay, thank you. And thank you again for the work you do, okay? We appreciate it. Next, we have the following bill. The following bill set, and thank you to Judiciary for joining us. We appreciate it.
We're very glad we get out of here about buying everyone dinner.
Thanks. So we have House Bill 784 is actually it's gonna be withdrawn. So that one you can actually take off your list. Next, we have House Bill 1143, and then we're gonna call you to House Bill 1143. Delegate Bandari, Emergency Medical Services, Maryland Emergency Department Wait Time Reduction Commission and Standardized Protocols Establishment. His panel is Anna Palmisano, Jonathan Crum, Marie Grant, if you can come up. And I want to thank the Department of Health and the HSCRC for being so patient. They have been waiting like all day to be called on this bill. So we're very grateful, okay? Usually I call when I see you guys, I try to put you first, but today I didn't have a lot of flexibility. But I thank you, okay? You want to get started, Delegate?
Yep. Thank you. For the record, I'm Delegate Bandari, Madam Chair, Madam Vice Chair in the STEAM Health and Government Operations Committee. I stand before the best committee, grateful for our shared dedication to improving ER wait time in our state, particularly addressing our state's pressing challenge of the longest emergency department wait times in the nation. Quick context to this bill. Last year, this committee collaboratively initiated took the initiation by, I actually sponsored a task force bill, which led to the formation of an informal work group under the guidance of then Senator Melanie Griffith, Chair of the State Finance Committee, and our Chair, Fania Melnick. Sincere thanks to Maryland Hospital Association for their leadership in this critical initiative. And this initiative was in response to the critical challenge, the longest in the nation, according to the Center of Medicare and Medicaid Services, CMS. Our aim was to assemble a diverse coalition of stakeholders, including healthcare professionals, patient advocates, and representatives from both the Maryland Health Department and Maryland Health Service Cost Review Commission. This collaboration focused on identifying the root causes of the delays and formulating effective strategies to address them. The insight gained have informed our legislative effort this session. And I had a pleasure of being together on that task force with wonderful delegates Kathy Shaliga and Delegate Martinez. This bill aims to establish the Maryland Emergency Department Wait Time Reduction Commission. This commission recommended to this committee on January 17th of this year, and further developed through my participation in the work group, is tasked with developing strategies to improve emergency department efficiencies and patient care across Maryland. And this represents a critical step in our collective efforts to address these prolonged wait times through standardized operational protocols, advanced technology solution, and collaborative healthcare practices. The ongoing support from the Maryland Health Department, the Maryland Health Service Cost Review Commission, and the Maryland Hospital Association, whose contribution will be very, very instrumental in the successful policy outcome. As we propose the establishment of this commission, we're not just addressing a current need, but laying the groundwork for the future, where all our citizens have access to timely and high-quality emergency care. Thank you again, this committee, for the character, commitment, and confidence to improving ER wait time for the people of our state. I look forward to working alongside all the stakeholders to bring the positive changes envisioned by this bill. And I do have, you want to go first? I do have Anna, Palmisano, Jonathan, and Marie.
Thank you, Chair Pena-Melnick and Vice Chair Cullison and committee members. I'm Dr. Anna Palmisano. I'm a microbiologist and director of Marylanders for Patient Rights. We're a coalition of healthcare advocates, and I'm testifying in support of HB 1143. I'd like to thank Delegate Bandari for sponsoring this important bill and the many co-sponsors on HGO. We are now in our 8th consecutive year of ranking worst out of 50 states in the length of ED wait time. And many Maryland families have been impacted by these long wait times. And I believe that as community leaders, you have heard some alarming stories from your constituents. Some patients seeking emergency care are waiting over 24 hours to get help. Some are leaving without getting the help they need. And some are so afraid of the long waits that they won't go to the ED when they need care. So this is really an intolerable situation. Not only is it hard on patients seeking emergency care, but it's also hard on the overburdened ED staff. HB 1143 articulates a pragmatic and sensible strategy to address Maryland's excessive emergency wait times. The proposed commission has clearly stated, actionable, and timely goals. Those goals will include development of strategies and protocols to improve efficiencies in our EDs while enhancing patient care. The membership of the commission includes key stakeholders while remaining at a workable size to ensure progress on difficult and complex problems. Marylanders for Patient Rights asks for a favorable report without amendments for HB 1143. Thank you.
Thank you. Thank you for your work. Who will be next?
Jonathan,
Thank you.
HSCRC.
Thank you.
Wonderful.
Thank you, Madam Chair and members of the committee for the opportunity to testify in support of House Bill 1143 with amendments. My name is John Crom, and I'm the Executive Director of the HSCRC. Long ED wait times, as you've heard, have a tremendous impact on Maryland patients, and it is a top priority for the Commission to drive impact toward improving ED wait times and patient experience in Maryland hospitals. HB 1143 complements and can accelerate work that is already underway at HSCRC to address ED wait times, including analysis of the root causes of ED wait times. Also, as we turn to the development of programs and incentives designed to reduce ED length of stay and wait times over the coming years. One of the critical aspects of long ED wait times that we recognize in the work that we're doing is that it is a multifactorial problem requiring a systemic approach. So improving ED wait times in Maryland will require us to look for opportunities to provide access to services outside of the ED to prevent the need for emergency services wherever possible. We'll have to improve how patients move through and receive care throughout the entire hospital. And then we need to ensure access to post-discharge resources and post-acute care in a timely fashion, right? So we commend the sponsor for his work and dedication to this really important issue. And we stand ready to work on this in partnership with the department. We would respectfully submit some amendments to the bill that we believe will ensure the work of this new commission will take a whole system approach to addressing ED wait times and improving the health of Marylanders. Thank you so much for your time, and happy to take any questions.
Thank you.
Thank you, Madam Chair, Madam Vice Chair, committee members, Marie Grant on behalf of the Maryland Department of Health. Thank you, Delegate Bandari, for your introduction of this important legislation and keeping this important issue before us. I just me too to everything Mr. Crum said, or Dr. Crum, sorry. But just also would like to reiterate the amendments that we are going to propose to the committee will propose that the Department of Health, along with the Health Services Cost Review Commission, staff this commission. And as Dr. Crum noted, really take that whole systems look approach at this issue. I think we got a really great start at looking at this over the past year, but I think clearly this is an ongoing issue. There's multifaceted reasons behind it, and it's going to take a multifaceted look and approach to solve it. So again, happy to answer any questions and look forward to working with you all on this legislation.
Thank you. And I want to thank you for working with our members on this issue and many others. Okay, what the public doesn't know is how hard you work. And I want to tell you thank you, okay, on behalf of our committee. I'm going to open it up for questions now. Are there questions for this panel? Delegate Gazzoni.
Thank you, Madam Chair.
You're welcome.
Just a couple sort of logistical kind of things. Do you think that by you all staffing it through the amendment process, that's going to affect the fiscal note?
Yes.
Okay. And then secondly, I see from at least in the text that this is not something that has an end date to it. So I'm just curious whether that's sort of what that looks like. Is this going to go on ad infinitum? What would success look like, I guess?
Yeah, one of the amendment is to have a sunset of 3 years,
okay,
which I accept. Yeah.
Thank you.
Any other questions? Those were great questions, Delegate, because it reduces the fiscal note and it has a sunset, because hopefully by then we will solve it, right? So I don't see any other questions for this panel, but I do want to take a minute to say thank you to Delegate Bandari for taking the leadership along with your partners at the table, because frankly, no one else was discussing this issue. And we kind of left it there, right? We had a presentation and we have not really addressed what we're going to do. And I have to tell you, our constituents, everyone, and those of us that have gone to the ER see the problem. So thank you for continuing to work on it, because we need to. And I want to thank you on behalf of our committee for doing that work. Okay, all of you. And Delegate Bandari, thank you for your leadership. I hope you have a blessed afternoon. And again, so sorry you had to wait so long. It usually is not that way, but for some reason I know what happened. We got off the floor late. That would do it. And it's going to happen more often. So please be patient with us, because we have 41 days left? Who's counting? I am. I see Matt back there raising his hand. All right. Thank you so much, everyone. Next, I'm going to call Luke Pinton. And that's it, I think. Oh, yes, that's it. All right, you're it.
Good evening, Madam Chair,
Good
Madam Vice
evening.
Chair, members of the committee. I hope I'll be very, very brief. My name is Luke Pinton. I'm here on behalf of the League of Life and Health Insurers of the state of Maryland. I want to thank Delegate Bandari for bringing this bill and for this committee for working on this issue increasingly over the last several years. Health insurers are committed to working to find a solution, find solutions to reduce wait times and ensure that patients have access to the care they need. For that reason, the League respectfully requests an amendment that adds a representative of a health carrier to the list of gubernatorial appointees to the commission. Thank you for your consideration.
You're welcome. And that's an easy ask. Okay, any questions? Seeing none, thank you so much. You have a great evening. This actually concludes the bill hearing on House Bill 1143. Next, we're going to go to House Bill 829. Oh, Delegate Austin is outside. Yes, will you please? Just hold on one second, everyone. Because it only has 3 witnesses and then the other one has 14. So try to be fair. If you're wondering, how do we decide what's the order? Well, if you have a lot of witnesses, you're gonna have to wait a little. What is it? Wait a lot? Well, you know, we try to learn the bill, ask the questions, right? Be engaged, which matters, right? And that takes time, and we give everyone the same respect, right? And attention. It is actually. This gives you a breather, clear your mind. Stretch, pretend you're in the islands for a second. What I'm going to do is, I have the Maryland Department of Health, Sarah Case Heron, will you please come up and why don't you present the bill to us? Tell us what the bill does and why you're amending it. And then Ms. Pat Fletcher, who's coming, that will get us started. No pressure. No, and you get extra brownie points for that. Go ahead.
Do I need to turn this on or is it?
No,
Okay.
it comes on.
And it's my first time testifying, so
This
no
is your
pre-
first time testifying? What a way to start.
Well, good afternoon, Chair Pena, Matt Melnick, and committee members. Thank you for having me before you today to testify in support with amendments for HB 829, Public Health Service Sector Employees Mental Health First Aid Training. As I'm sure Delegate Alston will note, the COVID pandemic really has highlighted a concerning rise in mental health needs across all ages, from youth, young adults, and adults. And these needs have greatly increased with the significant impact on pre-existing mental health issues. And as a result of these needs, we do support the purpose of HB 829 to provide virtual mental health training to increase mental health awareness and literacy. Research has shown that mental health literacy positively impacts people, and it helps them identify resources, enhances confidence and self-efficacy, and reduces stigma, increasing the likelihood that they will seek mental health services. This bill seeks to have mental health first aid training be more available and be something that MDH would assist with developing both the training and to collaborate with the Maryland Department of Health and the Public Service Commission to create a public awareness campaign related to the mental health training. Our main amendment here focuses on the specific mention of mental health first aid as the training being utilized. That's a proprietary training that is trademarked by the National Council for Wellbeing. As a result, our suggestion would be to have the department itself develop and post a virtual asynchronous mental health training and then do the collaboration on the public campaign.
Okay, you did extremely well. Are there any questions? It's her first time. The first time.
Oh, so
we do that to people, but seriously, thank you for stepping up and doing this. And I know Delegate Kaiser has a real question for you.
Thank you, Madam Chair. I heard you say at the end of your testimony that your amendment is to change it because the mental health first aid is a named thing out there.
Correct.
But being that it's a named thing out there, it's something that's already been created, pretty well done. I did it through my job at the University of Maryland. So I would ask, would you then mean to be creating something new?
So the goal would be to create something that is very similar. And part of the reason that we're suggesting this is because it is a trademark piece. Part of the fiscal note that we originally noted for this bill was based on the cost of that proprietary training. And we think that if we can develop a similar asynchronous training, that will help bring down the potential fiscal impacts of the bill.
Okay, and I was gonna ask that, did that amendment help that fiscal note? Because it's a little bit high. So
Follow up,
Delegate Kaiser.
if I could.
Yeah.
I appreciate that answer. I understand that paying for something external costs money, but then to create it internally isn't without cost. Given time, resources and everything else, and while that something like that doesn't usually make it into a fiscal note, where do you all see that cost as being?
So we do believe that there would still be a cost, but that it would be considerably lower. And we do understand that this bill is subject to the budget and would work to develop the training within budget constraints.
Yeah, and and I saw that it says subject to budget.
Yeah.
I saw that language in there as well. All right, any other questions? Yes, Delegate Woods and Vice Chair Collison. Oh, it was? Okay.
Thank you, Madam Chair. Thank you. I am a certified mental health first aid instructor, youth and adult. I'm also a licensed social worker. And in my full-time job, what they have done is to incorporate the mental health first aid instruction in our programs, in our training program. So that in itself would help to greatly reduce, right? Because now it becomes a part of my job. That would greatly reduce the associated costs, which has a lot more to do. I mean, the manuals are what, $18, $19. It's the cost for the instruction, the cost for the the video projector and there's not even a great cost for the curriculum, if you will, because now it's primarily online and available that way. Would that not be a sufficient response?
I think that the goal of creating a similar training would be because, and I apologize, I do not have the funding, the cost in front of me, but the goal of creating a similar asynchronous training would be to hit the same goals as mental health first aid, but to not be beholden to that kind of proprietary piece. And it gives us the added benefit of potentially being able to tailor it to our needs, things like that.
Madam Chair, thank you. So since I have become a certified instructor, they have now already curtailed the program to the effect that they have specified trainings for specified groups, specialized training for specialized service providers, public service providers, for law enforcement. They even have now the training for students. I'm just a little curious as to what it is that you feel should be, because I hope nothing would be taken away from the mental health first aid training.
And I can get back to you with more details on how we see the training as being somewhat unique and what the goal there would be. But I do know that part of this was to have that mental health awareness and skills building training, but accommodated within kind of budgetary constraints. Yes, we'll work on that. Thank you.
Thank you. I have to say, Delegate Olson, that your witness, Sarah, did an amazing job. I don't even know that you need to testify. She presented what the bill does. She explained the amendment. We were all wondering about the fiscal note, and she said the amendment will bring it down. So she did an amazing job. But give us your testimony now.
Yes, since it was beautifully written, I will do that. Thank you. I'm Delegate Tiffany Austin, here to present House Bill 829. Anybody can have a mental health crisis at any point in the day. These instances can occur anywhere, whether they're going to buy groceries, going to get a haircut, riding in an Uber, a taxi cab, to the extent they still exist. The possibilities are endless. In a situation where this occurs, how one person's employees in these situations react or know what to do. Do they even know? How can we ensure that they are getting the proper care? Employees need to be able to identify signs of mental illness, substance abuse disorders to ensure that the safety of not just the individual, but of also themselves and those around them. So what this bill attempts to do is create a mental health, we're changing the name, which you've already heard, but it says mental health first aid program to all service sector employees to ensure that mental health awareness and literacy are available. Service sector employees include cashiers, retail store employees, taxi drivers, transportation, bartenders, beauticians. The possibilities are endless. Currently, the law does not require that service sector employees undergo any kind of training in this area. And this too is not a mandate. It is voluntary. It is optional. I don't believe in mandating things, but I do believe that this can help. If enacted, this bill would increase mental health care awareness and literacy across our population. There have been a high number of people who have been experiencing mental health or substance abuse challenges, especially since the surge of the COVID-19 back in 2020. In conclusion, this bill is imperative. It would help many individuals across the state and increase the number of people who can recognize and assist other individuals in need. This bill will also decrease the stigma attached to behavioral health challenges that need to be addressed. Therefore, I ask for a favorable report of House Bill 829. And I also want to thank my community outreach person who is a former member of the school board, Miss Pat. I call her affectionately Miss Pat. She'll give you her full name when she testifies. But this bill was her idea based on her background and training. And so I'm happy to be able to present it on behalf of her today.
Okay. Good afternoon, and thank you for being patient. I saw that you waited there all afternoon. Thank you so much.
It was really interesting and eye-opening. I'm sitting there going, oh my God. But anyway, my name is Pat Fletcher, and for over 26 years, I worked in mental health with the DC government. I started off as a unit clerk, secretary, mental health counselor in neighborhood health clinics. I was a social service representative in schools and clinics, therapeutic recreation specialist, and retired as a forensic psych technician. I provided individual and group therapy to children, adult, and adolescents, family therapy, substance and alcohol groups, playroom therapy, gross motor and perceptual testing, intake, treatment plans, and case management. And guess what? I had no college degree in performing these duties. So how did I do this? The district government provided intensive, ongoing, in-service training in partnership with Howard University, Maryland University, Townsend University, Federal City College, and visiting psychiatric facilities such as Shepherd Pratt here in Maryland. It's totally different now than when I went there. Hudson River Side Hospital in New York City, which is closed, in St. Elizabeth's. But in New York, we learned and discovered that people pour their hearts out to bartenders, beauticians, cab drivers, and teachers. And what New York City did was they provided training to these individuals to recognize when individuals were in distress. And they provided cards that they handed out. And these individuals would go and get the services that they needed. And the district, we brought it back to the district and did the same thing. And what we discovered that although our caseload increased, the crisis situation decreased, meaning that people had to be on medication, they had to be hospitalized, intensive therapy, that decreased. So I want to commend Delegate Austin and her colleagues who co-sponsored this bill for being visionaries in the mental health field. This bill will catch individuals before they get into crises. We're always talking about crisis intervention and the crisis center. This is prevention, and it will help so many people. So I'm asking you all to support this bill.
And thank you for caring, we could tell, and for being here with us. Really makes a difference. I'm gonna open it up for question, although Sarah took them all for you, Delegate. Any other questions that Sarah did not get to from this committee? All right, Delegate Woods.
All right, I'm back, Delegate Austin.
You definitely owe dinner.
Y'all get me in all kind of trouble today. I just really, I hear what you're saying. I definitely understand, but I'm just concerned that perhaps we're reinventing the wheel, because again, as a certified mental health first aid instructor, even since I was certified, they have really tweaked the training, and it is intervention as well as crisis support. And so I'm just a little trying to understand, and I guess maybe the question was answered, what do you see to be the differences? Because now mental health first aid has expanded so much. We know that has over 4 to 5 million people have been trained in the United States, with a number of other countries that are getting it. It's like, hitting fire. People are doing it. People are seeing very positive outcomes. And so I'm really interested in, I certainly support the intent of your bill, but really, really interested, not to negate it, just to understand a little tweaking. And thank you also for your wonderful information.
I'm sorry, I might not be understanding. Are you saying not the mental health first aid, but what the health department wants to do? Are you asking what the difference is?
Correct. I'm asking I'm reiterating, because I realized I asked it. Since I already owe dinner, I was just reiterating.
And dessert too. But
and dessert too.
So I would say that I trust the health department to put together a program that our state can afford. It's affordability, right?
Okay. You're welcome. You got it. Yep, all of it, the whole enchilada. Anyone else? Oh, Delegate Taveras.
Thank you, Madam Chair. I just want to say it's so good to see you, Miss Pat. I remember sitting in your kitchen talking up a storm. So I really appreciate you. Thank you for always being engaged and always being present in the community. I really appreciate that. Thank you.
So we have no other questions from the committee. Just want to say thank you, and everyone that is still waiting to have their bills called. We have 2 more. I want to say thank you on behalf of the committee, okay? And Sarah, you did great. You're always welcome here. This actually concludes the bill hearing on House Bill 829. Next, we have Delegate Fellmark, who has been waiting patiently, House Bill 933, and this is her panel. Will you come up? Adrian, Tania, Jamie Brill, Johnny Silberman, and Nikki Highsmith-Burnick. Am I right that this is your panel?
Yes, thank you.
And if you will be so kind and pull up a chair so she can have you there. I am going to have to step aside for a second to meet with the health department, but my wonderful vice chair is more than capable, will be kinder than I am. She's going to preside over your hearing, okay?
I don't believe that's possible, but thank you, Madam Chair.
Welcome to our committee, okay?
Thank you.
And thank you for being so patient.
Absolutely.
All right.
Absolutely.
Yep, there you go. Thank you. You can get
Thank
started.
you. Thank you, Madam Chair, Madam Vice Chair, members of the committee. For the record, I'm Delegate Jessica Feldmark, and it is my pleasure to be presenting House Bill 933 to you today. I want to start off by thanking this committee for all of your efforts dedicated to mental and behavioral health in our state. I know that you all spend a lot of time on these issues, And just want to thank you for all the work you've done, including helping us stand up a tremendous 988 system in Maryland. And I know you all are already familiar with 988 as our suicide prevention and mental health crisis helpline, and that you really understand probably better than most how important it is to give folks easy, instantaneous access to the care they need. You know, a few weeks ago, I was visited, as I'm guessing many of you were, by constituents from my district who are members of NAMI. And this was one of their priority bills. And in talking about it, they shared a statistic with me that I actually had not yet digested. Looking at the volume of 988 calls and chat and text messages from May of 2022 to May of 2023, we saw call volume increase by over 40%. We saw web chat volume increase by over 50%. And those are huge growth numbers, right? We saw text volume increase by over 900%, right? And think about who are the folks who are most likely to reach out by text. It's not me, right? I've learned to say of a mindset rather than of an age, but of a mindset where having, having these tough, emotional, vulnerable conversations via text is not a very attractive medium, right? But we have a whole generation of native texters who are reaching out for help. And we need to make sure that when they have the motivation to reach out, or when anyone has the motivation to reach out for help, that text or call or chat message is responded to quickly and capably. And to do that, we need funding, right? We need to ensure long-term stable funding for 988. And that's what this bill does. With a minor telecom fee, minor, 25 cents a month, $3 a year, not a lot of money, to make sure that when you or a loved one needs that assistance, they find someone on the other end of that line who is qualified to give them the care they need. And I think it's really important to have a dedicated funding source, right? We have, over the past couple of years, funded the 988 Trust Fund. That's great. But to have a dedicated funding source is important because this is a tough budget year. We know we'll have more tough budget years in the future. We don't want our entire mental health community to have to focus their efforts on fighting for funding for 988 every year when they could be helping advance in other areas. So I do, with that, want to just turn it over to my panel, but I thank you. I look forward to any questions and conversation, and I respectfully ask for your favorable report.
Thank you, Delegate. Who would you like to go next?
It'll be me. Good evening. I guess that's where we are in the day. I'm Adrienne Bridenstine. I'm the Vice President of Policy and Communications at Behavioral Health System Baltimore. We are a nonprofit organization that serves as the local behavioral health authority of Baltimore City. And we also convene a statewide coalition called the Fund Maryland 988 campaign. Your down payment of $20 million over the last 3 years for 988 has really helped to strengthen our system. Maryland's 988 helpline network consists of 8 call centers and 1 regional partnership. However, only 3 of those call centers answer text and chat, and you heard how much that has increased over the past years, several years. Statewide calls have increased 60% since the launch, and text since the launch has increased 14-fold. So it's a little bit higher than what Jessica just shared with you. We now receive over 60,000 calls per year. Our call centers have managed this increase well.
likely because of the investment that this body has made over the past several years. We've improved our state answer rate, so we're answering around 90%, which is where the federal government wants us to be as a state, and we reduced the overall answer time. But keeping up with demand will require investments, especially for a 24/7 resource like this that is similar to 911. 988 and crisis services, as you have heard and as you all know, reduce overall healthcare spending costs and costs to local law enforcement. This committee knows very well that many people end up in our hospital emergency department. We heard about that earlier this afternoon. So we know that this can save money in terms of healthcare costs and for law enforcement. With a robust 988 helpline and crisis services, people are supported in the communities and they're kept safe in their homes and in their communities. And that's what we want. So a dedicated funding for 988 through a telecom fee is reliable regardless of the budgetary or political environment. Congress gave us this tool. Let's use it. We urge a favorable report.
Thank you. Next, please.
Thank you, Madam Chair and members of the committee. My name is Tania Reddick, and I am honored to serve as the 911 Director for the City of Baltimore. I am here to provide a testimony in support of House Bill 933, which focuses on critical partnership between Baltimore City's 911 and the 988 helpline. This partnership was established following a consent decree with the U.S. Department of Justice in April 2017, prompted by identified issues within the Baltimore City Police Department regarding the handling of behavioral health crisis. In response to the decree, the city conducted a thorough assessment to pinpoint gaps in the behavioral service system and proposed solutions. As a part of our dedication to addressing these gaps and improving support for those experiencing behavioral health crises, the City of Baltimore initiated the first in Maryland 911 behavioral health diversion program in June 2021. The primary goal of this program is to connect individuals 18 years or older that's experiencing behavioral crisis with the most appropriate and available resources when they call 911 for assistance, thereby reducing unnecessary encounters with police, fire, and EMS personnel. To achieve this, 911 diverts certain behavioral health related calls to the regional 988 helpline, staffed by trained mental health clinicians who can effectively resolve calls over the phone or dispatch a mobile team of clinicians responders. The partnership between the City of Baltimore and 988 helpline is crucial because it has the potential to lower public safety costs and divert calls from 911, averting costs from first responders. Since the program, over 1,000 calls has been diverted, saving time for BPD and BCFD, amounting to well over 500 hours redirected to focus more on emergencies. We are committed to continuing this expand vital work, but we also need your help to have adequate staff and staffing. Therefore, I urge you favorably to support House Bill 933. Thank you.
Thank you. Excellent timing. Is it Jamie Brill there?
Good evening. Thank you so much for having me. My name is Jamison Brill. I am the Call Center Director of Community Crisis Services Incorporated. We're a nonprofit organization based in Hyattsville, Maryland. We serve individuals in need 24/7 in both the state of Maryland and across the nation. Our particular center serves callers and chat visitors to 988 from Southern Maryland, but we also serve as part of the 988 regional backup Spanish phone and video phone subnetworks, which there are only a couple centers across the country that are part of each of those subnetworks. So through those, we provide backup coverage to other 988 centers in other parts of the country. We provide phone services in Spanish, and we provide video phone services to folks who are deaf or hard of hearing. So the expansion of funding to 988 has been transformative for our center in recent years. So through this, we've been able to expand our quality assurance team, making sure that the support we're offering on 988 is top notch. And we've been able to hire purchase needed technology for our staff. We've been able to raise staff wages and salaries. and generate more full-time and fully benefited positions for our staff members. So this has been huge for a nonprofit organization in which, oftentimes it's a small number of leadership overseeing a large number of workers and wearing a ton of different hats. We've been able to generate webs of support for our staff members in order to increase retention of our workers. However, we do need further stable funding in order to keep this moving forward. Also, in order to develop our workers, retain our workers so that we have experienced, confident, empathic people staffing our lines 24/7. Thank you so much.
Thank you. Next, please.
Hi, good afternoon. My name is Janie Silverman. Madam Chair and Committee, good afternoon. Thank you for allowing me the opportunity to testify this afternoon in favor of HB 933. I am here to represent NAMI Metropolitan Baltimore, where I serve as a volunteer and advocate. In my free time, I ballroom dance, sing, and spend time with my family and friends. I have lived with a mental health condition since I was 29. I was diagnosed with bipolar at that age. I was hospitalized twice with manic episodes and anxiety. In recent years, I have experienced panic attacks that have been hard to control. During a recent panic attack, I reached out to 988 and the responder listened carefully, grounded me, and made sure I was okay. If 988 was not there, I would have called 911. Police should not be the first responders to a mental health crisis. A mental health crisis should be met with a mental health response. 988 followed up with me the next day after my call, ensuring I stayed safe and well. I ask that you pass HB 933 to ensure that this critical resource line be funded for all Marylanders.
Thank you very much for sharing your story.
You're welcome.
Is that Nikki Heisman-Vernick?
Yeah, good evening. Thank you, Madam Chair, and to all of the committee members. Again, for the record, I'm Nikki Highsmith-Vernick. I'm President and CEO of the Horizon Foundation in Howard County. And I would like to extend my gratitude to Delegate Jessica Feldmark for sponsoring this bill and to many of you on this committee who are co-sponsors. The Horizon Foundation is the largest independent health philanthropy in Maryland, and we are committed to a Howard County free from systemic inequities where all people can live abundant and healthy lives. We've been a strong supporter of 988 and have worked with many community partners to expand crisis services, not only in Howard County, but in our surrounding region for those experiencing mental health challenges. But I'm also a wife, right? A daughter, a mother, a neighbor. So I just want to go back in time a little bit before we had some of these services in place, like the service providers that are doing such amazing work. A quick story about one of my neighbors. My neighbor's daughter began to struggle with mental health signs and symptoms late in her teenage years. Mom and dad were working to get an appointment with a mental health provider. I know you've heard this story before. It was taking weeks. And in that time, on one Friday night, she contemplated suicide. And she didn't have a texting capability at that time. But mom knew the number of our local hotline run by Grassroots Crisis Intervention Center. She called. They wanted to send out a mobile crisis team, but the team was already deployed. They didn't have backup. So the hotline called the police. And when the police arrived, because her daughter had recently turned 18, she was handcuffed, put into a police car without mom or dad, and taken to the local emergency department, where she sat, as we've heard tonight as well, for many hours, 12 to 18 hours, again, without mom or dad, because she had just turned 18 before she was given a psychiatric evaluation. And I think it was 24 hours into the ordeal before she actually saw someone for her mental health concerns. So let's not go backwards, let's go forward. Ensuring a dedicated and sustainable funding source to support local crisis centers and to support crisis services is critical to meeting the needs of all Marylanders. Thank you very much, and I urge a favorable report.
Thank you very much. Questions questions for this panel? Delegate Woods.
I'm already at dinner and dessert. Thank you, Madam Chair.
We're going on to the next night.
Thank you, Madam Chair. I just simply want to say first and foremost that I think that this 988 program is one of the best things that's happened to us in the United States. And I certainly agree that we want to reach out to address the mental health challenges first. And so I just want to commend you on your work. Thank you for your testimony and ask you all, isn't it so?
I think the answer is yes, Delegate.
Thank you,
Any
Delegate.
other questions? Delegate Kaiser.
I'd just like to say, I think the committee owes Delegate Woods a dinner for asking such great questions today.
There's a turnaround. Any other questions? Seeing none, I say thank you very much again for your testimony, but also for your service, Delegate. Thank you for bringing us the bill. And I'm going to call up another panel now. So thank you all.
Thank you.
I'd like to have Ann Geddes, Lila Martin, Carlos McCall, Andrea Brown, Pegeen Townsend, Ashley Towler. I think that'll be everyone. Oh, no. And then we have the virtual. Here are the real persisters. Thank you for your patience and for waiting so long today. Who'd like to go first?
Sure.
Go for it.
Right. Chair, Vice Chair, and members of the House Health and Government Operations Committee, thank you for this opportunity to testify in support of House Bill 933. My name is Lila Martin, and I am a graduate student at the University of Maryland School of Social Work and an intern at Maryland Citizens Health Initiative. Our organization advocates for policies that ensure access to quality, affordable health care for all Marylanders. 988 is a critical step forward in mental health care. It aims to reduce the stigma surrounding mental health, improve accessibility to services, provide timely crisis intervention during emergencies, and prevent suicide. In my experiences as a student, I've witnessed firsthand the profound mental health struggles endured by my peers and loved ones. Accessible crisis intervention stands as a cornerstone in addressing these challenges. Thank you for your time and attention to this matter. I respectfully request a favorable report of House Bill 933.
Thank you very much. Next, please.
Hi, thank you, Madam Chair and committee members. I'm Ann Geddes with Mental Health Association of Maryland. MHAMD is a nonprofit mental health education and advocacy organization, and thank you for the opportunity to testify in support of House Bill 933. I just wanted to focus today on the tremendous benefit that 933 provides to children, youth, and families. Historically, families have called 911 or taken their child to the emergency department when they felt that their child was beginning to experience experiencing a mental health crisis. The worsening mental health of children over the last decade, and particularly in the wake of the COVID pandemic, has led to an explosion in hospital emergency department utilization, which has resulted in children and youth becoming stuck there. This has been widely reported in the news. Yet much of the time, in fact, probably at least about half of the time, when a family reaches out for help, their child does not need to be seen in an emergency department or hospitalized. Emergency department stays can be tremendously detrimental to a child's mental health, as can calling 911 and involving law enforcement, which sometimes actually results in a child being handcuffed, even younger children. Instead, by calling 988, families can access appropriate mental health assistance over the phone and, if needed, have a mobile crisis team dispatched to them. This is usually sufficient and far preferable for everyone. In addition, as has been said, children and youth themselves can call, or even better, text 988 to communicate with someone and potentially avert a crisis. Therefore, we urge a favorable report. Thank you.
Thank you. Yes, sir.
Thank you. Hello, everyone. My name is Carlos Mackel. I am the Behavioral Health Lead and Strategy Manager for Totally Linking Care in Maryland. Totally Linking Care is a nonprofit coalition of 6 hospitals connected to healthcare providers and programs with residents in Southern Maryland, Calvert County, Charles County, Prince George's County, and St. Mary's County. We believe that everyone deserves access to quality healthcare. This telecom fee will support sustainability for services that are vital for the state of Maryland. This bill is important for TLC for several reasons. TLC is leading the implementation of the crisis continuum in Prince George's County that includes 911, 988, mobile response, crisis stabilization, and outpatient services. In most cases, 988 will be the entry point, first point of contact for individuals who are experiencing a behavioral health crisis. A 988 call specialist will stabilize, refer, facilitate services being delivered to individuals in crisis, and connect them to the most appropriate levels of care. 988 helps to reduce costs for the state of Maryland by often diverting individuals in crisis from a higher level of care. 988 is the best practice for behavioral health crisis in the United States of America, and Maryland deserves the best. Therefore, Totally Linking Care in Maryland urges the House Health and Government Operations Committee to pass HB 933. Thank you.
Thank you. Who's next, please?
Good evening, Madam Chair and committee members. My name is Cheryl Maxwell. I'm the Resource and Referral Program Director, speaking on behalf of Andrea Brown, who is our Executive Director. She experienced a medical emergency this morning. Thank you for the opportunity to come before this august body in support of House Bill 933, Behavioral Health Crisis Response Services 988 Trust Fund. We have for more than 40 years provided culturally relevant approaches aiding the development and sustainment of mental health programs and services for African Americans and communities of color. Supporting this bill is very personal for us. Given the alarming increase in suicide rates among Black men and boys, the sustained funding of 988 is paramount to ensuring a lifeline for the minority community and generations yet unborn. We want to offer an important example. On or about Monday, February 5th, a call came into our Black Mental Health Alliance resource and referral specialist. The caller indicated he needed a therapist right away, that he needed to get to a hospital emergency room, but could not because he felt panicky and disoriented. It seems he had been driving, and we assume he was able to pull onto the emergency lane, though he was uncertain about his location and as to where he was. The specialist immediately suggested he call 988, where she was confident a mental health professional would answer his call and would be able to talk him down through use of calming techniques, which would decelerate his heart rate, lessen anxiety, and perhaps assist in reorienting him. The 988 Behavioral Health Hotline is a lifeline for those experiencing a mental health crisis. The Black Mental Health Alliance urges the House Health and Government Operations Committee to pass House Bill 933. Thank you for your attention to this urgent matter.
Thank you.
Hello, Chair and members of the committee. My name is Ashley Toller, Policy and Advocacy Associate with Maryland Coalition of Families. We are testifying today in support of House Bill 933, submitted as also our written testimony. Last year, we served 4,603 families, and nearly 70% were families with children. We have over 60 family peer support specialists across the state of Maryland, and 100% of them have referred families to 988. 988 is an essential life-saving resource that is available at your fingertips. With the changes in technology, youth have been utilizing the 988 text feature more. For example, a mom stated her son's life was saved last year when he was struggling with thoughts of suicide, and he texted 988 and was able to connect with a professional on the other end immediately. Another family has utilized 988 more than 8 times this month for help with her child who was experiencing a mental health crisis. This is an important system of support, and having permanent funding to ensure the service remains accessible for families and individuals in crisis is vital. We respectfully ask for a favorable report, and that is all. Thank you.
Thank you. Thank you very much. Peggy?
Thank you, Madam Chairman. Peggy Townsend on behalf of the Maryland Hospital Association in strong support of this bill. I think we're maybe at a game-changing point with regards to the mental health treatment we provide in this state. If you think about all the mobile crisis centers and stabilization centers that you all supported and bringing up online, the AOT bill that you passed out a couple of weeks ago, and then 988. Those are significant pieces that will work together. And what the result of that will be, people getting better care in a more timely manner, but it too will reduce ED overcrowding and wait times, and it will reduce the need for psychiatric beds, or at least the need for an increase. So for those reasons, we strongly support the bill.
Thank you. Thank you very much. I'll open it up for questions. I'm going to look at Delegate Woods.
I pretty promised I wasn't going to say a word, but I do have one quick question,
Sure.
and that is the fiscal note. Can somebody help me?
Somebody back there.
Well,
I think Adrian probably knows best.
Sure.
Oh, the fiscal note. Okay, yeah.
Yeah, the fiscal note.
So the fiscal note estimates that the fee will generate around $22 million annually,
Right.
which is what we anticipate will be needed to support the call centers with the existing call volume, anticipate for growth, but then also make those investments, in particular in Spanish speaking and text and chat.
Sure.
Follow up. Do you all have any other way around that fiscal note?
No. Delegate,
No.
Delegate, this is a good fiscal note. This means they're going to get the money to do the work by with that 25% per month.
Yeah,
Okay.
it'll
This is a
generate
good
22
note.
million.
Thank you for the generate. Okay, that's what I misread.
It's been a long day. It's been a long day. I get it.
Thank you so much. See, I was not going to ask anything.
Don't feel alone. Others had the same reaction. I know. Delegate Tavares.
Yeah. Parentheses bad. No parentheses good. Okay, thank you, Madam Chair. Just a quick question. So given hi, everybody. Thank you. And thank you to the kind delegate for putting this bill forward. I don't know if everyone is still here from the last panel. And I just want to give a shout out to Community Crisis Services for being our local service provider. Where can we go to provide to get the information on the breakdown of those 90% calls that have been responded to by language and by county? I'm not sure who would be the person.
Yeah, we need one person to decide who's best.
So I can do this. It is, so calls are not broken down by county, but they are broken down by one of the 8 call centers that takes the calls. So the state captures this data, MDH captures it. 988 is also part of a national system. So Vibrant Emotional Health collects that data. That's where we pulled the data from that you referenced, the 90% answer rate.
And allow me just a quick. So it's just, so where, and if I could get information of like where these call centers are located, like, sometimes I don't know, when I call in my area, I had a particular case that I had to deal with. I end up in DC, not necessarily in Prince George's, so it's a little bit of a runaround.
Yeah.
So just trying to figure that out in terms of where the calls fall.
Yeah, we'd be happy to send that with you. We can show you a map so you can see where the call centers are located throughout the state. Absolutely. We'll share it with the whole committee.
It's my understanding that with 988, once you call 988, it will route you to the call center nearest your area code.
Currently, this routing system routes you based on the area code that you call from.
Right.
They are moving towards geo routing, which is work that needs to happen at the federal level. I know our state has been urging that to happen, and we are grateful for that support. And I do believe it will be happening soon, is what we've been told.
Thank you. I hope so. Okay, seeing no further questions. Oh, I'm sorry, Delegate Shalega. Go ahead.
Thank you. You usually look left.
I do.
So just to clarify on the fiscal note, the 22 million is a fee that consumers are going to pay. So there is a fiscal note.
On consumers.
Yes. And then there is $117,400 fiscal note for the comptroller. Is that correct? 2 positions annually?
Yes.
Yeah, so there is, just to be clear, there is a fiscal note. So I was wondering, you know, we had 311 in here earlier this month. So we have 311, 988, and 211. Obviously, everybody knows what 911 is. How do you interact with 311 or 211? Not at all.
I can speak to 211. 988, so 988, the 8 of the 988 helplines are in lockstep with 211. They coordinate very closely. Some of the 988 centers also answer calls for 211. So there's that overlap and connection and service. For 311, I don't know that there's a direct connection. I'm not sure I could really speak to the vision for that.
I think when 311, which one do you interact with?
211.
Sorry, it's too many phone numbers.
It's a long day.
At 7 o'clock at night. Okay, so 211, would it be better to merge you with them? I mean, your opinion? Why do we have 3? I mean, I'm confused.
I think it's, Maryland was ahead of the game in creating 211 and having 211 press one, which has now sunset. Maryland realized very early before the feds did that we needed an easy to remember number. And then the feds came in and made 988. I think there's continued opportunity for the 2 lines to work together. Whether they should be merged is a great question. I don't know. I would want to look at that more deeply.
At some level, Delegate, they're directly connected because 211, as we were just told, does operate in the mental health space. And so 988 is using those facilities and that infrastructure to deliver the service that the federal government mandates. So, and 988 is a national number. So all across the country, you can do it. And the 211 infrastructure is part of what we use in Maryland to deliver those services. 311 is a governmental information center. So if you have a question about your local government, it's 311 that you're going to call. And I think the bill we've heard is whether or not 211 and 311 should merge. And let me be clear, 211, the services that 211 delivers go beyond mental health services. They also provide services around finding food, finding shelter, helping with finding resources to pay your electric bill. It's, 211 has been my bill over the years. Yes.
And this could be a conversation for subcommittee. What's the fee that people pay for 211?
There is no fee.
Who's paying for it?
The state gives them about $1 million a year, but most of it's a nonprofit. So they fundraise.
Maybe that's.
Oh, I'm sorry. 311 is Friday. Okay. So, does that help?
That helps.
Okay. Okay. Thank you. Any other questions for the panel? Thank you all very much. And thanks for sticking around and your patience. We really appreciate you being here. We have one virtual witness, Tessia Shi. Ms. Shi, we're gonna. Oh, no. are we there? She's there? Miss Shi, if you, here we go.
Okay.
There we are.
Hi, sorry, I couldn't hear anything for a minute. But good evening, Madam Chair and members of the committee. Thank you for the opportunity to speak today in favor of House Bill 933. My name is Tessia.
Can you get a little bit closer to your mic?
Yeah. Okay.
There we go.
All right. But my name is Tessia, and I'm a lifelong resident of Maryland, and I also went to college in state. And 988 helped me to really during a low point in my mental health in senior year of high school and freshman year of college. In those years, my mental health had deteriorated to the point where I was having thoughts of suicide frequently, but unfortunately, my support systems were not necessarily always available to help, especially during times like the middle of the day or past midnight. During one particularly tough moment, I looked up the online chat and number for 988, which at that point was still the 1-800-273-TALK number, and was subsequently connected with someone. We chatted for about an hour, and I really believe that having that empathetic human at the end of the line really helped me get through that moment. And then later on in college, I went to volunteer for the line in Montgomery County, hoping to support others in the way that I had felt supported. Many of the callers that I talked to felt like they had no one else in their life they could reach out to, or didn't know where to start seeking help. And the people who used the line ranged from elementary school students who were getting bullied at school to seniors who felt isolated during the pandemic. And through the line, I was able to connect them to either national or local resources, or simply provide a safe space for them to express what they were going through. In conclusion, I urge your support of House Bill 933 so that the 988 helpline resources can be accessible to everyone, and that anyone, no matter who they are, would be able to connect to a supportive ear in their time of need. Thank you.
Thank you very much, and thanks for your patience in waiting online for us. Are there any questions for this witness? Seeing none, thank you very much for your time and your testimony tonight. With that, it concludes the hearing on House Bill 933. And we will go to the last bill of the day. I've just called out to Delegate Rosenberg, and he's here. Okay. Indeed, indeed.
You made up for the.
There we go. Well, I now know that if someone is not here, they are not in judiciary. Just saying. Oh, but they could be in appropriations. And they could be in ENT. Oh.
I apologize for being, if I may say, late out of the gate. Because I was, with the chair's permission, I was on a Zoom, a community Zoom regarding my favorite racetrack.
Oh boy.
So.
Welcome.
But a close second are restitution funds. Because as this committee knows, because we created the opioid restitution fund. And prior to that, we have the tobacco restitution fund. The purpose here is, instead of the money from the legal settlements with the big tobacco first such suit, and then more recently with the opioid manufacturers and distributors, we have targeted that money, prioritized how it should be used, so that we address the problems resulting from the product that was the subject of the lawsuit. And if it's a successful lawsuit, there's money that comes to the state. And if we don't act, and in this instance, we did act in time, but now this legislation would refine the process by which decisions are made and prioritize how those decisions are made. So this gives us a chance to be like we're the Appropriations Committee. So in making decisions with this legislation. So that's the basics and would defer to other testimony.
Thank you, Delegate. Go ahead, please.
Good evening. I'm Dr. Nancy Rosencone. I'm the Executive Director of the National Council on Alcoholism and Drug Dependence. I thank you for your time and for your patience as well. The Attorney General just announced that there's another settlement with other organizations like Walgreens and Walmart. So there'll be an additional $285 million coming into the state. So what this bill does, and I want to thank Delegate Rosenberg. He, back in 2019, established the Opioid Restitution Fund. And then after that, he established the ORF Advisory Council, which is very important. I'm part of a group, what we call the Roadmap to National Settlement. So it's over 25 states that are reporting in. And I can tell you honestly, and we don't have this in Maryland, thank goodness, we're finding in some states that the money's being used to repair potholes, to pay back government debts, and to buy new police cruisers. So as I say, we don't have that in the state of Maryland, and we won't have that. What we're looking for in refining this particular legislation is the transparency. So in other words, all of the jurisdictions need to report in how they're spending their monies. And then we want to ask for them to also report into the Secretary of Health, the Maryland Department of Health. We're also asking in this legislation that there be a reasonable time frame in which the Secretary of Health reports back to the public and to the communities how the dollars are going to be spent. The ORF Advisory Council started meeting in November of 2022. In November of 2023, they came up with recommendations that were sent to the Secretary of Health. We have yet to hear.
Go ahead and finish. Go ahead and finish.
Okay, we have yet to hear how those dollars will be spent. So we're looking for a reasonable time frame in which the health department can report back to us or report back to the communities. Remember, these dollars were awarded from the pharmaceutical companies to help family members, to help people's lives that have been destroyed. Their last request is we're asking for 25% of these dollars to be spent on recovery support programs and recovery support services. Remember, we have funding sources for treatment programs. They can bill insurance, they can bill Medicaid. Recovery support services are small nonprofit organizations throughout the state that provide life-saving services. They provide case management, they provide transportation, harm reduction, and they don't have a particular funding source per se. There are some small grants that are available. But that's the reason we're asking for that, because the treatment programs have done a great job. But then after somebody leaves treatment, then where do they go? Do they have case managers? Do they have recovery support services? Do they have the transportation? Do they have the housing needs and the food insecurity? So this is what we're asking for in this legislation, right? Okay. Thank you.
Thank you.
You're welcome. Are there any questions? All right, thank you so much.
Thank you.
Thanks. Oh, wait a minute.
We'll work on it.
Oh, I did not see your light. Delegate, you have to push it up a little for me. Delegate Taveras, yes, go ahead.
In addition.
All right.
I haven't checked.
Okay, so I move it back down?
Yes, go ahead.
I don't know. All right, thank you, Madam Chair. Thank you for this proposal. I think that it's really important. I mean, my concern is how are we dealing with the fact that people who are addicted recidivate back to using or backslide 6-7 times? I mean, how do we?
I'm sorry, what was the question, ma'am?
So we're gonna be receiving several $1 million
Right,
from this pot for the next 10 years.
correct.
So my question is, and we're assuming that we're trying to use it statewide.
Yes, ma'am.
So the question that I have is, how are we addressing the fact that there are individuals that will backslide after getting out of rehab
Right,
at a
that's,
significant rate, given how addictive what we're talking about is?
yes, that's an absolutely terrific point. That's where the recovery support community, the community-based organizations come to play because they see a high rate of recidivism, but they can take individuals in and it's no cost to the patient, or I'm sorry, the client, it's no cost to them, and they're going to help provide life-saving measures. So that's why this money is important for these community-based organizations. Because as you say, they could come out of treatment and then they could relapse. And that's where the CBOs pick up the slack and make an easy transition, track them with their family members, track them in their communities, get them into a treatment program if they need another treatment program, or provide the life-saving services that these community-based organizations do. And that's why we're requesting monies, because they don't have necessarily a traditional funding source like Medicare, Medicaid, insurance. So does that answer your question, ma'am?
So that there's an equity lens
Yes.
placed on this, on how we spend the money. Is there some assurances? I just want to make sure that in the legislation, we have that
Yes,
included.
that's what we're requesting, the transparency of the reporting out. So each jurisdiction receives a pot of money. Then they have to report back as part of the settlement agreement. We're asking to add another layer to that these jurisdictions report into the Department of Health as to the utilization of their dollars. And so, yes, we are putting in a check and balance system for that, so there's no misuse of funds. Does that answer your question?
Okay.
Yeah.
Thank you.
That's it.
Delegate Riley.
Thank you, Madam Chair. So I guess for the sponsor of the bill, thank you for the bill. Appreciate it. And you sitting here all day. Thank you so much. We are listening. I had, as I was reading through the bill and some of the opposition letters, does the bill actually remove the entire grant application process for the entire fund for just the 25% or remaining? If you could
No,
explain
there's
that.
still the grant process.
Okay, so
That will
there's-
still be part of it. So let's say, and even the 25%, there will be a grant process. Once it's been announced as to where the dollars are going to be spent, the ORF Advisory Council provided recommendations, 8 different recommendations. Once the Secretary of Health decides, then there'll be an RFP process to apply for those dollars. So there still will be a grant process. There has to be.
Yes.
So that is all laid in the current bill? Or who's making those recommendations and requirements to?
I don't know offhand. I mean, I would think there will be within the next week or so discussions with the department about trying to reach a common ground on how we should be distributing this money. And I'd also suggest that we look at how money is distributed under the tobacco restitution fund to the extent that that model is appropriate. No doubt.
Yes. Yeah, that is my understanding.
Only one of us can answer.
Oh, sorry.
That's okay.
He answered. Sorry. Okay.
Sure, that's fine.
And thank you so much for adhering to the rules, and thank you very much for your questions, Delegate Bagnell.
Thank you, Madam Chair,
You're
and
welcome.
thank you for this bill. I think this is an elegant solution to a very previously clunky and sort of ambiguous process. There is opposition from MACO about concerns about an additional layer of requirements, but do you see this as a tool that will bring like greater accountability, greater clarity, and sort of streamline that process so we're not constantly checking to see what stands up to constitutional muster?
I'm sure we can work with Mako to get an appropriate resolution.
Right. Any other questions? Seeing none, thank you very much, Delegate,
you.
for your leadership. Thank you so much, ma'am, for being patient, and everyone else that is waiting. Thank you very much. So
Thank you.
next we have Tony Torsch, Robert Massa, Jennifer Turk, Cindy Amador, Tom Gallagher. If you can come up, please, as I call your name. We can have a seat, and will you be so kind and get started? And good afternoon, good evening now. Thank you for being patient, everyone. We appreciate it, okay? Next, please.
Good evening. Hi, I'm Tony Torsch. I'm the director of the Daniel Carl Torsch Foundation. And thank you. Thank you for being so patient with us. And Delegate Rosenberg, thank you so much. I'm also the mother of a son that I lost to an opioid overdose. I left my testimony in my car, so I made notes. I'm sorry. I'm going to try to
Just talk from your heart.
talk from my
From your heart. Talk from your heart, and I'm sorry for your loss. Just tell us why you support this, how you feel. Just talk from your heart.
Well, transparency, I think that's all something that we all want in our government is transparency. Of course, the 25% set aside. I do run a recovery based community organization, and there is no direct line of not a direct threat of funding for us. We do have small grant opportunities, but we're also pitted up in that same grant. We're pitted up against the Johns Hopkins of the state and the Shepherd Pratts. We're all vying for those same funds. So unless you have a great grant writer on your team, you know, it just depends on how that's going to work out. Maryland, and it's really, you really have to take the credit for this. You really have pushed us through with states that are looking at us to see how did Maryland do that so quickly. I say quickly over the last several years. We have detox beds. We have treatment on demand. We never had this. This definitely would have been a game changer, I think, for my son. But where we aren't doing so well is in recovery support. I think we can all remember the debacle of Optum last year. Remember that? And you know who paid really a high price for that? It was the recovery programs and our clients. That's who really paid a high price for that whole chaos. You know, we have, I think some of our trust was a little tainted by the previous administration for promises, some of the promises that weren't fulfilled. But we could get past that. Somebody said, you know, let's not go back. We'll go forward. And these funds are much like the tobacco funds. And we can only hope that they're not going to be mishandled, that we're going to trust in our health department, trust in our government. But I need you to remember where these funds came from. These funds came from deaths and the destruction of so many lives, you know, across our state. That's where these funds came from. And I just think that we owe it to families. I think we owe them that grace and decency to show them how much we are going to maybe honor of what happened or honor them in that way. So I just want to leave it that when you're going over this, when you're in your committees, say to yourself, if it was your sister, if it was your son, your daughter, how would you want those funds to be spent? Where is it really going to make the most? And the people in recovery, that's where we are going to have to do it. It's taking longer for them to gain stability, and it's costly. So with that, I'll end and I respectfully request a favorable vote. Thank you.
Tony, you didn't need your testimony. You did just fine.
Thank you.
And you're honoring your son, and I'm so sorry for your loss, okay?
Thank you.
We appreciate you. Next, please.
Well, this is my first time, so I need my testimony.
Okay, it's okay.
Good afternoon, but now evening, Madam Chairman and committee members. My name is Cindy Amadori, and I am here in support of this bill. On November 24th of 1997, I moved into sober supportive housing. Unfortunately, I had nothing or no one. I had a difficult time getting a job and I couldn't pay my rent. I almost got kicked out and I saw a lot of women return to the streets. Luckily, I got a job and they allowed me to stay and get caught up on my rent. If I would have received some sort of help, I would have been able to focus more on my recovery process rather than my survival skills. But 26 years later, as someone who was a counselor for 20 years and currently working in harm reduction, I continue to see the same struggles in others. I just want to say that we all deserve the right to recover. This funding could actually make a difference between someone returning to the streets of active addiction, homelessness, or even death, or continuing on to the path of recovery. Thank you.
Thank you. You did really well.
Thank you.
Yeah. I'm so glad you're doing well. And Thank you for what you're doing. Next, please.
Okay, good evening.
Good
Hi,
evening.
everybody. My name is Jennifer Turk and I'm a person in long-term recovery and the executive director of Voices of Hope, a recovery community organization or RCO that serves Cecil and Harford counties. I am asking you to be supportive of House Bill 980, and in doing so, you will be investing in recovery from opiate use disorder throughout Maryland. After crisis and treatment, recovery is what happens with us and our families in our communities. This bill invests directly into recovery from addiction. Recovery community organizations are nonprofit groups that have been formed by people in recovery, parents, and loved ones of those who have died from overdose and addiction. We fill the gaps in services in our local communities, especially rural communities. Services include distributing Narcan, providing treatment connection, assisting with recovery planning after treatment, providing recovery housing, increasing access to vocational training and employment, offering family reunification supports, and comforting the grieving after an overdose death. For example, in Cecil County, where we have no detox or inpatient treatment programs for those with Medicaid, we transport individuals to the closest location 45 minutes away or more when they are ready 24 hours a day, 7 days a week. RCOs work with health departments, justice systems, and local governments to address needs so people have access to treatment, but are also supported to overcome barriers to long-term recovery. Recovery supports our smart investment because it moves us away from the costly acute care models of only crisis and treatment, get out, crisis and treatment, get out, over and over again. This bill will provide restitution or setting things right for the opioid crisis caused in part by the pharmaceutical companies by funding directly into the local communities affected. We're just asking for a percentage of the total opioid restitution dollars. Please vote in favor of House Bill 980. Thank you.
And thank you. I'm so glad you're doing well. Thank you for being here. Next, please.
Good evening. I'd like to thank Madam Chair and the House Committee for allowing me to share my experience. My name is Robert Massa and I'm in my 10th year of recovery. My journey was started by the generosity of a nonprofit, making me the beneficiary of a scholarship that got me into treatment for the first time. Without that opportunity for a new start, I would have undoubtedly gone back to the same people, places, and things that I was used to and comfortable with. But instead, I was able to begin again in a new area in a large recovery population in Maryland, as is very important to my journey. During my second year of sobriety, I began searching for a way to pay the debt forward, and I started a very small nonprofit that ran off the kindness of our friends, family, and local charity events. In the 5 years that we were running, we were able to fund 183 men and women into homes all over the state. But the groups I'm here to support probably see that on a monthly basis. Then I began my own recovery residences, as that they have grown into 4 male houses. In my 7 years of running this business, 81% of the 647 residents I've had have had some form of support from a community-based nonprofit. That's got them started in housing, got them access to vital records, birth certificate, driver's license, things they need to get jobs, transportation to job interviews. I mean, without these services, guys would be lost, completely lost when they get out. They offer so much more, including access to food banks, application for medical insurance for people who don't know how, access to mental health services. And I feel like what this money does, it doesn't bring back the hundreds of thousands of people we lost to the opioid epidemic, but if you're going to accept the blood money, it should go to the people that are bleeding. Thank you.
And thank you for sharing your journey, and thank you for being here. And I'm so glad you're doing well as well. So I'm going to open it up for questions. This is what we do after people testify, and see if there are any questions for you, okay? Are there any questions, Delegate Bagnall?
I think any of you could answer this, but since I can only ask one person one answer, I'm going to ask Ms. Turk, because I think you could speak to this. One of the recurring themes we see with people in recovery is that giving back. So how would having direct dollars in the recovery community, how would you be able to leverage that with a return on the recovery community?
I mean, specifically for my group, I mean, like I said, almost 90% of the guys receive some sort of funding so that they don't start off in debt, right? They need to find a job. Most people are not returning to a job. So this gives them that little bit of breathing room really to kind of start on firm ground and not shaky ground to begin with. Like my whole life was shaky up until I got a stability that the recovery community gave to me. There's so many things to worry about when you have nothing. And for these men and women, I mean, 1 month of funding could be the difference between, going back to jail or prison or, being a productive member of society.
Delegate Taveras.
Thank you. Thank you, Madam Chair. I'm asking this respectfully, and I'm just curious, frankly, for those who have been in the life, can you kind of, I don't know, because I know only one of you can respond. If there's a way for y'all to let me know, like how many of you, either by hand raise, how many of you have done time in jail? Thank you.
Okay. So, and I should have said you don't have to answer. You didn't have to answer that question, okay? At all. And I apologize, I didn't say that before you answer. It's just that it's I know you want to know, but it's not appropriate. And I apologize on behalf of the committee, okay? That being said, I don't see any other questions. I do want to say thank you for coming, for using your voice and your journey to make a difference, because it is impactful as policymakers, right? To be able to relate and to use your experience to make a change. There's one of my favorite saying in life, it's a Buddhist saying that says that you don't die when you're cremated or when you're buried. Think about that. You die when the last deed you have performed on earth is forgotten. So you using your journey will help others. And I thank you on behalf of the committee. I hope you have a blessed evening. Thank you for being here.
Thank you.
And for being patient. So we have next, I'm going to call a favorable with amendment, just to be fair and to be balanced. And that will be the amazing Marie Grant from the Maryland Department of Health, who has been here all day with us. And again, thank you for working with our committee. Okay.
So thank you very much, Madam Chair, for that super kind introduction, Vice Chair, committee members. The Department of Health is here today in support with amendments. And first of all, Delegate Rosenberg and his team have been wonderful to work with, and we've been in discussion with them about a couple of changes. I think as you've heard previously, there are two components to this bill, or I see it in sort of two parts. The first part is transparency. The second part is making sure that recovery services are a part of the fund. On the transparency piece, I think the department is committed to transparency about where these dollars are being funded. It is critical for all the reasons that you've heard and folks that testified before me. There's a timeline in the bill of 2 months after the opioid restitution fund advisory council makes its recommendations. And I think that's the language we are working with the sponsor on. I will say, first of all, I know the council has made its recommendations. They made categories of funding. The Secretary of Health has, really taking this incredibly seriously and doing a needs assessment and making sure that we can appropriately cadence the rollout of these dollars to the areas with greatest need and that will have the most impact. And so that's why it's taking a little longer time. Perhaps it will take less time in future years, but we would like to not be boxed in. And so we're talking to the sponsor about that. The second piece is the addition of recovery services as a type of services that can receive funding. Through the ORF. We are definitely supportive of that. I think there may be an amendment to define that recovery services, which we are also supportive. The 25% allocation, I think, is what we would like to not be boxed into, just given, again, that needs assessment, the settlement agreements themselves, which are very complex. And I think, as you heard, there's a new settlement today, which will have its own set of agreements and complexities that we need to work through as a department and state. So, but very supportive, again, of the transparency and adding these services to services that can receive funds from the fund. So that's why we're here in support with amendments. Thank you.
So just so that I'm clear.
Yeah.
These services, these organizations like these will be in the mix.
That's right.
To be
That's right.
considered, right?
That's right. Yep.
Because they have a point. It's so tough if you're not one of the big institutions, to be able to compete as well. And they do the brunt of the work with the real people. So thank you for being at the table. Are there any questions? Delegate Rosenberg, followed by Vice Chair Collison.
Do you know, thank you, Madam Chair. Do you know if the new settlement would require any changes to the statute? And our schedule, the timeframe we're working under. There is no cross-file.
Yeah.
But do you know that yet, or could you let us know within a week?
We will definitely let you know within a week. I will say, Delegate Rosenberg, I just learned about it just prior to this bill hearing. So.
If I may.
Sure.
Is the 258 million, if I got the number correctly, is that the lump sum over a period of years that we'll be getting? Do you know that answer? If not, I understand.
It's okay. In the phone a friend answer from the crowd, I believe it is a lump sum, but we'll confirm that with you. Believe it is a lump sum, but we'll confirm that with you.
Okay.
Okay, thank you. Vice Chair Collison.
Thank you, Madam Chair.
You're welcome.
And thank you for supporting and working with us on the bill. I heard you say you didn't want to be boxed into the 25%. Do you have a thought about how, and that the way you wanted to approach it was through a needs-based kind of process? Do you have a notion of in a couple of sentences how that might work?
Yeah, absolutely, Delegate Collison. So under current law, and then also under the current settlement agreements, the opioid, the advisory council is charged with taking a look at the needs of the state and making recommendations to the secretary. And a needs assessment is really envisioned as part of that. The report from the advisory council made recommendations on categories And the secretary is taking that and bumping it against a needs assessment that we've been conducting that you may have heard about as part of our behavioral health advisory committee work, to again, really make sure that we're getting these dollars out in the areas of greatest need. I think the other concern about the 25%, Vice Chair Cullison, is also just again about the complexities of these settlements agreements, right? We absolutely agree these services are vital. They are part of our behavioral health continuum of care vision. They're going to be important to be in the mix. It's just that percentage and outlining that in statute at this juncture, as we've just heard today, things are changing around us. I think that's what we have a little concern about at this point.
Thank you. Any other questions? Seeing none, Marie, thank you. And thank you for waiting, okay?
Oh, thank you.
We're really grateful to you. I'm going to go back to favorable. Actually, to be fair, I have been unfavorable. Sarah Sample? Sarah, I don't know. You don't want to contemplate your testimony?
All right, thank you to the chair. Thank you to the members of the committee for having me today. My name is Sarah Sample. I'm here on behalf of the Maryland Association of Counties, and we are here in opposition to this bill. What I would start by saying is that there is certainly an urgency needed when it comes to remediating the effects of the opioid crisis. There's also on the ground an extensive amount of collaboration and coordination that happens amongst our local agencies. And then there's also collaboration and coordination that has to happen directly with the state. So it is a really big lift, and it's something we're taking very seriously, but it requires a lot of urgency. And I think when it comes to the reporting and the accountability, we think that that absolutely has to be there. There's no question about it. And I would also add that the transparency should be there as well. But we think that the current requirements are sufficient to allow for the urgency and also the reporting and the transparency. Just to give a little bit of background on it, we've got the National Settlement Agreement that governs some of this. You've got the state subdivision agreement. You have the local abatement plans that we're required to submit. We've also got the request for proposals. When it comes to those applications that we have to submit, they're incredibly extensive. And if we were granted any money from those other pots of funding, the reporting that comes with that is also extensive. And then the last thing I would add to that is that in the Section 6 of the settlement agreement, we have to be audited every year by the state, and it's for every dollar that we receive, not just grant funds, but also things that we've been allocated directly from the settlement agreement, but also disbursements that might come from the state's separate set of funding that's discretionary. So that's just sort of giving you a little bit of insight on what already exists. We fear that having more layers added to this could put us in a situation where we're doing more reporting than actual remediation work. And that's just a concern that we have. And then the last thing I would say about the allocated funding, we don't think it's appropriate to have a set of funding allocated to one particular group. It is a competitive grant fund. And so an earmark or sort of a prioritized section of funding it's not in the spirit of why the fund is competitive. And we think that their applications and proposals should have to be considered and vetted against all the other quality proposals that are coming in. So for those reasons, we are in opposition to the bill. Thank you.
You're welcome. Are there any questions for Sarah? Seeing none, thank you. And I want to thank you for being patient as well and for waiting,
Absolutely.
okay?
Yeah,
we
thank you.
appreciate you. We do have, I want to call them all at the same time. Tom Gallagher, Rachel Penderson, Lisa Lowe. And can you bring the two last witnesses that are favorable that are virtual up, and then we're done? Is there someone here that did not get called? I don't want to miss anyone. All right. And thank you again for waiting, okay? So who would like to get started?
Okay, Lisa Lowe, Face Addiction, Maryland. I'm here today with cautionary support for the idea of the bill and the promise that it potentially holds out for community-based recovery organizations. But if I went around the room and asked each of you what is a community-based recovery organization, I'm not sure that any of you guys would know. So I'm going to tell you what my concept is. A community-based recovery organizations is an Addiction Connections resource in Harford County, where Linda Williams founded the first safe station in Maryland with no money inside her home in 2000, a full 17 years before Anne Arundel safe stations would be funded with a grant in 2017. Or it's Heroin Action Coalition of Montgomery County, where myself and my affiliates, we navigated over 200 Marylanders into some level of treatment with no funding source whatsoever every year. A full 6 years before Montgomery County funded their STEER program that cost nearly $240,000 to navigate between 44 and 101 people per year into treatment between 2017 and 19. Or it's any one of the 6 nonprofits that formed a network throughout Maryland back in 2014. And we assisted close to 1,400 families via in-person and telephone support, providing education and support for families impacted by opioid addiction and other SUDs. The same year that Maryland Coalition of Families for Children's Mental Health was handed $350,000 without an RFP or any bid process to pilot a program to do the same thing for 100 families that year. I like about,
You can finish.
okay, about a dozen other community-based recovery organizations throughout Maryland have had our programs replicated by our local jurisdictions, but rarely funded by our local jurisdictions. I currently have a website and a publication, copyright 2019, summarizing the conclusions of more than 650 valid research sources on treatment for opioid addiction, including data on alternative therapies like Kratom, ibogaine, cannabis, ketamine, amino acid therapy, transcranial magnetic stimulation, which Johns Hopkins is doing research on most of this. And last year, I contacted scientists and researchers from across the nation who agreed to fly to Maryland at their own expense to present their research on these alternative therapies at a conference center in Western Maryland that agreed to hold space and rooms without a deposit until 2 weeks prior to the conference. An unheard of deal, I was told. But in the end, I couldn't find anyone willing to work pro bono to create the electronic promotion and registration pages and was forced to table the project. So if you're really planning on funding community-based recovery organizations, which I hope you are, then I hope you'll work with us over the next few days to add amendments to ensure that these organizations are able to access these funds. Because like we've pointed out, we're competing with, people who are a lot bigger than us. And instead of funding good programs founded and operated by peers to save lives, we allow business operators to chase funding opportunities once the money's available.
Thank you. Next,
I
please.
urge a favorable response.
Thank you. Next, please.
Good evening, Madam Chair and members of the committee. My name is Rachel Pedersen. I am a person in recovery since 1997, and I am also the Harford County Program Supervisor for Voices of Hope. Our mission is to empower lives and foster recovery. Our peer-run nonprofit is dedicated to supporting individuals and families facing substance use disorder, which is why I am here testifying in support of House Bill 980, which will require that a minimum of 25% of the opioid restitution fund dollars go directly into the community. Voices of Hope and community-based recovery organizations support individuals through sustained, no-cost services such as peer treatment coordination, family support activities, recovery support meetings, outreach and community engagement, transportation to and from treatment and other resources. And we help rebuild lives by getting birth certificates, state IDs, insurance, providing wound care, and many other life-saving services. House Bill 980 will ensure that the funds go to support organizations working to fill the gaps in the continuum of care for individuals struggling with substance use disorder. This is where the financial need is the greatest, and the frontline services meet people with the highest risk of substance use, overdose, and death. I urge you to return a favorable report on HB 980. Thank you, Madam Chair.
And thank you for being here and for sharing your journey with us. And I'm so glad you're doing well.
Thank you.
Thank you so much. Are there any questions? Seeing none, thank you so much. So we do have two people virtually. Would one of you please just mute yourself? And you can get started, unless you want me to call on someone. About Bell, last name Bell? Thank you.
First name Bell. Good evening.
Is it a
Madam
first name?
Chair
Okay.
And committee. My name is Bell Leonard, and I am present and request a favorable vote for House Bill 980. I'm a person in long-term recovery. That means since 1992, I have not had a drink or drug or any mind or mood-altering chemicals. I used substances for approximately 22 years in Baltimore City. Almost everyone gave up on me. My journey to recovery has been challenging. However, today, I am a solid member of my community. I am the founder and CEO of the Light of Truth Center, a recovery residence for women who are seeking recovery. I am a recovery coach professional, a registered peer supervisor, and a registered voter. Recovery is not merely an abstract concept. It is a tangible reality within the reach of all who dare to believe in its possibility. We do recover. Recovery is possible. It is a journey of self-discovery, of healing old wounds, and forging new beginnings. The recovery community is in need of financial support in order to provide recovery services, including recovery residences, wellness centers, peer support, and a host of other supportive services. Recovery organizations are holding the line. Many organizations are filling the gap for services that are not currently funded. Recovery residences, for example, are the bridge from treatment to the community, providing the pathway to recovery, transition, and restoration. The recovery community is providing training to peers, developing programs and workshops, and building recovery-oriented systems of care and support industries in so many ways. Therefore, I ask that you support House Bill 980 so that together we can embrace the transformative power of recovery. Let us celebrate the courage and strength of those who walk this path, and let us stand together as allies and advocates. I humbly ask for a favorable vote for House Bill 980.
Thank you for sharing your story, and that's so impressive. We really appreciate you sharing your journey with us. Glad you're doing well. Thank you for being with us.
Thank you.
You're welcome.
Thank you.
Mr. Nicholson. You are
Good
it.
evening. Good
For
evening.
the last one.
Can you hear me?
Yes, we can hear you clearly. How are you?
I'm good. I'm good. Good evening, Chair and committee members. My name is Sean Nicholson, and I am a person in long-term recovery from substance use disorder. And I also am the founder of Solid Ground Recovery, which houses about 165 residents in 12 MCOR certified homes here in Frederick, Maryland. And I'm also a founding board member for the Phoenix Foundation of Maryland, which is the only organization to exist in the state of Maryland that operates a recovery high school, which is the Phoenix Academy. And I have my own journey into recovery. Since a teenager, I was making bad decisions at an early age that led me down a path of destruction. At 20 years old, I broke my legs. I was on Oxycontins and fentanyl patches and substances that led me down a path of pain, misery, and shame for 12 years. Fortunately, I had a family that never stopped loving me. the process of change and the process of recovery ultimately helped me heal and find purpose. Establishing Phoenix Recovery Academy 6 years ago was given me an opportunity to find an outlet, a rewarding, meaningful opportunity to make a difference in the lives of others and help some of these children, these kids, not go through the life that I had went through, and to teach some of these parents, give them the tools to deal with their deal with their students, deal with their kids as they were going through their struggles and their journeys. And just quickly, I'll say that 9 out of 10 people who suffer from substance use disorder started in their adolescence. And those that attend and graduate recovery high schools are 4 times more likely to stay sober 1 year after graduation, and 5 times less likely to be on parole or probation. So I support and ask for a favorable vote for HB 980. Thank you.
And thank you, Sean, for sharing your story. And I'm so glad that you're here and that you're doing well. Okay. Thank you for using your life to make a difference, all of you. I'm going to open it up for questions now. Are there any questions from the committee? Seeing none, I want to thank you for hanging in there with us and for being patient and for your contributions today. I hope you have a blessed day. I had 2 witnesses, Mr. Tom Gallagher, he's not here. He had to leave. And how about Rachel Penderson? Oh, you testify already. I got everyone. Well, thank you, everyone, for being with us. You have a blessed evening, okay? Take care. You're welcome. Bye-bye. Bye. Get some rest. You can take us down.